Now the MCQ that will go toward is, we will do the MCQ of embryology and anatomy of hair. Now without delay, let's begin. The pinna develops from, talking about the development of pinna, it has got tragus, right? Tragus, which develops from what? First branchial arc, right? First branchial arc, and remaining structure developed from what? Second branchial arc, right? Or the whole pinna is developed from hillocks of his, right? Now, so the right answer is first and second pharyngeal arc, right? Now here, true regarding the marked below structure is, now what is this? This is, right? Okay, what is this? This is preauricular sinus, right? Preauricular sinus that will be formed because of failure of fusion of first brachial arc and second brachial arc, right? Now this is seen between what? It is seen between, this is tragus, right? And it is ascending hallux. Now it is seen between hallux and ascending what? Ascending limb of hallux, right? Now this tragus, it is formed by what? First brachial arc. This hallux, it is formed from second brachial arc. So here this preauricular sinus, it is formed because of improper fusion of first and second brachial arc, or improper fusion of auricular tubercle, right? Improper fusion of auricular tubercle. Now moving further, external auditory canal is formed by, now external auditory canal, right? External auditory EAC is formed from what? It is, EAC is formed from cleft, right? Brachial cleft, right? Brachial cleft. Now if you remember, right, the development, right, here these are a cleft, right? Now these are cleft, right? These are cleft. Now these are developed from brachial cleft, or which is also called groove, right? Now from which they develop from first brachial groove or cleft. Now call auricle fistula, right? Call auricle fistula, it is what? It is first brachial cleft anomaly, right? First brachial cleft anomaly. Now a newborn presents with bilateral microtia and external auditory canal atresia, right? Correct surgery is usually performed at what? It is usually performed what? At 5 to 7 years of age, right? It is done at what? Correct surgery is done at 5 to 7 years of age. Now Eustachian tube developed from, Eustachian tube, right? Now Eustachian tube, it is developed from what? It is developed from pharyngeal pouch, right? Now which pharyngeal pouch? First pharyngeal pouch and second pharyngeal pouch, right? Now first pharyngeal pouch and second pharyngeal pouch. So the answer is B and C. Eustachian tube, right, develops from first and second what? Pharyngeal pouch, right? Okay, now talking about what? Talking about other pharyngeal pouch, right? As I have said, first and second pharyngeal pouch, right? Pharyngeal pouch, what they form? They form Eustachian tube, right? Eustachian tube. Along with Eustachian tube, it also formed tympanic cavity and mastodentrum. Similarly, second pharyngeal pouch, right? Second pharyngeal pouch, it formed tonsil, T4 tonsil, right? And third pharyngeal pouch, it forms inferior parathyroid, right, and thymus, right? It will cause inferior parathyroid and thymus. Similarly, fourth pharyngeal pouch, it forms superior parathyroid, right, and some part of thyroid also, right? Okay, the proximal part of tubotympanic recess lead to the formation of, right, the proximal part of tubotympanic recess lead to the formation of what? Pharyngotympanic tube, right? Pharyngotympanic tube. Okay, moving further, right? Moving further, we have the following structure represent all three components of embryonic disc. Now we know tympanic membrane is what? Trigeminal, right? Trigeminal, right? Okay, it is formed from all germinal layers. Now steps developed from what? Steps, talking about malleus, incus, and steps. Malleus and incus, they develop from what? They develop from first arc, right? But whereas steps develops from second arc, right? Steps develop from second arc. Now true regarding development of ear is, right? Now Eustachian tube develops from first cleft. Eustachian tube, it develops from what? It develops from pouch, not cleft, right? Eustachian tube open behind the level of inferior turbinate. Yes, it is correct, right? It is correct. Pinna developed from first pouch. Pinna, okay, pinna developed from first pouch. Is it correct? No, because pinna developed from first and second branchial arc. Growth of organ of corti is completed by 5th month. Yes, so in Mahabharata there is tale, right? In 5th month also what? The hearing is possible, because there is development of what? Growth of organ of corti, and ossicles are adult size at birth. Yes, this is also true. So the right answer is B, D, and E. Now conor septum is what? It is what? Conor septum is, what is conor septums? petrosquamous suture, right? Petrosquamous suture. Now all of the following are of the size of adult at birth, except now which is not of adult size at the birth, right? We have already said ossicles. What ossicles are of adult size, right? Tympanic membrane are of adult size, tympanic cavity are of adult size, but mastoid is not of adult size, right? Some of the changes is what to be there, right? So mastoid is incompletely developed, right? Develop at birth and continue to develop till 18 years of age, right? Now here the largest ear cell of mastoid are called mastoid antrum and is present at birth and is of adult configuration, but that is of adult configuration. Now moving so, okay, moving toward question number 13. Which of the following attains adult size before the birth? Yes, ear ossicles, right? We already said. And tympanic membrane, middle ear and inner ear structure are fully developed and of adult size at birth, right? Orbital structure continue to grow after birth also, right? Okay, which of the following attains adult size before birth? Same question, ear ossicles, right? Okay, now talking about the inner ear is present in which bone, right? Inner ear is present in which bone? It is present in petrous part of temporal bone. Yes, we are clear about it. Now question number 16. The inner bony labyrinth is, what is the inner bony labyrinth? The inner bony labyrinth is the cartilaginous bone, right? It is what? Inner bony labyrinth is cartilaginous bone. The cartilaginous bone ossify from a cartilage model, that is endochondral bone formation. Example, bony labyrinth, also called otic capsule. In contrast to cartilaginous bone, membranous bone, also called a dermal bone, does not form from cartilage that then calcifies, right? So here the inner ear bony labyrinth is cartilaginous bone, right? Moving further, which of the following is not pneumatic bone? And which of the following is not pneumatic bone? Okay, out of these, the malleus is not pneumatic bone, right? Mastoid, ethmoid and sphenoid, these are what? Pneumatic bone, right? Now this malleus, it does not contain what? Ear field cavity within them, right? To make them lighter. That's why ethmoid, mastoid and sphenoid, these are also what? These also what? They contain ear field cavity, so there are also sinuses of it, right? Okay, now moving further, the crus commune, right, is a part of the crus commune is a part of, right? You can remember like this, it is a part of semicircular canal, right? Crus commune is a part of semicircular canal. The posterior and superior semicircular canal fuse together to form what? To form common crus called as what? Crus commune, which opens into utricle. Because of these the three semicircular canal open into utricle by 5 opening instead of 6, right? Okay, so crus commune is what? It is the common point of opening of two semicircular canal, that is posterior and superior circular canal, that will open into utricles. Okay, now moving further, endolymphatic duct connect which structure? Talking about endolymphatic duct, right? It connects which structure? Now this endolymphatic, it will connect utriculosaccular duct to endolymphatic what? Sac, right? Utriculosaccular duct, right? Endolymphatic duct connects utriculosaccular duct to endolymphatic sac, right? Okay, now moving further, now non included in bony labyrinth, which is not included in bony labyrinth. Now organ of Coti is a part of membranous labyrinth, so organ of Coti is not included in bony labyrinth, right? It is what? It is a part of membranous labyrinth. Now bony cochlea is coiled tube making how many turn around the bony pyramid, right? And it is called what, right? The bony cochlea is coiled tube making how many turn, right? It will make 3 by 4, right? It will make this much turn. Now what is this called? This is and around the bony pyramid, and that is called modulus, right? The bony cochlea is coiled tube making 3 by 4, right? 2, 3, 4 around a bony pyramid called modulus, right? Modulus. Now the organ of Coti is situated where? It is situated in scala media, right? In scala media. Fetus start hearing by what time in uterine life? That is how many? At around what? Fetus start hearing at around 20 weeks, right? At around 20 weeks, that is right around 5 months, right? Around 5 months, and we know the organ of Kotai develops at around 5 months, right? Now, sense organ for hearing. What is the sense organ of for hearing? We know the organ of Kotai, right? The semicircular canal are situated by they are stimulated by what? Rotation. Semicircular canal are they are what? Stimulated by rotation, right? Semicircular canals contain cristae which sense angular and rotational acceleration, right? Gravitational movement, head tilt, and linear acceleration are sensed by maculae, right? In the utricle encephalitis, sound is sensed by organ of Kotai, right? Sound is sensed by organ of Kotai, right? Gravitational movement, head tilt, and linear acceleration are sensed by maculae in utricle encephalitis, right? Okay. Now we know that rotation semicircular canal are stimulated by rotation. Now moving further, horizontal semicircular canal respond to, right? Horizontal semicircular canal respond to what? It responds to rotational acceleration, right? It responds to rotational acceleration. The horizontal or lateral semicircular canal along with posterior and superior semicircular canal contain cristae which sense angular or rotational acceleration, right? Which senses angular or rotational acceleration. The angular movement are sensed by these are sensed by what? Semicircular canal. The same thing, semicircular canal. Now steps foot plate covers. Now steps covers what? They cover oval window, right? They cover oval window. Now oval window is covered by foot plate of what? Steps, right? The round window is covered by what? It is covered by secondary tympanic membrane, right? The part of middle ear medial to descending part of facial knob is called sinus tympani, right? The part of middle ear medial to descending part of facial knob is called sinus tympani, right? Talking about pyramid, what is pyramid? Pyramid is projection on posterior wall from which originates the stapedius muscle, right? From this pyramid, stapedius muscle originates. Now moving further, the movement of steps cause vibration in. It will cause vibration where? It will cause vibration in scala what? Scala vestibuli, right? Vestibuli, because the stroke it is like this, right? Now here there is what? Oval window, here it is round window, the steps are right here. This is what? Scala vestibule, buli, scala media, scala tympani, right? Now here, because of vibration of steps, it causes what? Movement of steps cause vibration in scala vestibuli, right? Now moving further, where is electrode kept in cochlear implant, right? In cochlear implant, where is electrode kept? It is kept in scala tympani, right? The electrode of cochlear implant are placed into scala tympani by passing through a round window, right? Okay. The microwick and microcatheter sustained release device are used in, where they are used in? They are used in delivering drug to round window membrane, right? The microwick and microcatheter, they are used to sustain release device and are used for delivering drug to round window membrane, right? Now moving further, perilimb content, right? Now perilimb and endolimb. Now endolimb is what? Similar to intracellular fluid, right? Intracellular fluid is rich in potassium. Similarly, perilimb is what? Similar to extracellular fluid, that is rich in what? That is rich in sodium, right? So perilimb is fluid which fills the bony labyrinth, and it is what? It is rich in sodium, right? Perilimb is actually extension of CSF which enters from subarachnoid space into scala tympani through cochlear aqueduct, right? Now site where endolimb is seen. Now the site where endolimb is seen, that is scala media, right? Okay, the fluid which has highest potassium and low sodium content is, as I have already mentioned, high potassium, that is intracellular fluid, that is endolimb, right? Similar to endolimb, right? Now talking about cochlear aqueduct, right? It connects what? It connects our internal ear with subarachnoid space, right? It connects internal ear with subarachnoid space, right? Not endolymphatic sac to subarachnoid space. It connects what? Internal ear with subarachnoid space, right? The internal ear communicates with cranium through two openings, that is one cochlear aqueduct, right? Another is internal acoustic meatus, right? Okay, now moving further, the most potential route for transmission of inner ear infection leading to meningitis is through what? Through, obviously we have said, the communicating medium, that is cochlear aqueduct, right? Cochlear aqueduct. The infection of CNS is spread in inner ear through, it will spread to inner ear through, same question, cochlear aqueduct. The commonest genetic defect in inner ear causing deafness is, what is the commonest genetic defect of inner ear causing deafness? And it is SAVE dysplasia, right? It is SAVE dysplasia, right? Okay, the commonest genetic defect of inner ear causing deafness. The screen over pinna is, what is over pinna is, it is what it is, where it is loose and where it is firm, right? Loose on, it is loose on medial side, right? It is loose on medial side. Now talking about the length of axonal auditory canal is, it is about 24, right? It is about 24 mm, and 36 mm is what? Eustachian tube, the length of Eustachian tube. Now moving further to question number 41, the cartilaginous part of external auditory canal is, right? The cartilaginous part of external auditory canal is what? It is lateral 1/3, right? It is lateral 1/3, right? Ceruminous gland present in ear are, what are ceruminous gland? These are modified which gland? These are modified apocrine gland, right? These are modified apocrine gland, right? Ceruminous gland are modified sudoriferous gland or sweat gland, right? Sudoriferous gland or sweat gland located subcutaneously in external auditory canal. These are apocrine glands, such that while discharging the secretion, their cells apical part are set off, right? Okay, their apical part of gland are set off. Now, dehiscence in external auditory canal cause infection in parotid gland via, right? Dehiscence of external auditory canal cause infection in parotid gland via, it will cause via our through fissure of Santorni, right? Through fissure of Santorni. Now here, the notch of Ravenous, right? The notch of Ravenous is what? Upper attachment of pars flaccida, right? And talking about pterygotympanic fissure, right, is present on anterior wall of middle ear, and on which there is the attachment of anterior malleolar ligament, right? And talking about retropharyngeal fissure, it is fissure, it does not exist, right? Okay, now what is the color of normal tympanic membrane? It is pearly gray, right? It is pearly gray. And in the case of glue ear or SOM, right, in the case of glue ear or cerosotitis media, right, at that time we can see blue tympanic membrane, right? Similarly, at the case of acute suppurative otitis media, we can see red or congested what tympanic membrane. And similarly, where in active otosclerosis, we can see pink color of tympanic membrane. So we are clear, pearly gray is normal, blue is in cerosotitis media, pink is in active otosclerosis, and red is seen as in acute suppurative otitis media. And moving further, pars flaccida of tympanic membrane is also called, what it is called? It is called Sharpnell's membrane, right? It is called what? Sharpnell membrane. Now the talking about this point, right? Now the Reissner membrane, what is Reissner membrane? It separates scala media from scala vestibuli, right, in inner ear. And basilar membrane, what is basilar membrane? Basilar membrane separate scala media or cochlear duct from scala tympani, right, in inner ear. And secondary tympanic membrane, we know it overlies the round window in middle ear. That's all. The most mobile part of tympanic membrane is, right, the most mobile part is peripheral, right, peripheral, and in the center it is not mobile. There is the what? Umbo, we can see the handle of umbo there. Now surface area of tympanic membrane is, okay, total surface area is 90 millimeter square, whereas the effective vibratory area of tympanic membrane is only 55 millimeter square. That's important. These 2 points, these 2 questions, these are important. Which knob supply the tragus, right? Now talking about the knob supply of tragus, right, it is supplied by our what? Auriculotemporal nerve, right? It is supplied by auriculotemporal nerve. Now okay, it is supplied by auriculotemporal nerve. Now talking about the knob supply, right, talking about the knob supply, okay, of tympanic membrane, right, okay, of tragus. Let's talk about the knob supply of our pinna. right? Talking about the knob supply of pinna, okay, talking what lateral surface, right? Talking about lateral surface of pinna, right? Lateral surface of pinna, tragus is supplied by what? Tragus is supplied by what? Auriculotemporal nerve. We said it, right? Now this auriculotemporal nerve is what? It is what? It is branch of what? V3, right? Fifth cranial nerve, right? Branch of V3. Now other, right? Other structure. The other structure, tragus, we talked about tragus. Now talking about superior posterior, right? The superior posterior part of, okay, let us suppose what is this? This is our pinna, right? Okay, I'm not good at making it, but this is our pinna, this is what, this is our helix, right? This is our lobe, right? Now here tragus, we said that it is supplied by what? Auriculotemporal nerve, which is what? The third branch of fifth cranial nerve, right? Now talking about the superior, right, the posterior superior region, it is supplied by what? It is supplied by what? It is supplied by our what? Auriculotemporal nerve only, right? Here the structure is like this, right? It is the tragus, along with the tragus this, right? These everything. Now tragus, now this anterior superior structure, all are supplied by our what? Our auriculotemporal nerve, right? Now remaining, now here the major main, right? The main one, the main this main region is supplied by what? It is supplied by the main region, this a large area, it is supplied by what? It is supplied by greater auricular nerve, right? That is C2 and C3, and the middle one portion here, the middle one portion is supplied by what? Cranial number 7 and 10, right? Cranial number 7 and 10. Okay, and this is what? This is about the lateral aspect, right? Lateral surface of pinna. Now we're talking about the medial aspect, right? Right, we're talking about the medial aspect, right? Talking about the medial aspect. Now let's say this is the medial aspect, right? Now here it is the what? Lobule. Now here this side, it is supplied by what? The same cranial number 7 and 10, right? 10. Now here here the majority of portion here, this majority portion here, this is supplied by what? Greater auricular nerve, right? Now greater auricular nerve, now which is C2 and C3, C2 C3. Now here superior part, right? This superior part, right? Small superior part, it is supplied by lesser occipital nerve, right? Lesser occipital nerve. Now in lateral, we said that the anterior superior part was supplied by auriculotemporal nerve, but here the what? Anterior superior part is, small part is supplied by what? Lesser occipital nerve, right? But here the major part is supplied by greater auricular nerve, and here this inner structure is supplied by what? Cranial number 7 and 10, right? Okay, these are the nerve supply of what? The pinna. Now nerve supply of tragus, what is the nerve supply of tragus? It is what? Auriculotemporal nerve, which is a branch of what? Which is a branch of our what? Fifth cranial nerve, right? Now moving further, nerve supply for external ear are all except, right? Greater occipital nerve, yes, it was supplying greater occipital nerve, right? Greater occipital nerve was supplying, or greater auricular nerve was supplying? Greater auricular nerve was supplying, not occipital nerve, right? Okay, now auriculotemporal nerve, it was supplying. Lesser occipital nerve, yes, it was supplying the medial aspect, the small superior part of medial aspect, lesser occipital nerve. So the wrong answer is what? This, right? So the answer is this. It will not supply what? The pinna, right? Okay, now Arnold nerve is a branch of, it is a Arnold nerve is a branch of vagus nerve, right? It is a branch of vagus nerve. Now moving further, the major part of skin of pinna is supplied by, major part of skin of pinna, we have already said greater auricular nerve, right? Greater auricular nerve. All of the following nerve supplies auricle and external auditory canal except. Now we know about what? Auricle, right? We know about pinna, we know about auricle, the nerve supply of auricle. Now what about the external auditory canal? Now talking about the external auditory canal, let's rule out, okay, let's rule out initially the nerve supplying what? External auditory canal, okay, auricle. Now trigeminal nerve, we know what is trigeminal nerve? Fifth nerve, right? Fifth nerve, the fifth branch of fifth nerve was our what? Auriculotemporal, so it is supplying what? Auricle. Glossopharyngeal nerve, right? Ninth nerve, still we are not about, we don't know about it, so let's leave it. Facial nerve, we know seventh nerve was supplying what? Our auricle, right? And vagus nerve, 10th nerve was supplying our what? Our auricle pinna. So here, without knowing the about external auditory canal, we knew that glossopharyngeal nerve is the right answer. Glossopharyngeal nerve did not supply auricle and external auditory canal. It gives sensory supply to middle ear only, right? Sensory supply of external auditory meatus is by. Now talking about external auditory meatus, the nerve supply of external auditory meatus, right? Okay, talking about the external auditory meatus, right? Let's suppose this is external auditory meatus. Now here what we have got different region, right? Now here this posterior superior region, it is supplied by what? Seventh cranial nerve, right? And here in the case of what? In the case of vestibular schwannoma, right? Vestibular schwannoma, at that time there is what? There is loss of sensation in posterior superior region, or hypostasis of hypoanesthesia of posterior superior region, right, in external auditory canal, and that was called Hertzberger sign, right? It was what? It was found in vestibular schwannoma. Now here talking about this region, right, anterior superior region is supplied by what? Auriculotemporal nerve, and that is the V3, right, trigeminal, third branch of trigeminal nerve, right? Similarly, talking about this anterior inferior is supplied by what? Arnold nerve. Now this Arnold nerve is what? The Arnold nerve is a branch of vagus nerve, right? And here, right, while doing syringing, there is what? There is cough reflex, right? Now cough reflex, there is cough reflex, and that cough reflex is not because of what? Internal laryngeal nerve. It is because of what? It is because of our Arnold nerve, right? It is because of Arnold nerve. Okay, now talking about posterior inferior, right? Posterior inferiorly, right? Okay, now these are what? These are the nerve supply of external auditory meatus, right? These are the nerve supply of external auditory meatus. These are the nerve supply of external auditory meatus. Okay, now talking about the sensory supply of external auditory meatus. Okay, what are the sensory supply of external auditory meatus, right? The sensory supply are our what? These are the facial nerve, right? Facial nerve, and another auriculotemporal nerve. These are the sensory supply of external auditory meatus, right? Okay. Now moving further, the cough response caused while cleaning the ear canal is mediated by stimulation of, I've just said, right, what? Arnold nerve, right? The Arnold nerve, that is the Arnold nerve is a branch of 10th cranial nerve. So 10th cranial nerve is the right answer, right? Okay. Now moving forward, during ear examination, cough occurred due to stimulation of, normally it is because of internal laryngeal nerve, but here it is not such. The here Arnold nerve is responsible, that is vagus nerve, the branch of vagus nerve. Now question number 57, the nerve supply of tympanic membrane is by. The nerve supply of tympanic membrane is by. Now talking about the nerve supply of tympanic membrane, right? Tympanic membrane, it is again what? It is again divided into medial and lateral aspect, right? Talking about medial aspect, right, it is supplied by what? It is supplied by Jacobson, right? Jacobson's nerve, right? Nerve. And Jacobson nerve is a branch of what? It is a branch of 9th nerve, that is glossopharyngeal nerve, right? Glossopharyngeal nerve. Now this 9th nerve, glossopharyngeal nerve, is responsible for referred pain at ear, right? Now okay, now talking about now this medial surface is supplied by what? Jacobson nerve, we can remember as MJ. And talking about the lateral surface, it is supplied by there are two divisions, anterior and posterior. Now posteriorly it is supplied by Arnold nerve, right, the branch of vagus nerve, and anteriorly it is supplied by what? It is supplied by auriculotemporal nerve, right? Auriculotemporal nerve, right? Okay, this is about the nerve supply of tympanic membrane. Now let's see, auriculotemporal nerve, yes it is supplying what? The anterior part of lateral surface, right? Auricular branch of vagus, auricular branch of auriculotemporal, auricular branch of vagus. No, the branch of vagus is Arnold nerve, right? Okay, occipital nerve, we don't talk about that. We did not talk about that, right? Greater auricular nerve, we did not talk about that also. And glossopharyngeal nerve, yes, we talked about glossopharyngeal nerve also. So the answer is our A, right? Auricular branch of vagus also, because Arnold nerve is also there. B and our E, right? Glossopharyngeal nerve. Okay, moving further, the sensory nerve supply of middle ear cavity is provided by. Sensory supply of middle ear cavity is provided by our glossopharyngeal nerve, right? The supply of middle ear is by tympanic plexus, which is formed from Jacobson nerve, right, which is tympanic branch of our this glossopharyngeal nerve, right? Okay, now which nerve is responsible for report pain to ear? That is also our what? Glossopharyngeal nerve, right? Which of the following pain is not referred to ear? Now which? Pharynx, yes, it is referred to ear, right? Tongue, it is referred to ear. What? TM joint, it is also referred, but vestibule of nose, it is not referred, because vestibule of nose is supplied by maxillar nerve, which do not supply ear, right? Pharynx, it is supplied by what? It is supplied by pharyngeal plexus, formed from vagus and glossopharyngeal, both of which also supply ear. And talking about tongue, it is supplied by lingual branch of mandibular, glossopharyngeal and vagus, and all which also supply ear, right? And talking about TM joint, right? TM joint is supplied by auriculotemporal nerve, which also supplies ear. That's why referred pain is present there. Now talking about question number 61, referred pain can be due to, it can be due to what? It can be due to carcinoma of larynx, tongue and oral cavity. It can be because of all of the above, right? It can be because of all of the above. Okay, now moving further, okay, now we are into the question number 62. The carcinoma base of tongue is referred to ear through. The carcinoma base of tongue is referred to ear through, that is what? Glossopharyngeal. Again, stapedius is supplied by what? It is supplied by what? It is supplied by simple our what? Facial nerve, right? It is supplied by facial nerve. Now talking about question number 64, the tensor tympani is supplied by tensor tympani, right? It is supplied by tensor tympani is supplied by anterior part of fifth cranial nerve, right? Anterior part of fifth cranial nerve. The tensor tympani muscle is derivative of first arc and is supplied by first knob of first arc, that is mandibular knob or anterior or motor branch, right? Anterior part of fifth cranial nerve, tensor tympani, right? Okay, moving further, promontory is seen in middle ear and is related to, promontory is related to what? It is related to basal tone of cochlea. Promontory is simply nothing, it is bulge, right? It is bulge in center of medial wall of middle ear produced by basal tone of cochlea, and promontory tympanic plexus is present, right? And talking about, okay, that's all, right? Talking about jugular bulb, it is below the floor of middle ear. And talking about the body of Mcqs is present in epitympanium of middle ear cavity, right? Epitympanium, right? Epi, meso and hypo, it is present in epitympanium. And talking about what? Semicircular canal, lateral semicircular canal bulge is present on most posterior superior portion of medial wall of middle ear, or just above the horizontal or tympanic segment of facial nerve. Now moving further, talking about processus cochleariformis is related to, it is related to what? It is related to tendon of tensor tympani. Now this process cochleariform, what? Is a hook like a structure present anterior superiorly on medial wall of middle ear. Now this tensor tympani, what it does is muscle, it will what? It will wind around process cochleariformis and then turn laterally to get attached on upper part of handle of medius, right? Just below its neck. Now Stapes footplate covers, it covers what? Oval window, right? And talking about round window, there is what? Secondary tympanic membrane, right? Secondary tympanic membrane. Now moving into next question, that is the secondary tympanic membrane is present over, yes, we know about it, that is round window. The facial recess is bounded by what? The facial recess is bounded by medially. The facial knob is bounded medially by, the facial recess is bounded by, it is bounded by what? Medially by vertical part of what? Our seventh cranial nerve, laterally by coda tympani, right? Laterally by coda tympani, above by fossa incudius, right? Fossa incudius. Now it is bound here, the answer is all of the above. While doing posterior tympanostomy through facial recess, there are chances of injury to following accept. Now there are chances of what? Injury of following accept. In facial recess, we knew about the boundaries of facial recess just above, right? Now there was what? Vertical part, there was no horizontal part, right? Okay, but facial nerve horizontal part was not there in that boundary, so here the facial nerve horizontal part is the right answer. Coda tympani can be affected because of the forming lateral boundary, right? Talking about dislodgement of short process of Mcqs from fossa incudius, it was on the roof. Vertical descending part of facial nerve, yes, vertical part of facial nerve was what? Providing what? It was providing medial boundary, right? Now all are true about facial recess except suprapyramidal recess. It is suprapyramidal recess, yes, it is, right? Now talking about another, that is medially it is bounded by coda tympani and laterally by facial nerve, that is also right. Medially it is bounded by coda tympani and laterally by facial nerve. Okay, now important in cochlear implant, right? Now okay, now here question number B, medially it is bounded by coda tympani, medially it was bounded by vertical segment, right? And laterally it was bounded by what? Coda tympani. So here the option number B is not right, right? And the option number C, important in cochlear implant, yes, it is important in cochlear implant, right? And middle ear can be approached through it, yes, it can be. So medially the facial recess is bound by facial nerve, that is vertebral vertical part, and laterally by chora tympani. So this option is not correct here, and it is the right answer. Eustachian tube open into middle ear cavity at Eustachian tube and tensor tympani. These are the component of what? Anterior wall, right? Okay. Now length of Eustachian tube is what? 36 millimeter. And about Eustachian tube, true is it is 24 mm in length. No, it is not. Outer 1/3 is cartilaginous. Here the outer 1/3 is cartilaginous. No, it was in what? Eustachian. It was in external auditory canal, right? Inner 2/3 is bony, right? It is saying inner 2/3 is bony. It is also not right. Inner 2/3 is cartilaginous. So the option number D, this is right. Open during swallowing. Yes, it is also right. It opens during swallowing, right? Swallowing. Now true about Eustachian tube is size is 3.75 centimeter. Yes, the size is this much. 1/3 cartilaginous and 2/3 bony. It is not right, because here it is opposite. That means inner 2/3 is cartilaginous. Opens during swallowing. That's also right. Nasopharyngeal opening is narrowest. No, it is not right. Tensor palatini help to open it, right? Tensor palati, right? This is right. So here tensor palati helps in opening it. Yes. Open during swallowing. Yes. Size is 3.75 centimeter. That's also right. So okay, now talking about true about Eustachian tube is length is 36 mm in children. Is it? Okay, just okay. Now talking about question number 76, is the length 36 in children? No, it is not, right? Talking about higher elastic cartilage in adult? No, higher elastic what cartilage is in what? Yes, it is present in what? Adult only. Higher elastic cartilage content is present in adult, right? Okay, ventilator function of ear better developed in infant? No, it is not. More horizontal in adult? No, it is more horizontal in children. Angulated in infant? It is straight in infant, right? So that the infection will easily be what? It will be traveling, right? So here the right answer is higher elastic content in adult, right? Okay. Now which of the following cause opening of Eustachian tube? Levator veli palatini and tensor veli palatini, right? Here among these two, the tensor veli palatini will cause opening of Eustachian tube, right? Okay. Now moving further, the floor of middle ear cavity is in relation with, right? Floor is in relation with bulb of internal jugular vein, right? Bulb of internal jugular vein. But here internal carotid artery, it is what? It is in relation to anterior wall, right? It is in relation to anterior wall. Now moving further, right? Moving further, the tegment tympani separate middle ear from the middle ear cranial fossa containing temporal lobe of brain by, right? The tegment tympani separate middle ear from middle cranial fossa containing temporal lobe of brain by, it will separate by what? By roof of middle ear, right? So tegment tympani is right here, middle cranial fossa is right here, and here what? Here we have what? We have ear structure, right? Now here we have ear structure. So here this what? Tegment tympani, right? Tegment tympani is forming what? It is forming roof, right? Roof of middle ear, right? Roof of middle ear. Now moving further, right? Moving further, the distance between tympanic membrane and medial wall of middle ear at the level of center is, so if we remember, if you remember, at the level of center it is narrowest, right? That means it is how much? It is 2 mm, right? 2 mm. Now 2 mm, if you recall the fact, the epitympanum, right? Epitympanum, the cavity of middle ear, epitympanum, mesotympanum and hypotympanum, right? The hypotympanum is 4 mm in diameter, meso it account for 2 mm and it is narrowest, and epitympanum is 6 mm and it is what? It is widest. So 4, 2 and 6. EP is highest, so it is highest, right? EP is highest. Meso is how much? It is 2 and hypo is 4 mm. So here at the center there is meso, so 2 mm. Distance of promontory from tympanic membrane, it is also asking the same thing but in different way, right? It is 2 mm, right? The narrowest part of middle ear is, it is what? It is mesotympanum, right? As we have already mentioned. Now true sac space is situated in, it is situated where? It is situated in epitympanum. Now importance is the space of epitympanum lying in between Sharpnell's membrane or pars flaccida and neck of malleolus, right? Between neck of malleolus and Sharpnell's membrane or pars flaccida, that is true sac space. When retraction pocket on pars flaccida grows medially, it goes into Prusac space, making this the most common site of primary cholesteatoma, right? It is the most common site, right? It is most common site of primary cholesteatoma. Okay, all of the following are component of epitympanium acid, right? Okay, the body of incus, it is head of malleus, it is the component, right? Now talking about coda tympani, it is foot plate of step is not the component of what? Epitympanium, right? Now epitympanium, what epitympanium contains? It consists of head, neck, anterior and lateral process of malleus, right? Similarly of incus, short and body and short process of incus, right? Incudo-medullary joint is also present here, right? Coda tympani is also present here, Prusac space is also present here, but the long process of incus, handle of malleus, incudo-stapedial joint, they are not present here. And hypotympanium does not contain anything at all, right? What is type of joint between ossicles of ear? Now talking about MIS, right? Now in between all these ossicles there is present of what? Synovial joint, but talking about specific type of synovial joint in between malleus and incus, it is what? It is saddle joint, right? Saddle joint. And between incus and what? Our steps, it is what? Ball and socket joint, right? So here the answer is synovial joint. As a whole, it is synovial joint. Now the Mcqs triangle is landmark for what? It is landmark for mastoid antrum, right? Mcqs triangle is landmark for our mastoid antrum. Now, talking about Mcqs triangle, right? It is suprameatal triangle, and it is important while doing mastectomy surgery in approaching the mastoid antrum. Now, talking about Mcqs triangle overlies which structure? The same one, mastoid antrum. The suprameatal triangle overlies which? It is also the mastoid antrum. What forms lateral wall of mastoid antrum? Now the lateral wall of mastoid antrum is formed by what? It is formed by our what? Squamous temporal, right? Structure, squamous temporal bone. Okay, now here talking about other structure, tegmen antri, right? Tegmen antri, it forms what? It forms roof, right? And medial wall of mastoid antrum is related to posterior semicircular, what? Medial wall is related to posterior semicircular canal, right? Medial wall is related to posterior semicircular canal, and remaining is our squamous temporal, it forms lateral wall of mastoid antrum, right? Now which of the following forms boundary of Mcqs triangle except? Temporal line, it forms. Posterior superior segment of bony external auditory canal, it forms. Promontory, no such role. Tegmen drawn to external auditory meatus, yes, it also forms. Now talking here, so the right answer is promontory. Now talking about what? Mcqs triangle, right? Mcqs triangle, let's suppose this is Mcqs triangle. Now okay, let us suppose this is Mcqs triangle, and here we have what? External auditory canal. So now here the temporal line, this is the temporal line, right? Temporal line is what? It is forming what? It is forming temporal line or supramastoid crest, right? Now here it is forming what? It is forming superiorly, it is bounding what? Our this Mcqs triangle, right? Now here right here we have what? We have, okay, here we have posterior superior segment of bony external auditory canal. This is posterior superior segment of bony external auditory canal. Now here, and this is what? This is tegmen drawn to external auditory meatus. So here what is this structure? The above one, that is what? That is our temporal line, right? Temporal line. And here we have what? We have posterior superior segment of bony external auditory canal, and here we have got what? Tangent drawn to external auditory meatus. So these are what? The boundary of Mcqs triangle. Now moving further, all are false about Mcqs triangle except mastoid antrum lies 1.5 cm deep to it. Yes, that's right. Surgical landmark to facial nerve. Okay, all are false about Mcqs triangle except, that means what is the true statement, right? Here it is asking about true statement. Mastoid antrum lies in 1.5 cm deep to it. Yes, it is the true statement, right? Surgical landmark for facial nerve, no, it is not, because it is for mastoid antrum. Present in preauricular region, no, it is not present in preauricular region, right? It is bounded by suprameatal crest anteriorly, no, it is not bound by suprameatal crest, right? Anteriorly, right? Suprameatal crest is superior root of zygomatic process, right? And here Mcqs triangle is surgical landmark for mastoid antrum lying in posterior auricular region, not preauricular region. It is bounded superiorly by temporal line or suprameatal crest, which is posterior extension of suprameatal crest, right? Okay, now talking about City's angle, what is City's angle? It is sinusoidal angle, right? It is sinusoidal angle. Now spine of Henle is a landmark for mastoid, right? Spine of Henle is also a landmark for mastoid. Now talking further, the organ of Cautai is situated in where? It is situated in basilar membrane, right? Now endolymph in ear is what? It is endolymph in ear is our secreted by stria vascularis, right? Stria vascularis. The cochlea endolymph has potential of how much? It has the potential of our plus 80 millivolt, right? It has the potential of plus 80 millivolt. The function of stria vascularis is it produces endolymph, right? It maintains electrical malleus of endolymph, right? It maintains electrical malleus of endolymph. Primary receptor cells of hearing are, what are the primary receptor cells? These are our what? Our hair cells, right? Primary receptor cells of hearing are our hair cells, right? What is the primary? Where were we? Okay, primary receptor cells of hearing are our hair cells, right? Now moving further, all of the following are concerned with auditory pathway except, right? Trapezoid body, medial geniculate body, genu of internal capsule, lateral laminosus, right? Genu of internal capsule, right? It's not related to what? Auditory pathway, right? Genu of internal capsule is not concerned with auditory pathway. It is posterior limb of internal capsule through which ultimately the fibers pass through and reach auditory cortex. Now trapezoid body is associated with what? It is associated with auditory pathway, right? As mentioned above, it is associated with what? Auditory pathway. Now moving further, the higher auditory center determines what it determines. It determines sound localization, right? It determines sound localization. Higher auditory center determines sound localization. Appreciation of sound occurs in where it occurs, right? It occurs in transverse temporal gyrus, right? It occurs in transverse temporal gyrus, that is appreciation of sound, right? And above we talked about higher auditory center determines what? Sound localization, and appreciation of sound occurs in transverse temporal gyrus, right? Okay, otolith organ are concerned with function of what? Otolith, linear acceleration. The otolith are concerned with linear acceleration, right? Now talking about static equilibrium is due to macula. Macula senses linear acceleration, right? Gravitational, it senses linear acceleration, gravitational movement either with or against gravity, and head tilt movement, and they also help to maintain static equilibrium by facilitating postural tonic neck and writing reflexes, right? And that is done by macula, right? Okay, now moving further, all are correctly matched except, right? All are correctly matched except, right? The otolith is made up of uric acid crystal, so it is not correctly matched. Other position of otolith changes with head position, that's right. Otolith component of maculae, that's right also, right? Otolith organ stimulated by gravity and linear acceleration, that is also right, right? But here the otolith made up of uric acid crystal is not right, because it is made up of calcium carbonate, right? Calcium carbonate, they are present in macula and stimulated by gravity, linear acceleration, and head tilt movement, right? Okay, now moving further, not correctly matched pair is, right? Now not correctly matched pair is utricle and saccule, right? Utricle and saccule contains cristae. No, utricle and saccule, right, they contain maculae, right? Utricle and saccule contain maculae, right? Talking about oval window, in oval window footplate of steps, yes, it is right, right? Antrum, what the landmark for antrum is Mcqs triangle, that's also right. Scala vestibuli, right, contains Reznor's membrane, that's also right. So the utricle and saccules contain macula, right? It contains macula, and the cristae are present where? The cristae are present in semicircular canal, they are not present in utricle and sacculus. sacules, right? And footplate of steps overlies oval window. We are right, it is right. Similarly, Mcqs triangle or suprameatal triangle is the bony landmark for mastodontal. That's also right. Similarly, scala vestibuli is separated from scala media by razor membrane. That's also right. Now, vertical crest of bone in internal acoustic meatus is, in internal acoustic meatus, the vertical crest of bone is what? What is it? It is Bill's spur, right? It's Bill's spur. What is Bill's spur? Right now, Bill's spur is vertical crest of bone in internal acoustic meatus. Now, talking about ponticulus, is a ridge which run from oval window to sinus tympani, forming a superior content. And talking about cog, it is bony projection from roof of middle ear, right? Such that tegment tympani to processus cochleariformis, serving as approximate landmark for facial nerve. And talking about falciform crest, divides the internal acoustic meatus into superior and inferior part. Now, moving further, the singular nerve is, right? The singular nerve is, what is the singular nerve? Now, here the singular nerve is our inferior vestibular nerve supplying posterior semicircular canal, right? It is inferior vestibular nerve supplying posterior semicircular canal. Talking about labyrinthine artery is a branch of, it is a branch of anterior inferior cerebellar artery, anterior inferior cerebellar artery, right? Labyrinthine artery is a branch of AICA, anterior inferior cerebellar artery. Now, what is scutum? Now, talking about scutum, what is scutum? It is lateral wall of attic, right? It is lateral wall of attic. Now, talking further, right? Okay, Eustachian tube connects middle ear to pharynx. Yes, we are sure about it. The utricles tip links to hair cells are involved in utricles. The tip links in hair cells are involved in, where are these involved? Regulation of distortion activated ion channel. These are involved in regulation of distortion activated ion channel. The tip links in hair cells are involved in regulation of distortion activated ion channels. Now, type of joint between malleus and incussus, I have already said these are what? Saddle joint. Site of Darwin's tubercle is, what is the site of Darwin's tubercle? That is posterior lateral part of helix, right? Darwin's are situated posterior lateral part of helix. Now, common nerve supplying pinna, tympanic membrane and EAC is, that is greater, the common nerve, right? Common nerve means which is found in every, in pinna also, in tympanic membrane also, and EAC, that is Arnold nerve, right? Arnold nerve. Now, the direction of EAC is what? It is what? Downward, forward and medial, right? Downward, forward and medial. Now, the oval window opens into, where oval window opens? It opens into scale. Where does it open into? It opens oval window, right? Oval window opens into what? It opens into vestibule, right? It opens into vestibule. Yes. Now, membranous labyrinth developed from, where it is developed from? It is developed from surface ectoderm, right? Membranous labyrinth develops from surface ectoderm. The complete absence of bony and membranous labyrinth is what? Michel's aplasia. Now, pinna is made up of how many cartilage? It is made up of what? Single cartilage, right? Now, here the pain in tonsillitis is referred to ear through. The referred pain to ear is through what? It is through 9th cranial nerve, right? 9th. Location of preauricular sinus is, preauricular sinus is where? At the what? Root of helix, right? Root of helix and tragus, in between root of helix and tragus, but here root of helix is appropriate answer. Not seen on medial wall of middle ear. In medial bar, promontory is seen, oval window is seen, facial braces, is it seen? No, it is not seen, right? It is not seen. And lateral semicircular canal bulge, yes, it is seen. So, facial braces is the right answer. Knob supply of auricle and EAC are all SF. Recall of auricle, right? In auricle, there was Arnold nerve, greater auricular nerve, right? There was what? Auriculotemporal nerve, right? Okay, these were the nerve. Lesser occipital nerve also. And talking about EAC, right? They were Arnold nerve, right? They were Arnold nerve. They were 7th nerve, right? There was what? There was our Arnold nerve, 7th nerve. Okay, let's see this much, right? Now here Arnold nerve, yeah, it supplies. Auriculotemporal nerve, it supplies. Jacobson nerve, no, it does not supply. It was found in tympanic membrane. So the right answer is Jacobson nerve, which is a branch of what? Our glossopharyngeal nerve, right? Now, skin of lower 1/3 of auricle is supplied by nerve. skin of lower 1/3 of auricle is supplied by our greater what auricular nerve, right? Greater auricular nerve. Now moving further, the sensory supply of marked structure is, now here sensory supply of this structure. What will supply this structure? It will be supplied by what? Greater auricular nerve only, right? Greater auricular nerve. Now coda tympani passes between which layer of tympanic membrane? Coda tympani passes between which layer, right? It passes between what middle and inner, right? Inside it passes. Suprameatal triangle is external marking for mastoid antrum, right? The angle of tympanic membrane with horizontal is that is our 55 degree, right? 55 degree is the angle of tympanic membrane with horizontal. Now moving further, okay, the significance of marked structure in the given picture is, okay, now we need to know what is this structure, right? Now the significance is, right, the significance is Stapes flip plate is present on it, okay, no. Intact tympanic intact canal wall surgery is done through it, no. It ventilates the middle ear, no. Cochlear implant electrode are introduced through it, yes, it is right, because what is this? This is our what? Now here the mass structure is round window, right? Round window. So through round window, right, cochlear implant electrode are introduced into inner ear through round window. Okay, now encircled area is, now what is this encircled area? This is facial recess, right? Facial recess. Moving further, true about the marked area in the given picture is, it is landmark for antrum, yes it is, right? It is the landmark for mastoid antrum. It is known as Trotman's triangle, no, that's not right, right? The Prussic space is being depicted, no, that's not right. The site is approached while doing maringotomy, no, that's not right. So the answer number A is right answer, right? Now moving to our next question, find the incorrect pair, tympanic membrane and malleus. Okay, that's right. Helicotrema, apex of cochlea, we need to think about it. Basilar membrane cochlea, that's also right, right? Otolith, semicircular canal. Okay, now here it is not right, right? It is not right. Why? Because it is not right. Cristae are present in semicircular canal, right? 5-year-old child developed perotitis following otitis external. This could have happened through fissure of Santorni. We talked about it earlier, right? The cranial nerve passing through internal auditory meatus. The cranial nerve passing through internal auditory meatus. What is the cranial nerve? That's 7th cranial nerve, right? Simple as that. Stria vascularis is present where? It is present, right? It is present, it helps in secretion of endolymph, we know that. It is, where it is present? It is present in cochlea, right? It is present in cochlea. Otoconia is seen in utricles, right? It is seen in utricles. The feature of Selbach's dysplasia is, right, it is what? It is the most common genetic abnormality, right? Now the feature of Selbach's dysplasia is dysplasia of cochlea and saccule, right? It is the dysplasia of cochlea and saccule. Now endocochlear potential is how much? It is the endocochlear potential is plus 85 millivolt. We talked about it earlier. The facial nerve exit in skull through what? The facial nerve exit through skull, exit from skull through, it is stylomastoid foramen. Stylomastoid foramen, right? Facial nerve exits the skull through stylomastoid foramen. Where is auditory cortex located inside the brain? Auditory cortex, it is what? It is present where? It is present in superior inferior area 31 or cingulate gyrus. It is present in superior temporal gyrus, right? Inferior and vertical post-auricular incision in children less than 2 years old may cause damage to which cranial nerve, right? Inferior and vertical post-auricular incision, it will obviously lead to damage of what? The facial nerve, 7th nerve, right? Which of the following help in detection of horizontal movement of head and body? Horizontal, right? Horizontal, that is what? Utricle, right? Utricle, right? Okay, now moving further, question number 144. The facial nerve lie with which nerve in internal auditory meatus? Facial nerve lies with which nerve in internal auditory meatus? It will lie along with vestibulocochlear nerve, right? To lie along with vestibulocochlear nerve. All of the following are part of bony labyrinth except, right, which is not a part of bony labyrinth, and that's our Utric cord is not part of bony labyrinth, right? Okay, now moving further, length of external auditory canal is how much? 2.4 centimeter or 24 mm. Coronal septum arises from petrosquamous suture, right? Petrosquamous suture. Tensor tympani is attached to, it is attached to what? It is, tensor tympani is attached to our, let's say, malleus, right? Malleus. Now from, okay, tensor tympani is attached to malleus, yes, because it will wind around processes cochleariformis, and from there it will go to malleus to bind in malleus. Sensory supply of middle ear is provided by, we talked about it, that's glossopharyngeal. Endolimb resemble intracellular fluid, right? Referred pain can travel through all except, right? Glossopharyngeal, it can travel through glossopharyngeal, right? Trigeminal, yes, there are. Vagus, yes, but abducens, no, there are no chance, right? Abducens is the answer. Sidley's angle is sidereal angle. Cone of light is seen in which part of tympanic membrane? That is anterior inferior part, right? Anterior inferior part. True about eustachian tube is bony part measures 24 mm. No. Lateral part is cartilaginous. No, that's what? That's bony, right? But in ear it was. Valsalva maneuver opens eustachian tube. Yeah, that's right. Valsalva maneuver opens eustachian tube. And tensor velipalatine closed eustachian tube. No, it opens eustachian tube. Muscle originating from pyramid of middle ear, that is stapedius, right? Stapedius. Now, talking further, the most common congenital middle ear abnormality. What is it? It is fixation of foot plate of steps, right? Fixation of foot plate of steps. That's most common congenital middle ear abnormality. Fixation of foot plate of steps. Fixation, right? Foot plate, not option but fixation. Now volume of middle ear and mastodantrum is how much? 6 ml, right? 6 ml is the right answer. Ostman pad of fat is related to what? Eustachian tube, right? It helps in opening it, right? Not part of middle ear. Semicircular canal, yes, no, it is not. Mastodantrum, it is. Tympanic cavity, it is. Eustachian tube, it is. Semicircular canal is not the part of middle ear, it is a part of inner ear. Structure present in the given picture is, right? What is the structure present? Now here, okay, as you can see, this and this, right? This is obviously what? Handle of malleus or umbo, we can say, right? Malleus. And what is this? This is round window. We just talked that from round window only we are giving what? Cochlear implant, right? Okay, so these are what? Our malleus and round window. That's right. Now, which of the following is true about given picture? Now, talking true about given picture is, okay, here we can see the cone of light. Cone of light is what? It is in what? How much? 5 o'clock, right? Not in 7 o'clock. And 5 o'clock, right? 5 o'clock, that is what? That is right ear, right? 7 o'clock, that is left ear. It is left ear. It is saying it is left ear. No, it is not left ear, right? Okay, the posterior part is more easily accessible, right? The posterior part is more easily accessible. Develops from first arc. No, it is also wrong. Sharpness membrane is more tense. It is also not. What? Following is true about the given picture, so it is also not right. Sharpness membrane is not more tense, right? The sharpness membrane is what? It is mobile. The periphery is mobile. The center is tense. Develops from first arc, that's not right. Posterior part is more easily visible, so that's right statement. Inner ear cell of organ of Cotter release which excretory neurotransmitter, right? It releases glutamate, right? It releases glutamate. So these are what? These are 162 questions of embryology and anatomy of ear. Now here we are going to do the MCQ from physiology and test of hearing of what? Of ear. Now here the first question is, now bone of middle ear are responsible for following except. Now yeah, from except we need to find the wrong statement. Protecting the inner ear, yes, it does it. No alteration of sound intensity, it increases the sound intensity, right? So it is not the right answer. It is not the right statement, so it can be right answer. A reduction of impedance to the sound transmission, yes, it is done to protect from ear trauma, noise induced trauma. Amplification of sound intensity, it does it, right? So here the answer is no alteration of sound intensity because it increases the sound intensity. right? Okay, function of ear ossicle is impedance matching. Yes, it is the function. Transduction of sound, it is also what it is, not the right statement. Equilibrium, no, none. So impedance matching is what the function of ear ossicles. Now how it does impedance matching? The first thing is there are two mechanisms. One is what? Now one is through lever ratio and another is through aerial ratio. Now okay, lever ratio, the Mcqs is 1.3 times, right? What the long process of the length of handle of Mcqs is greater than long process of Mcqs, right? That is lever ratio. Now it is around 1.3 times, right? 1.3 times. And talking about the what surface area ratio, right? The aerial ratio, tympanic membrane is how many times? It is 17 times what more than of Stapes foot plate area, right? That is 55 mm square and 3.2 mm square. So from 17, right, 17 aerial ratio, and from lever ratio, that is 1.3, right? Now here by doing it we get what? 22 times, right? 22 times of ossicular coupling, right? Now there is another thing, that is also tympanic membrane catenary lever, right? Curved membrane effect, that will produce how much? 2 times. So into 2 it will produce how much? 44 times, right? The amplification will be 44 times. Okay, let's say, yeah, 44 times. Okay, now this was, so the impedance matching is the function of ear ossicles. The lever ratio is, I have just mentioned, the lever ratio is 1, how much? 1 is to, okay, 1.3 is to 1. The handle of Mcqs is 1.3 times longer than the long process of Mcqs, so the lever ratio is 1.3 is to 1, right? Similarly the aerial ratio is how much? 17 is to 1, right? 22 is the total transformation ratio of middle ear, right? Aerial ratio into what? Our lever ratio. The ratio of tympanic membrane to oval window is, I have already said, it is how much? It is 17 is to 1. The impedance matching occur due to, right, impedance matching, difference of surface of tympanic membrane and foot plate, that's also right. Semicircular canal is not right. Utricle encephalus, it is not right. So the difference in surface area of tympanic membrane and foot plate. Scientists who worked on conduction in inner ear, right? It is what? The scientist who worked, that is our Helming and Mcqs, right? Helmholtz and Mcqs, right? He be remembering by be he, right? Okay. Conductive deafness occurred in what? Conductive deafness will occur in what? Traveling in aeroplane? No. Trauma to labyrinth? No, it is inner ear. Steps abnormal at oval window? It can be, because it is middle ear, right? Middle ear infection or middle ear problem cause conductive deafness. And high noise? No, it is not. So steps abnormality at oval window will cause conductive deafness. All are cause of sensory neural deafness except old age. Yes, it is, right? Cochlear otosclerosis, it is also the cause. Loud sound, it is also. Ruptured tympanic membrane, no, it is not, because it is related to conductive hearing loss, right? Not sensory neural hearing loss, right? Okay. Resonance of tympanic membrane. What is the resonance of tympanic membrane, right? In what frequency it resonates? It resonates about 1000 to 3000, right? 1000 to 3000. Now ear ossicles effectively transmit sound of which frequency? It effectively transmits sound of which frequency? It is how much? 500 to 2000 hertz, right? 500 to 2000 hertz it transmit sound of these frequencies. Now here all are tuning fork test except Swabach test, yes. Greenwich test, yes. Weber test, yes. So Grant's test, we don't know about it, right? There is no entity in ENT called Grant test, so it is what? It is not tuning fork test. Tuning fork of 502 bell FPS is used in test of hearing because it is better heard, right? It is better heard, that's right, better heard. Tuning fork tests are most commonly done with 502 bell hertz, right? Sound frequency producing fork, because these are better heard, right? And tuning fork less than 502 bell have more of vibration sense, and those with above 502 bell dampens very fast, because of which comparison is not possible. So less than 502 bell hertz, right? Less than 502 bell hertz, what they will do? They will produce more vibration, right? More vibration. And which are what? Above 502 bell hertz, they will what? They will dampen fast, right? Tuning fork frequency used most commonly in ENT is how much? 502 12 hours, right? Raynaud's test is negative in, Raynaud's test is negative in, it is negative in our what, in middle ear infection, in conductive hearing loss, that is tympanosclerosis, right? The Meniere's disease is an inner ear condition. Acoustic neuroma is also inner ear condition. Sensorineural deafness is also inner ear condition. So Raynaud's test is negative in tympanosclerosis, that is conductive hearing loss, right? Raynaud's test negative is seen in, Raynaud's test negative is seen in where? I have already said it is seen in conductive hearing loss, right? Presbycusis, no. Labyrinthitis, no. CSUM, yeah, it is the right answer, right? Now Raynaud's test is negative if minimum deafness is how much for minimum deafness for Raynaud's test to be positive? That is what? That is 15 to 20 decibel, right? 15 to 20 decibel. Positive Raynaud's test indicate, right? That is normal, that is ear conduction is greater than bone conduction, right? Now positive Raynaud's test is seen in, right? It is not seen in otosclerosis, it is CSOM because it is also middle ear condition. Impacted wax, here also conductive hearing loss will be seen. Presbycusis, here the positive Raynaud's test is seen. Raynaud's test is positive in, it is seen in what? Inner ear condition, right? Or in normal individual. So normal individual is the right answer. Now moving further, Weber test is best elicited by, now how it is elicited? Okay, I would like to go toward direct to our answer. By placing tuning fork on the forehead and asking him to report in which ear he hears it better, right? Placing from forehead, tuning fork on forehead and asking him to report in which ear he hears it better. What should be least hearing loss for Weber test to lateralize, right? The least, it should be 5 decibel, right? 5 decibel. Okay, now moving further, in right middle ear pathology, Weber test will be, right? Weber will lateralize toward what? Toward conductive hearing loss, right? Lateralize toward right side, so it will lateralize toward the pathologic ear, right? Weber test is in conductive deafness, right? It will sound louder in diseased ear, right? It will sound louder in what? Diseased ear. Weber always what? Lateralizes toward worse ear in conductive hearing loss and better ear in sensory neural hearing loss, right? Okay, now threshold for conductive threshold for bone conduction is normal, and that for ear conduction is increased in which disease? That means bone conduction is normal, right? But threshold for ear conduction is what? Increased, right? Ear conduction is increased. Now it will be in what? It will be in middle ear disease, right? That's why there is what? There is gap between what? Bone conduction and ear conduction in what? Pure tone audiometry, right? In pure tone audiometry, right? But here the ear conduction is increased, right? But pore conduction is normal in middle ear condition. Now Galley's test is done. Where it is done? It is done in the case of otosclerosis. Galley's and Bing both are done in otosclerosis. In Bing test, on alternative compressing and releasing the trachea, the sound increases and decreases. This indicates, what does this indicates? Right? On pressing the trachea, sound increases and decreases. On alternative, on compressing and releasing. Now this indicates sensory neural deafness. This indicates sensory neural deafness. Now here all other conditions are what? Conductive hearing loss, right? So here it is what it is, sensory neural deafness. Now 38-year-old man presented with suspected diagnosis of suppurative labyrinthitis, right? Suppurative labyrinthitis. A positive Raynaud's and positive fistula test were recorded on initial investigation. The patient refused treatment and returned to emergency department after 2 weeks, complaining of deafness in affected ear. On examination, fistula test was observed to be negative, right? There was fistula test positive. Now here fistula test was observed to be negative. What is likely associated finding on repeated Raynaud's test, right? Now the fistula has already got to be what? Negative, right? Now what about the Raynaud's test? Now here this is the case of what? This is the case of false negative Raynaud's test, right? Now here false negative Raynaud's test will be expected from each individual. In the patient of suppurative labyrinthitis, positive Raynaud's means sensory neural hearing loss, right? Here positive means what? Positive Raynaud's means what? It is sensory neural hearing loss. It doesn't mean normal individual, right? Now here positive fistula test suggests that there is fistula on middle ear wall of medial wall of middle ear. Probably this is cause of labyrinthitis, right? It is cause of labyrinthitis. The fistula test becoming negative after 2 weeks, right? Here the fistula test which was negative after 2 weeks in absence of treatment suggests that the ear has become dead now and therefore non-responsive. False negative fistula is being seen. So Raynaud's here will be false negative because of severe sensorineural hearing loss, right? Raynaud's will be false negative because of severe sensorineural hearing loss. Old man has 30 decibel deafness in left ear with Weber showing more sound in left ear, right? Okay, 30 decibel deafness in left ear and Weber is showing more sound in left ear. That means in left ear there is what? Conductive hearing loss. And bone conduction more on left side, right? And a normal hearing in right side. This test can be summarized as, okay, here let us break it down, right? Now here it is left ear, right? Now it is right ear, right? Weber is showing more sound in left ear, right? Now Weber, what is Weber saying is that, right, Weber is saying that it can be conductive hearing loss in left ear, right? Or what? Now in right ear, Raynaud's, what is Raynaud's saying? It is saying bone conduction more on left side and normal hearing in right side. This test can be summarized as, okay. Let us again begin, right? Now let us talk about the Weber test showing more sound in left ear. Now Weber is showing what? More sound in left ear, right? And bone conduction more on left side, on normal hearing. And bone conduction more on left side, right? Bone conduction is what? More on left side, right? On left side, okay. That means left ear, what is going on? Left ear there is what? Conductive hearing loss, right? And right ear it is normal, right? Weber, now how we can do it is, Weber test is what? Lateralized leftly, right? Weber test is left lateralized and Raynaud's is positive on right? So now here the answer can be Weber test lateralizes toward what? Left lateralized and Raynaud's right positive. Bone conduction is greater than ear conduction and left side. So this can be the answer. Now moving further, right? A middle-aged man presented with right-sided hearing loss. Raynaud's test shows positive result. Now the middle-aged man is there, right? Presented with right-sided hearing loss, right? Right-sided hearing loss. Raynaud's shows positive result on left side. In Raynaud's there is what? Raynaud's shows positive effect on left side and negative result on right side. Weber test shows lateralization to left side, right? Now according to Weber there is what? Left is lateralized, right? Left is lateralized. That means in left we can say conductive hearing loss can be present there, and in right sensorineural hearing loss can be seen there, right? But Raynaud's, what Raynaud's says is, right, Raynaud's says shows positive result on left side, right? On left side positive result. That means in what? Can be sensorineural hearing loss in what? In left side or normal, and in left, right, since it is what? Raynaud's shows positive result on left side and negative on right side. In right there can be what? There can be conductive, right? So here the values are what? Just opposite, right? Now here what you can say that it is the condition of what? Severe sensorineural hearing loss, right? Right sided severe sensorineural deafness. So here also the same thing is going on. This question also same thing is happening. So here also there will be right severe sensorineural hearing loss will be here, right? Okay, moving further. In patient Raynaud's, right, in question number 31, in patient Raynaud's test positive in both ear and Weber lateralizes to right. The next step is, now here what you need to do here is we need to do Swabak test, right? Swabak test, because here in here with Raynaud's test positive in both ear means, right, Raynaud's test is positive in both ear, it means the hearing is normal or there is sensorineural hearing loss in other words there is no conductive hearing loss, right? Since the Weber since here the Weber is where the lateralizing toward what? Right, it means that left ear has sensorineural hearing loss, as it cannot be conductive hearing loss of right ear, right? Raynaud's being positive here, so the diagnosis is left sensorineural deafness, and Swabak test is used to confirm it, right? Okay. In pure tone audiogram, the symbol X is used to mark, okay, there are symbols. One is circle, another is X, right? The circle, right, to this is left and this is right here, right? Now here the it is what it is, I've already said, and the X is used in left here, right, in left here. So the answer is air conduction in left here, right? And here this circle, right, circle, it denotes what, right here. Now O sign in pure tone audiogram indicates, I've already said, it indicates what, right here. And right here also what it indicates, it indicates air conduction, right, and air conduction in right here. Now high frequency audiometry is used in, high frequency audiometry is used in, where it is used, high frequency audiometry, ototoxicity, right, in ototoxicity. Now high frequency audiometry, conventional audiometry test frequency between 250 to 8000 hertz, whereas high frequency audiometry test frequency ranges from 8000 to 20000 hertz, and these are used in what, ototoxicity, right? Okay. Ear is sensitive to what, okay, we talked about, okay, ear is sensitive to what, 20 to 20000 hertz, right, 22 to 20000 hertz, right, hertz, it is sensitive to 20 to 20000 hertz. Now according to WHO classification, severe degree of impairment of hearing is 8, right, severe, that means there are how many, talking about in WHO, right, there are slight or mild, moderate, severe and profound, right? Severe lies between how much, severe lies between 61 to 80, right, 61 to 80 lies in severe, and profound, there is how much, over 81, that is profound, right? So slight or mild, 26 to 40 decibel, right, in adding 20 to it, 41 to 60 is moderate, right, and 61 to 80 again on 18 20 it falls under what, severe, and over 81 is profound, right? Threshold for moderate hearing losses we have already said, right, 26 to 40 and then 41 to 60, right? So right, so here the appropriate answer is 41 to 55 decibel. 40 decibel compared to 20 decibel is how much, it is 100 times, right, it is 100 times. How? Because 40 decibel, right, it accounts for 10 to the power 4, whereas 20 decibel it accounts for 10 to the power 2. So on comparing these two, right, we get 100 times. After rupture of tympanic membrane, the hearing loss is how much, it is how much, at around 10 to 40 decibel, right? Now hearing loss is in range in the hearing loss is in range of tympanic perforation only, right, whereas in other condition, right, in ossicular discontinuity it will be above than 40 decibel, right? Which of the following condition causes maximum hearing loss? Now here the tympanic membrane should be intact and there should be ossicular discontinuity, right? Ossicular disruption should be there with intact tympanic membrane. So the answer is ossicular disruption with intact tympanic membrane, right? Okay, ossicular disruption with perforated tympanic membrane will have rather less hearing loss, because some sound is able to enter in window directly through that perforated tympanic membrane, right? So okay, that is the thing. In patient audiogram shows a hearing loss of 54 decibel. The most probable condition in his ear is, right? Now here what can be what will happen, what can be the probable cause? It can be ossicular discontinuity or disruption with intact tympanic membrane, right? Okay, hearing loss is maximum on what, tympanic membrane perforation or complete destruction of ossicular chain, right, where it is complete closure, where the hearing loss is maximum, it is on complete closure of oval window, right? If there is complete closure of oval window, at that time hearing loss is maximum. Now trough-shaped curve in audiometry is seen in, trough-shaped curve. Now trough-shaped curve in audiometry is seen in congenital sensorineural hearing loss. Trough-shaped curve, right, is seen in congenital sensorineural hearing loss, or it is also called U-shape or cookie bite curve, right? And it is not just seen in cochlear congenital sensorineural hearing loss, it is also seen in cochlear otosclerosis, right? Impedance audiometry is for pathology of impedance audiometry. We already said impedance is being masked by what, middle ear structures. That's why it is for pathology of middle ear, right? It is for pathology of middle ear. Similarly, which of the following test assess resistance in middle ear, right? Test assesses resistance in middle ear. Now here it is done by impedance audiometry. It assesses resistance in middle ear, right? Pure tone audiometry, what it does, it tests the threshold of hearing at various frequency. It tells about type and degree of hearing loss, right? And caloric test is test of vestibular function. And talking about brain evoked response audiometry, right? It tests peripheral or central auditory pathway. Now moving to our next question, the impedance audiometry is done using the frequency of probe 226 Hz, right? It is done using 226 Hz. True statement about tympanic membrane are, right? Now here, tympanosclerosis increases compliance. No, it decreases compliance. Ossicular disruption with intact tympanic membrane reduces compliance. With impact tympanic membrane, no, it does not. It reduces the compliance. Fluid in middle ear cavity increases compliance. It decreases the compliance. Otosclerosis reduces compliance. Otosclerosis, yes, it increases. Now, it increases compliance, right? Flat curve in tympanic membrane perforation, yes, it is also right. So the right answer is otosclerosis reduces compliance. And I know that is flat curve is present there on what? Flat curve is present there on tympanic membrane perforation. Dome shape graph in tympanogram is found in dome shape graph, right? Dome shape graph, that is type B, that is our middle ear fluid, right? Dome shape, it is found on what? Middle ear fluid, that is what? In the case of what? Middle ear fluid, that is serosotitis media, right? In serosotitis media. Now in otosclerosis, AS type of curve is found, right? In ossicular discontinuity, AD type of curve is found. In tympanic membrane perforation, tympanic membrane tympanometry cannot be done as it is not possible to do pressure change, hence a flat curve is obtained, right? B type of tympanogram is seen in what? Serosotitis media. In patient of tympanic membrane perforation, tympanometry shows which curve, right? In patient of tympanic membrane perforation, tympanometry shows which curve, right? That is flat curve, right? Flat tympanogram is a feature of what? It is a feature of serosotitis media, perforation of eardrum, and safe CSOM, right? In osteogenesis imperfecta, the tympanic membrane is, right? In osteogenesis imperfecta, the tympanic membrane is of low compliance, right? Of low compliance. In a young man presents with loss of hearing in right ear following an accident. On otoscopic examination, the tympanic membrane was normal. Pure tone audiometry shows ear-bone gap of 55 decibel in what? Right with normal cochlear reserve. Which of the following will be likely tympanometry finding, right? Now here 55 decibel is what? Will occur in the case of what? Ossicular or discontinuity. Now here, that's why it will show AD type of tympanogram, right? AD, right? AS is found in what? Otosclerosis or tympanosclerosis. B type is found in fluid, presence of fluid, right? Okay. Now talking about another, the post head injury, the patient has conductive deafness, and on examination, in post head injury, the patient had conductive deafness, and on examination, tympanic membrane was normal and mobile with increased compliance on impedance. Likely diagnosis is, what is the diagnosis? There is what? Increase in compliance. So increase in compliance is, right? Increase in compliance, right? And there is what? There is another thing is that tympanic membrane is what? Conductive deafness, tympanic membrane was normal and mobile with increased compliance. The likely diagnosis is, that is distortion of ossicular chain, right? Distortion of ossicular chain. Now why? Intact tympanic membrane with increased compliance on impedance suggests distortion of ossicular chain. Hematotympanium is what? Is possibly for following head injury leading to conductive deafness, but their tympanic membrane compliance will not be reduced, right? Similarly, tympanosclerosis and otosclerosis do not follow head injury, and tympanometry shows reduced compliance, right? Now here increased compliance is shown. Regarding stapedial reflex, which of the following is true, right? Regarding stapedial reflex, it is protective reflex, and it is again protective reflex against loud sound. It is true, right? Stapedial reflex is mediated by how much? It is mediated by 7th and 8th knob, right? 7th and 8th knob. Okay. And hyperacusis is defined as, it is hyperacusis. Normal sound heard as loud, right? Normal sound heard as loud and painful is known as hyperacusis. Similarly, stapedial reflex is absent in where it is absent, right? We said already 7th and 8th are responsible for stapedial reflex. So what? Obviously it should be what? The option number C, that is 8th nerve lesion. In facial nerve palsy of right-sided stapedial reflex, is absent on, right? It is absent on what? It is absent in right side only, right? Tone decay test is done for, it is done for what? Neural deafness, right? Tone decay test. Tone decay is a function of nerve fatigue. If nerve are fatigued, the patient stops hearing a sound given to him continuously before the completion of 1 minute, right? So it is what? Done for neural deafness. Electrocochleography is, what is electrocochleography, right? It is evoked potential generated in cochlear and auditory nerve, right? It is evoked potential generated in cochlear and auditory nerve. In neonate, the most sensitive audiometry screening is, it is OAE, right? Autoacoustic emission, right? Autoacoustic emission. Similarly, initial screening test for newborn hearing disorder. Initial screening test for newborn hearing disorder, that are autoacoustic emission, right? Autoacoustic emission arise from outer ear cells, okay? And true about autoacoustic emission are byproduct of outer ear cells. We are clear about it. Used as a screening test for hearing in newborn infant. Yes, we talked about it. Useful in ototoxicity monitoring. That's also right? Okay. Now, which of the following is the investigation of choice in assessing hearing loss in infant, right? Which of the following is investigation of choice, right? Investigation of choice, it is what? It is BERA, right? Brain evoked response audiometry. To distinguish between cochlear and post-cochlear damage, that means cochlear and retrocochlear damage, the test done is, right? What is the test done? Here the test done is what? The BERA, right? The BERA. Impedance and pure tone audiometry are the test of what? Middle ear only, right? Test of middle ear only. The normal adult, the wave V is generated from, where is the wave V generated from? That is generated from lateral lemniscus, right? The V is the most prominent and easily identifiable, and hence the most important wave of BERA. Wave V is generated from lateral lemniscus. Similarly, the cochlear nucleus give what? Okay, you can remember ECOLI, right? The cochlear nucleus gives wave number 3, right? Similarly, superior olivary complex gives what? Wave number 4, right? And lateral lemniscus gives wave number 5, and similarly inferior colliculus gives wave number 6 and 7. So we can remember by E. coli, right? E. coli. From E there is nothing, from earth now it is earth now, but there is no significance of any wave. So from C we have got what? A cochlear nucleus, right? That gives 3rd wave. Superior olivary complex, that gives 4th wave, and what? Lateral lemniscus, that gives what? 5th, and inferior colliculus, that gives 6th and 7th, right? Okay. Brainstem evoked response audiometry. What is true for brainstem evoked response audiometry, right? Now the true statement is it can differentiate cochlear and retrocochlear lesion. That's the correct statement. And another is it helps to diagnose brainstem pathology in patient of deafness. That is also true. Now moving further, a 9-month-old baby was brought in ENT OPD with complaint of not responding even to loudest sound. Hearing assessment was done, which showed OAE waves were present but no wave on BERA. This condition can be, right? What can be this condition? Here this can be auditory neuropathy, right? Since OAE are present, so pathology is retrocochlear, right? The pathology is retrocochlear. Auditory neuropathy is the condition. Now test for detecting damage to cochlea, except what are the tests, right? 71 caloric test is for vestibular assessment, right? It is for vestibular assessment, right? Renin, Weber, ABC are test of hearing to find out conductive and sensory neural hearing loss, right? So here caloric test, but here the answer is the caloric test, right? Which is for vestibular assessment. And other all Renin, Weber, ABC are for what? Conductive and sensory neural deafness. All are subjective tests for audiometry except, right, subjective test, all are subjective test except, that is our impedance audiometry is an objective test, right. Now impedance audiometry, it does not require what, patient's cooperation, right. This is what, this is objective test. Here the cooperation of subject is not required. Other objective audiometry tests are what, other objective tests are what, OAE, right. Similarly electrocochleography, right, BERA, right, BERA, these are what, these are objective tests where subject's cooperation is not required. Subjective test of hearing is what, pure tone audiometry, yes it is, yes I think pure tone audiometry is only, right. Other all autoacoustic emission, BERA and impedance audiometry, these are what, these are objective tests. Which of the following test is used to detect malingering? That is Stenger test, right, Stenger test. Rennes test was negative in right ear and positive in left ear, which is true. Rennes test was negative in right ear, right, right ear, and positive in left ear, that means right ear, right, positive, that means positive in left ear, that means positive at the left ear is normal or sensory neutral hearing loss, right. Negative is what, conductive hearing loss, it can be like that, right. So the right answer is our profound sensory neural hearing loss in right ear and left ear is normal, right. The left ear is normal, the profound sensory neural hearing loss in right ear and left ear is normal. So the next question is true about the given test is. Now what is this? Here pure tone audiometry is given. Now the true statement is, right, here it requires what, it requires soundproof room, right. Now X does not denote the ear conduction for right ear, it denotes for left ear, right. It is objective test, no, here cooperation of subject is needed, that's why it is subjective test. It needs soundproof room, yeah that's right. Frequency detection of 2000 to 12,000 hertz is done conventionally, no, that's not also right. So next question, if OAE are present, the result is mentioned as, if OAE are absent, so sorry, the result is mentioned as, it is mentioned as refer, right, refer. Reaction time for stapedial reflex is how much? It is about 100 to 200 millisecond. Stapedial reflex, it is 100 to 200 millisecond, right. The patient complaint of decreased, okay, let's leave this question right now, let's move into another question. Negative Rennes test indicates, right, negative Rennes test, now it indicates what, conductive hearing loss, right. So that is CSOM, right. Most reliable test for eustachian tube dysfunction, what is the most reliable test? That is our tympanometry, right. Tympanometry is the most reliable test for eustachian tube dysfunction. Now going further, all of the following are involved in conductive deafness except, all of the following are involved in conductive deafness except what, auricle, it is involved. Vestibular cochlear nerve, let's see, medial ear, yes it is involved. External auditory meatus, it is involved. So vestibular cochlear nerve is not involved, right, it is involved in what, inner ear defects, right. Okay, now moving to our next question, right. The center of stapedial reflex is superior olfactory complex, right, as per as, right, center for superior olfactory complex, right, not superior colliculus, it is superior olfactory complex. Now which of the following belongs to profound hearing loss according to WHO? We have already said greater than 81, right, greater than 81. Now what is intensity of decibel of normal conversation? That is how much? That is 60 decibel, right, 60 decibel. If we whisper, then it is 30 decibel, right, whisper, normal conversation, that is 60 decibel. Similarly if we shout, that is 90 decibel, right. Okay, the intensity of whispering is, we have already said, that is 30 decibel. Maximum hearing loss is caused by oscular damage, tympanic membrane perforation, obliteration of oval window, blockage of ear canal, and that is what, that is obliteration of oval window, we just did it earlier. Recruitment is seen in, right, recruitment is seen in, it is seen in cochlear what, sensory neural hearing loss. Recruitment is seen in cochlear sensory neural hearing loss, right. It is seen in many stages also, recruitment phenomenon, right. Okay, moving further, what we have next is all of the following are feature of cochlear hearing loss except. Now in cochlear hearing loss, sound discrimination is highly impaired, right. Okay, is not highly impaired, right? Sound discrimination. So 90, the right answer is speech discrimination is what? Highly impaired. So this is the right answer, right? It is what? It is not highly impaired. CC test is positive in what? Cochlear hearing loss, right? Cochlear, right? Similarly, otoacoustic emission is absent here. Damage to inner ear and outer ear cells are seen here. Recurrent phenomenon is seen in many diseases, right? We have already said it. Objective test of hearing test is objective, right? Tuning fork test, no. Proton audiometry, no. Tympanometry and speech audiometry, right? And the right answer is tympanometry, right? Objective test of hearing. Other all are subjective. Screening test for neonate ICU is what is it? That is BERA, right? C-shaped curve on tympanometry is seen in. Where it is seen in? It is seen in C-shaped curve, right? C-shaped curve is seen in early stage tube obstruction, right? It is seen in early stage tube obstruction. In that we see C curve, right? Okay. Now hearing loss of 65 decibel. What will be the grade of deafness? 65. Yes, it falls under how much? It falls. Okay. Let's recall 26 to 40, 41 to 60, 61 to 80, and greater than 80, right? It falls under what? Severe, right? It falls under severe. Stenger test is used to diagnose what? It is used to diagnose malingering, right? Non-organic hearing loss, that is malingering. CC is specific for what? It is specific for cochlear conditions. Like now, what are the cochlear conditions? These are Meniere's disease, right? CC for Meniere's disease. The otoacoustic emission are absent when the following is damaged. If outer ear cell is damaged, right? Now, all of the following are feature of sensory neural hearing loss except, right? Renist positive, yeah, that's right. Weber lateral is to better ear, that's right. Swabach test, lengthen and ABC is reduced. So here the right answer is Swabach test do not lengthen, right? It will be shortened, right? Okay. Next question. True statement about otoacoustic emission, right? Spontaneous OAE is absent in 50% normal individual. Absence in retrocochlear lesion. Absence of hearing loss is less than what? 30 decibel. So here sensory neural hearing loss of 45 decibel in, okay, sorry, here the right answer is spontaneous OA is absent in 50% normal individual, right? That is the right answer. Which of the following test does not show negative Renist test in right ear? Which of the following do not show negative Renist test in right ear? Which will not show negative Renist test in right ear? That means here the sensory neural hearing loss, right, 45 degree in left ear and normal in right ear, right, will not show what? Renist test negative in right ear, right? Because for showing what? Negative Renist test in right ear, negative Renist test in right ear means what? Not normal right ear, it is conductive hearing loss. So this is the right answer. Rise of pressure from middle ear to inner ear. The ratio of ear pressure across the tympanic membrane transmission is about how much? It is 22:1, right? True about BERA finding in acoustic neuroma. Latency of wave B is increased in affected ear, right? Okay, in infant, hearing loss above 80 decibel can be tested by, right? Hearing loss above 80, it can be what? It can be assessed by ASSR, auditory steady state response, right? In infant, hearing loss above 80 decibel. Quaternary lever provides how many times? 2 times, right? That's why from 22 times it was reaching about 44 times, right? Okay, BERA is most accurate at how much? It is most accurate? It is most accurate at 34 weeks, right? It is most accurate at 34 weeks, right? Now, true about the given test is, what is this? This is obviously our what? Renist test, right? Renist test. Now here what is right is in normal ear AC is greater than BC, that's right, right? So what is the question asked? Not true about the given test, right? So this is the right statement. In sensory neural hearing loss, AC is greater than BC, that's also right. In severe sensory neural hearing loss, AC is greater than BC, that is what? Not right, right? conductive hearing loss, BC is greater than AC. That's also right. So the C number option is not right. Right. Okay. Now here, a 5-year-old child present with bilateral painless hearing loss for past 10 days. Right. For past 10 days. On examination, tympanic membrane appears dull. His tympanogram finding is given below. Most probable diagnosis is. So here it is what it is. But it is type B cough, right? Type B cough, and tympanic membrane is appearing dull. It might be the case of what? SOM, right? It can be the case of SOM. It is the case of SOM. Not true about the test shown here is, which is not true, right? It is a byproduct of outer ear cells. Yes, it is. Here it is showing autoacoustic emission. Used as a screening test for hearing in neonates. That's right. Disappear in cochlear pathology. Yes, it disappear in cochlear pathology, right? Disappear in earth knob pathology. No, it does not disappear in earth knob pathology. So this is the wrong statement. 6-month-old child developed labyrinthitis following meningitis. You were subjected to test shown below, right? Now, what is test being performed? The test here being performed is beta, right? Beta is performed here. As you can see, this is beta, right? Now here above you see this is autoacoustic emission, right? So now the large perforation in tympanic membrane can cause sound wave to reach oval window and round window at the same time. This will cause hearing deficit due to the loss of what? Phase difference between what? These two, right? Phase difference between two window. This is the right answer. The patient present with unilateral hearing loss, right ear Raynaud's is positive and left ear Raynaud's is negative. Weber lateralizes to right. What is the diagnosis? Right? Okay, the diagnosis here is left severe sensory neural hearing loss. Right? Best time for hearing assessment in infant is how much? During first month, right? During first month, as soon as possible. It is done within 48 hours after birth. Earliest age for doing beta is, right? It is in utero, right? It is in utero. Now, moving to our next question. Now, here this is the diagram, as you can see. Now here, as you can see, this is right. This is below, right? This is below, right? Here you can see this is right here. Red one is right here, right? And it is what in blue one is left here. Now here, as you can see, both ear conduction and bone conduction both are decreased, right? Both are decreased. Okay, let's say now here the answer is bilateral, right? Because right ear and left ear both they are decreased, so it is bilateral conductive hearing loss, right? Bilateral conductive hearing loss. Right ear, compare this right ear with this right ear. Right here you can see earbone gap, right? Earbone gap, right? And earbone gap is seen here, right? And if you'll see the left ear, compare this to left ear in conduction and bone conduction of left ear also, there is also what significant gap. That's why it is bilateral conductive hearing loss. The average hearing at 500,000 and 2000 is 45 decibel in left ear. Percentage hearing loss in left ear is, right? It is how much? It is, how to calculate it? We need to find the average. The average is 45. We just separate it by 25 and multiply by 1.5. And here 20 into 1.5, right? That is what? 30%. Okay, that is 30%. Thick tympanic membrane as seen in tympanosclerosis give rise to what type of tympanogram? Tympanosclerosis, that is AS, right? So AS. So this was all about what? The MCQ point from what? From physiology and test of hearing of ear in ENT. Now the MCQ will be covered from the topic of vestibular physiology and assessment of vestibular function. Now here the first question is true about central nystagmus is. Now before getting into the options, now talking about central nystagmus, right? Peripheral nystagmus and central nystagmus, right? Central nystagmus. Talking about peripheral nystagmus and central nystagmus, right? Direction is what? It is fixed in peripheral, right? It is fixed in peripheral nystagmus, but in central nystagmus it changes, right? It changes, direction changes. And talking about duration, right? Duration, peripheral nystagmus, it is what? It is short time period. It is for short time period, for days, but here it is long time period. That means it will be for weeks, right? And talking about latency, right? Latency. Now latency will be present in peripheral, right, but it will not be present, it will be absent, right. Similarly, fatigability is present what in peripheral, but it is absent in central. So we are clear about direction, right. Direction, where it is changes in central, right. Duration, short and long period. Latency is present in peripheral, it is absent in central. Similarly, fatigability, it is present here and absent there. So here, true about central nystagmus is duration not limited. Duration not limited, just duration, it is for long period of time. Direction is fixed, no, direction is not fixed, it changes. Latency is not present there. Suppressed by visual fixation, no, it is unchanged by optic fixation or visual fixation. So the right answer is duration not limited. Peripheral nystagmus, true is duration not limited, no, it is for short period of time. Duration fixed, yes, it is fixed, right. No latency, no, latency is present there. Vertigo is not present, it is present there. So the right answer here is direction fixed, right. Direction fixed. Nystagmus is associated with all of the following except vestibular disease, it is associated. Vestibular disease, cerebellar disease, it is associated. For in vestibular disease, it is associated. Cochlear disease, in cochlear disease, it is not associated, right. It is associated with vestibular, not cochlear. And Arnold-Chiari malformation, it is associated with that also. Nystagmus and vertigo, right. Vertigo per se are not the manifestation of cochlear disease. Cochlear disease lead to hearing loss, right. So here the right answer is cochlear disease. Similarly, spontaneous pure vertical nystagmus is seen in. Spontaneous pure vertical nystagmus is seen in medulla, right. It is seen in lesion of medulla, right. Okay, now destruction of right labyrinth causes nystagmus to. Now as right labyrinth will go, it will cause nystagmus to left side, right. It will cause to left side. Stimulation of posterior semicircular canal produces what? Torsional vertical nystagmus, right. It will cause torsional vertical nystagmus, right. Torsional vertical nystagmus. Stimulation of posterior semicircular canal. Vertigo of peripheral vestibular origin are all except. Vertigo of peripheral vestibular origin are all except, right. Peripheral origin are all except our what? Meniere's disease, it is also. BBB, it is also. Vertebrobasilar insufficiency, it is not, right. It is not what? It is not of what? Peripheral origin, right. Vertebrobasilar insufficiency. Vestibular neuronitis, it is also, right. So the right answer is vertebrobasilar insufficiency. Other all are what? This vertebrobasilar insufficiency is what? Central vestibular condition, right. The two right. Now the vertebrobasilar artery, right. Okay, now here this is of central, not of periphery, right. Vestibular function is tested by, it is tested by what? It is tested by our what? Our fistula test, right. One is fistula test and another is cold caloric test, right. Vestibular function is tested by fistula and cold caloric test. The acoustic reflex is a part of impedance audiometry, which is test of hearing, right. Talking about vestibular function test is tested by, right. It is tested by galvanic stimulation test also, right. It is tested by acoustic reflex, no, it is not tested by acoustic reflex, right. One is galvanic fistula test, we talked about it. Impedance audiometry, no. Another cold caloric test. So fistula test, cold caloric test and galvanic stimulation test, right. Now cold caloric test stimulates, right. It stimulates what? It stimulates lateral semicircular canal, right. Cold caloric test stimulates lateral semicircular canal. Now at what angle is Helpik thermal caloric test done? It is done at what? At 30 degree, right. It is done at 30 degree. Helpik thermal caloric test at 30 degree. Fitzgerald's caloric test uses the temperature at how much? It uses it our 37 plus minus 7, right. 37 plus minus 7, that means from 30 to 44, right. From 30 to 44, right. Caloric test has slow component, fast component, both slow and fast component. Both slow and fast component is right. In cold caloric stimulation test, the cold water induced movement of eyeball in which of the following direction? Cold, right. COWS, that means cold in opposite direction, right. Towards opposite direction, right. Warm towards same direction. In Fitzgerald's and Hallpike differential caloric test, cold water irrigation at 30 degrees centigrade in left ear in normal person will produce, right? Now here it is saying cold left ear, it is providing in left ear, right? So where it will go, right? It will obviously go cold water, it will go to what? It will go to right ear, right? That means nystagmus will be felt on right side, right? The cold water was being provided on left side. So which of the following is not true of caloric test? Which is not true? Okay, induction of nystagmus by thermal stimulation, that's right. Normally cold water induces nystagmus to opposite side and warm water to same side, that's also right. In canal paresis there is no nystagmus. In canal paresis there is no nystagmus, that's also right. So none of the option are wrong, all are correct. In cold water caloric test, right, if cold water caloric test is done in both meatus, right, simultaneously, then nystagmus will be, right, what will happen to nystagmus? It will be vertical upbeat with slow component downward, right? It will be vertical upbeat with slow component downward, right? In both meatus, if both meatus are irrigated simultaneously with cold water, under normal circumstance the effect within both horizontal semicircular canal is equal and self-cancelling. This eventually cause an upbeating vertical nystagmus, right? Okay, now talking to another question, Dundas Grant apparatus is used for, right? Dundas, it is used for cold air caloric test, right? It is used for cold air caloric test. Now fistula, a test following fenestration operation stimulates, right? Fistula test following fenestration operation stimulates, it stimulates what? Our lateral semicircular canal, right? It stimulates lateral semicircular canal. False positive fistula test is associated with, it is associated with what? False positive fistula test is associated with what? False positive, right? False positive, that means it is what? It is Hanin-Bott, right? Hanin-Bott, that means it occurs when there is what? Hypermobile steps footplate, right? Hypermobile footplate of steps, that is seen in the case of what? Congenital syphilis, right? So the false positive fistula test, right? False positive, that means fistula is what? Fistula is absent but fistula test is positive, right? False positive, that is Hanin-Bott sign, right? It is seen in two conditions, that is congenital syphilis, in which the steps footplate becomes hypermobile, and another is what? In the case of Meniere's disease, right? Okay, now hypermobile steps footplate, right? The Hanin-Bott sign is false positive fistula test when there is no evidence of middle ear disease causing fistula. It is seen in the case of congenital syphilis, right? We already talked about. Positive fistula test during segalization indicate, right? Positive fistula test during segalization indicates what? It indicates erosion of lateral semicircular canal, right? Positive fistula test indicate what? Erosion of lateral semicircular canal, right? Or what we can say is there can be other condition also, that is labyrinthine fistula can be there, right? Labyrinthine fistula, it is what? It is the erosion of horizontal semicircular canal, right? Perilimb fistula can be there. Fenestration operation, right? It can be there. In otological examination, all of the following will have positive fistula test except, right? All will have positive fistula test except dead ear, no, it will not have positive fistula test. Labyrinthine fistula, yes, there will be. Hypermobile step fistula, yes, there will be. Following fenestration surgery, yes, there will be, right? Fenestration surgery following fenestration operation, positive fistula test should be there. Hypermobile step fistula, yes, positive, but false positive will be there, right? Okay, now talking about labyrinthine fistula, yes, positive will be there. So in there will not be what? But there will be not positive fistula test, right? Okay, moving further, positional vertigo is due to stimulation of positional, it is due to posterior semicircular canal, right? Posterior semicircular canal. Okay, Dix-Hellpike maneuver is done for assessing what? Obviously our vestibular function, right? Vestibular function. Now what is the treatment for benign positional vertigo? It is what? It is our what? Canalith reposition procedure, right? Reposition procedure that we do through what? Epley's maneuver, right? Okay, now here latest treatment of EPPB is, that is what, that is our, what is the latest treatment? It is same, that is our Epley's maneuver or repositioning maneuver, right? Epley's maneuver. Now Epley's maneuver is for positional vertigo, right? The vestibular evoked myogenic potential VEMP in sternocleidomastoid muscle detect the lesion of what? Vestibular evoked myogenic potential in sternocleidomastoid muscle detect the lesion of, it will detect the lesion of inferior vestibular nerve, right? Inferior vestibular nerve. True about Henneberg sign is fistula test positive without fistula. That's right, right? Fistula test positive without fistula, seen in congenital syphilis, right? Okay, in which there is hypermobile stress spread. The cold caloric stimulation test, the cold water induces movement of eyeball in the following direction toward opposite side. That's right. Dix-Halpic maneuver is used for diagnosis of benign paroxysmal positional vertigo, right? That's also right. Now moving further, next question is, the person has vertigo without central involvement, right? Cause can be all except without central involvement, that means peripheral can be there, right? Perilimb fistula, it can be there. Meniere's disease, it can be there. Vestibular neuronitis, it can be there, but multiple sclerosis cannot be there because central involvement is not there, right? Given maneuver is used to what? It is used to what? It is used to assess the vestibular function, right? It is used to it is used to assess the vestibular function. What is this? This is Dix-Halpic maneuver, right? Destruction of one semicircular canal lead to what? Destruction of one semicircular canal lead to spinning of world around sensation, right? Now this spinning of world around sensation. Cerebral pathology present with ataxia and dysarthria, right? Central cause of vertigo lead to deficit of cranial nerve, third and what 12th, which are closely associated with brainstem. Now 36, what test is being done here? Now here testing, now here testing vestibulocochlear reflex by injecting cold water is done here, right? By injecting cold water is done here. Now in 37 number, which not true about benign paroxysmal positional vertigo, right? Hearing loss is often present in, which is not true, right? It is often, your hearing loss is not often present, right? It is what? It is not true about benign paroxysmal positional vertigo, right? Hearing loss is often present is the false statement. It is not present, right? Hearing loss is not present. Halpic's maneuver is it helps in diagnosis, yes. Epley's maneuver is used for treatment, yes. Disorder of posterior semicircular canal, yes, it is right. Which of the following procedure is done now for the management of the following procedure? What is this? This is our Epley's maneuver, right? Epley's maneuver. Now it is done for what? For BPPV, right? BPPV. Which of the following is not true of the following test? Which of the following is not true, right? Now induction of nystagmus by thermal stimulation, yes, it is true. Normal cold water induced nystagmus to opposite ear and warm water to same ear is true. In canal paresis there is no nystagmus, that's also true. Stimulates posterior semicircular canal, it is not true, right? Stimulates posterior semicircular canal is not true. It stimulates horizontal and lateral semicircular canal, right? Not posterior semicircular canal. Positive head impulse test is suggestive of injury to semicircular canal and vestibulocochlear tract, right? Positive head impulse test is suggestive of injury to semicircular canal and vestibulocochlear tract. When patient was administered cold water in right ear, the nystagmus was seen toward the left. Which of the following is correct interpretation of the test? That is first, okay, now here the first component is to left, right? The first component is to left because the nystagmus was seen toward the left, so the first component is toward left. Wherever the nystagmus will go, the first component will go there, right? So this was what this was all about, the MCQs point from what? From vestibular function, right? Vestibular physiology and assessment of vestibular function. Now we are going to talk about the disease of external ear, right? MCQ from disease of external. Now ear. Now without delay, let's begin. Cauliflower ear is, the cauliflower ear is, it is due to what? Hematoma of pinna in boxer, right? Cauliflower ear is due to hematoma of pinna in boxer. Now adding some point to it, right? Now boxers, it is also called boxer's ear or cauliflower ear, right? Okay, that's all. Now moving further, cauliflower ear is due to, it is due to hematoma, we are clear about it. The chondritis of oral cartilage is most commonly due to, chondritis of oral cartilage is most commonly due to, it is most commonly here the most common or causative organism is Pseudomonas, right? Pseudomonas. Now fungus causing otomycosis is most commonly, right? The fungus causing otomycosis is most commonly, it is Aspergillus niger, right? Aspergillus niger. Candida is also there, but Aspergillus niger is what? The better option. The fungus causing otomycosis is most commonly. Now here we have got what? We have got Candida, right? We haven't got Aspergillus niger. So here what we'll select? We'll select Candida, right? Most common organism causing otomycosis is Aspergillus, right? Aspergillus niger, right? Followed by Candida. Since Aspergillus is not in the option, so the better answer is Candida, right? Otomycosis is caused by, it is caused by what? It is caused by both, right? Okay. Diffuse otitis externa is also known as, okay, diffuse otitis externa, right? Diffuse otitis externa, it is also called what? It is also called our what? It is also called what? The diffuse. There is one localized and another is diffuse, right? Diffuse. Now this, it is also called Singapore ear or Hong Kong ear or telephonist or tropical ear, right? Now here, right, it is mainly caused by what? Excessive swimming, that is, it is also called swimmer's ear, right? Okay, swimmer's ear. We have already said about different name. Diffuse otitis externa, it is the other name are what? The synonym are Singapore ear, Hong Kong ear, telephonist ear or tropical ear, and it is called by what? Excessive swimming, so it is also called swimmer's ear, right? Similarly, this is the diffuse, right? Diffuse. Now talking about localized otitis externa, the localized is our what? The localized is our what? Furunculosis of external ear, right? That is localized one, right? Okay. Now common cause of otitis externa is, what is the common cause? We have already said, right? Aspergillus, it was there, right? Mcqs, no. Candida, yes, it is. Pseudomonas, it is also there, right? So these three are the common cause of otitis externa. Moving further, malignant otitis externa is caused by, right? Malignant otitis externa. Now it is caused by Pseudomonas, right? Okay, Pseudomonas aeruginosa, Staphylococcus and Aspergillus. So here what I'm saying Staphylococcus, right? Staphylococcus, yes, it is the right answer. Yes, Staphylococcus is here, right? S. albus, no. Pseudomonas aeruginosa, yes, it is also here. And another what we said is Aspergillus, but here it is E. coli. So what are the right answer here? It is what? Pseudomonas aeruginosa, right? And Staphylococcus, right? Staphylococcus, right? So Pseudomonas aeruginosa and Staphylococcus aureus are the two, what? These two are the answer. Malignant otitis externa is seen in, it is seen in what? It is seen in which condition? Okay, now malignant otitis externa, it is mainly seen in diabetic patient, right? In PBQ, if there will be question like diabetic patient with granular tissue, right, and facial nerve palsy. Now if that patient presents with what? Nocturnal otalgia, bloody stain, purulent ear discharge, right, facial palsies, right? Now that is what? That is malignant otitis externa, right? Okay. Now malignant otitis externa is, what is it? It is what? It is malignant otitis externa. The name is simply malignant, but it is not the malignant condition, right? It is what? It is misnomer, right? It is misnomer. Okay, it is not, I have already said it is not the malignant condition. It is caused by fmge, no. We talked about what? Pseudomonas aeruginosa. We talked about what? We talked about Staphylococcus, right? We talked about Aspergillus, right? So it's also not the answer. Blackish mass of Aspergillus, so it can be the answer, right? It can be the answer. Pseudomonas infection in diabetic patient, yes, it is also, it is the answer, right? So here 11 number, what is the most appropriate one? Pseudomonas infection in diabetic patient, is the right answer. Now moving further, we have question number 12. A true statement about malignant otitis externa is, right? True statement about malignant otitis externa. Not painful, I have already said nocturnal pain is there. Common in diabetic and old age, yes, it is true. Caused by Streptococcus, yes. Streptococcus, no. Staphylococcus, right? Staphylococcus. So the right answer is common in diabetic patient, right? Next question. Which of the following is not typical feature of malignant otitis externa? Caused by Pseudomonas aeruginosa, yes, it is right. Patient that usually old, yes, old diabetic patient. Mitotic figure are high, Okay, we don't know about that. Patient is immunocompromised. Yes, that is also right. So here, right, what is the right answer? The right answer is mitotic figure are high, right? This is the right answer. High mitotic figure are suggestive of malignant condition, right? But here malignant otitis externa is not what? Malignant condition, right? Malignant condition. So it is a misnomer. So high mitotic figure are high is a wrong statement. Now malignant otitis externa is characterized by, it is caused by Pseudomonas aeruginosa. Yes, that's right. Malignancy of external auditory canal. No, it is not right. Granulation tissue is seen in floor of external auditory canal. Yes, it is right. And talking specifically, granulation tissue are present at the Johnson of cartilaginous and bony external auditory canal, right? And radiotherapy can be given. No, here talking about the treatment. Treatment is pretty similar. Here we give what? We give oral antibiotic, right? Ciprofloxacin. That is the drug of choice, ciprofloxacin. And similarly, we can give what? We can give piperacillin, gentamicin, and ceftazidime, right? We can give that. And debridement is the what? Is the treatment, right? Now here radiotherapy can be given. It is not right answer. Gallium scan help in monitoring treatment. Yes, it is right. Gallium 67 scan, right? It is sensitive monitoring of infectious, right? Infections. It will sensitive monitor. It will what? It will monitor the infection, right? Now here negative scan indicate termination of treatment, right? For prognosis and follow up, right? Response of treatment, gallium is given. Gallium 67. Right, so it is the, yes, it is gallium scan helps in monitoring. Now along with gallium we also give technetium 99 scan. Now this technetium 99 scan is given for what? For diagnosis. This is this technetium 99 is taken up by osteoblast, right, in osteomyelitis. So it will be seen there, right? It will be seen there. If it is seen there, then obviously the person is suffering from malignant otitis externa, right? So technetium, right, technetium 99 and gallium 67 are the what investigations. So here the option number A, option number C, and option number E are the right answer. Now the facial nerve palsy is seen in, right, we know, right, malignant otitis externa is the right answer, right? Malignant otitis externa, right? Okay, now moving further, right, now what are the facial nerve palsy that it can cause? It can cause facial nerve palsy of 9, 10 and 11th cranial nerve, right? 11th cranial nerve. Now regarding necrotizing otitis externa, all are true except necrotizing otitis externa or malignant otitis externa. These are same thing, right? These are same thing. Caused by Pseudomonas, yeah, that's absolutely right. Surgery never done, except surgery we don't. Okay, let's facial nerve involved, that's right. Common in diabetic, that's right, right? Now here surgery never done is the wrong statement, because what we are doing, we are doing debridement of necrotic tissue, right? We are doing that. So an old diabetic male, right, presented with rapidly spreading infection of EAC with the involvement of bone and presence of granulation tissue. The drug of choice for this condition is, I have already said, the drug of choice is oral antibiotic, right? That is tablet ciprofloxacin, right? Ciprofloxacin, not just ciprofloxacin is the drug of choice. That is 500 to 750 mg 2 times a day for 2 to 6 months, right? This is the right answer. Now 60-year-old male, diabetic patient presented with extremely painful lesion in external ear and otorrhea. There is evidence of granulation type tissue in external ear and bony erosion with facial nerve palsy. Right, here we have got the necessary clues, right? Bony erosion is there with facial nerve palsy, right? Granulation tissue is there and diabetic patient is there. That is also of old age. That means obviously that is malignant otitis externa, right? Okay. Now moving further, we have another question, that is an elderly diabetic male presented with severe pain, right, in ear. On examination he found to have granulation in external ear. Yes, given blood, right? You can see granulation tissue on the external ear can be seen here, right? Granulation tissue on external ear can be seen here. Now conductive deafness and facial palsy is also seen here. He was found to be having increased uptake of technetium 99, right? Technetium 99. Obviously this is the case of what? This is the case of what? Malignant otitis externa only, right? Malignant with middle ear infection, since conductive hearing loss was there, right? Conductive hearing loss was there. So what we can say? We can say this is what? We can say malignant otitis. Okay, now conductive loss is also seen in external auditory external ear infection. So here there is no enough evidence for middle ear infection, right? So here what we can say is from this technetium, right, and this diagram we can say is that it is malignant otitis externa, right? This is clear-cut case of malignant otitis externa. For early diagnosis, technetium 99 scan is used, right? Technetium 99 scan is used, and technetium 99 we have already said it is taken up by what? It is taken up by osteoclast and osteoblast that indicate bone erosion, right? That indicates bone erosion, right? Now it is found in otitis externa. Okay, now moving further, next question, that is otitis externa hemorrhagica is caused by. Now here the otitis externa hemorrhagica, right? Now this otitis externa hemorrhagica is caused by what? It is caused by influenza, right? Virus. Myringitis bullosa is caused by. Now this myringitis bullosa, right? Myringitis bullosa, it is caused by bacteria, right? Now talking about this otitis externa hemorrhagica, right? Otitis externa hemorrhagica, it is also called bullous meningitis, right? It is also called bullous meningitis, right? And its causative organism is what? Our what? Influenza virus, we have already said. It is also caused by mycoplasm, right? Now here bulla filled with serous and hemorrhagic fluid, right? That is on tympanic membrane, right? Okay, now meningitis bullosa, right? Meningitis bullosa, it is also the same thing, right? Now here otitis externa hemorrhagica is caused by influenza, but bullosa it is caused by bacteria, right? Moving further, direction of water jet while doing syringe or syringing of ear should be. Now what is the direction of what water jet? That is, the direction of jet is posterior superiorly, right? Posterior superiorly. One important thing I would like to add up here is while doing syringing of ear, right? Okay, while doing syringing of ear, there can be what? There can be what? Our reflex, right? Reflex cough can be there. That is because of what? Arnold knob, right? Not because of internal laryngeal knob. Okay, moving further, dysfunction of tympanic membrane is characterized by. Dysfunction of tympanic membrane is characterized by normal cone of light. It is seen in normal also, right? Retracted tympanic membrane, it can be the answer. Not purulent umbo, no, it is found in normal also. Prominent malleolar fold, right? So now here dysfunction of tympanic membrane is characterized by all except here it is asking that dysfunction of tympanic membrane is characterized by all of the above, just leaving one, right? So retracted tympanic membrane, it indicates dysfunction of tympanic membrane. Non-prominent umbo, it represents prominent malleolar front, it represents. So normal cone of light is found in normal individual, it is not found in someone with dysfunctioning tympanic membrane. Feature of moderately retracted tympanic membrane are all except, right? Are all except. Handle of Malleus appears 4 short-sighted, right? Yes, 4 short-sighted. Handle of Malleus is 4 short-sighted in the case of retraction, right? Cone of light is absent or interrupted. That's also right. Cone of light is absent or interrupted. Lateral process of Malleus become more prominent. Lateral process, yes, it becomes more prominent, right? Shiny pearly gray tympanic membrane. So shiny pearly gray tympanic membrane, it is what it is, the feature of normal, right? Normal tympanic membrane. So here this is what? This is the answer, right? Other all indicates retracted tympanic membrane. Now here talking about retraction of tympanic membrane, right? Retraction of tympanic membrane. Okay, we'll talk about that later on. Now moving further, right? Moving further, what we have is, we have which of the following is false about tympanic membrane? Cone of light is anterior inferior, that's right. Sharpness membrane is also known as pars process, that's right. Yield perforation has 3 layers, no, it has just 2 layers, right? The middle fibrous, the strong layer is not present there. And tympanic membrane attachment to tip of malleus and yes, handle is called umbo. Yeah, that's right, right? Okay, chalky white tympanic membrane is seen in. Chalky white tympanic membrane is seen in what? It is seen in tympanosclerosis. Keratosis obturans, right? Keratosis obturans. What is keratosis obturans? Right now, keratosis obturans is desquamated epithelial cells, right? It is desquamated epithelial cells, right? Keratosis means what? Epithelial cells, right? Production of epithelial cells. So here keratosis obturans is what is it? Is what? Desquamated epithelial cells, right? Okay. Now 60-year-old male presented with left ear discharge, right? It is present with left ear discharge for past 7 years with dull ear rack. On examination, tympanic membrane on both side with discharging discharge coming out from posterior canal wall on left side. Hearing is normal. Diagnosis is, now here what it is saying is, right, what it is saying is there is 60-year-old man presented with left sided discharge for past 7 years with dull earache. On examination, there is intact tympanic membrane on both sides with discharge coming from posterior canal wall on the left side, right. Here the left side, from left side there is discharge coming on. The hearing is normal. Now here what is the diagnosis? The diagnosis is keratosis obturans, right. The diagnosis keratosis obturans. Why? Because since tympanic membrane is intact, right, so it cannot be chronic suppurative otitis media, right. Tympanic membrane is intact, right. And another is otitis externa is an acute condition, right, but here the condition is lasting for more than 7 years. And carcinoma of EAC, right, talking about carcinoma of EAC of such long duration will not remain localized, right, it will what, it will metastasize to different site. That's why. Now moving further, the focal length of mirror used in head mirror. What is the focal length? The focal length is 250 mm, right. What is the focal length? That is 250 mm or 25 centimeter, right. And diameter of head mirror in ENT is, it is 9 centimeter. The focal length of mirror used is 25 centimeter focal length is, but the diameter is how many? 9 centimeter, right. Use of Siegel's speculum during examination, right. Examination of ear provides all except. Use of Siegel's speculum during examination of ear provides all except magnification, okay. Yes, it provides magnification, right, it provides magnification. Assumption of movement of tympanic membrane, yes, it can be done. Removal of foreign body from the ear, okay, it is doubtful because it does not remove, right. As applicator for powder antibiotic of ear, yes, it can be used to apply powder as antibiotic into ear also. So the removal of foreign body from ear is the appropriate answer. So the use of Siegel's speculum during examination of ear provides all except removal of foreign body from ear. That's right. Okay, talking about another question, the most common organism, right, the most common organism causing skull based osteomyelitis is. Now what is the most common organism causing skull based osteomyelitis? So the most common organism is pneumococcus, no sorry, it is Pseudomonas aeruginosa. That is what was causing our external what, otitis externa, right, it is Pseudomonas. Okay, now another, external ear not washed with water in the presence of lead, okay. In lead we do what wash, in wax also we do wax, in animate object also we do wash, okay. In animate object we do wash, right, okay. In EAD, that is not lead, EAD, in vegetable matter and in lead battery we don't wash external ear with water, right, we don't wash it because lead battery, it may what, it may be damaged, it may leak, right, causing more further destruction. Vegetable matter, they may what, they may give rise to what, growth of different microorganisms because of its decomposition. That's why. Now next question is, which of the following is false regarding malignant otitis externa, right. ESR is useful in monitoring of response to antibiotic, okay, it is, right. Sensory hearing loss is common presentation, okay. We are not sure, we are not known about it, right. Sensory hearing loss, we are not sure about it. Common in diabetes, yes, it is common in diabetes. Granulation tissue in external ear canal, yes, all are right, but the sensory hearing loss is common presentation is not the right answer. Child with battery as foreign body in nose, which of the following is an important concern? Refer to specialist and plan for electric removal. Local release of chemical from battery and destruction of tissue, yes, it is the concern. What? It is the concern, what concern, important concern, that local release of chemical from battery and there may be destruction of tissues, right. Okay, now moving further, impaction of wax is treated by, okay. Now syringing, we don't do directly syringing, right, by directly syringing it will not come out. So what we do initially is we just do softening followed by syringing, okay. All of the following are risk factor for malignant otitis externa except diabetes, yes, it is very important risk factor. Immunodeficiency, yes, it is. Parotitis and chemotherapy, so here parotitis is the appropriate answer because the individual undergoing chemotherapy has also immunodeficient condition. That's why. Now here the next thing is, most common cause of otitis externa is, what is the most common cause of otitis externa? And here the bacterial infection is the most common cause because we talked about 3 bacteria, right, okay, 3 bacteria. What are they? Pseudomonas aeruginosa, aspergillus, right, and then we have got Staphylococcus. Now given the given appearance of pinna is suggestive of. Now what is this? This is what we were talking about, the cauliflower appearance, right, after hematoma. So it is what? Due to Pseudomonas infection? No. Aspergillus infection? No. Post-traumatic? Yes. Post-traumatic, that is boxer's ear, right? Post-traumatic. Now the retraction of tympanic membrane lie on promontory with intact middle ear mucosa. What is the Sears grade, right? Now here talking about Sears grade, right? Sears grade of retraction of what? Tympanic membrane. Now tympanic membrane is lying on tympanic membrane is lying on promontory with intact middle ear mucosa. So it is what? Grade 3, right? Grade 3. Now here if it touches promontory, right? Promontory, that is grade 3, right? Now another is if it is adherent to promontory, then that is grade 4, right? If it is adherent, that is grade 4. Now here similar question, retraction of tympanic membrane with tympanic membrane adherent to promontory with no middle mucosa, no middle ear space remaining, it is called what? Now here question number what? It is our, right, 43. Now here that is what? That is adhesive otitis, right? Otitis media, right? Here it is type 4, right? Type 4, stage 4, right? Let's say the tympanic membrane is adherent to promontory, right? Adherent to promontory, that's why it is adhesive otitis media. Now talking about Sears classification, right? There are 4 Sears classification, right? 1, 2, 3 and 4. Okay, we'll get it in later on. Now here another question, 65-year-old diabetic patient with necrosis of external auditory canal with foul smelling discharge. The probable organism causing this condition is, we are sure it is what? Pseudomonas aeruginosa, right? Okay, Pseudomonas aeruginosa. Now moving further, what we have next question is foreign body in ear is not true is, foreign body in ear not true is, most common site is medial to isthmus. It can be, right? Syringing is not done for vegetable and foreign body, yet it is true. Syringing uses room temperature water directed at eardrum. No, it does not use room temperature. What it uses is, it uses the body temperature water, that is 37 degrees Celsius. And right now in vegetable, right, in vegetable foreign body syringing is not done, right? Syringing is not done because it may get swollen up and therefore it may get further more stuck up, right? No, syringing is avoided there. Now we have already done it. Adherent, it is what? It is adhesive otitis media, right? Which of the following is false regarding malignant otitis externa? ESR is useful in monitoring the response to antibiotic, as is true. Sensory neural hearing loss is common presentation. No, it is not, right? And common in diabetes, it is true. Granulation tissue in external ear canal, that is also true. Malignant otitis externa is, what is malignant otitis externa? Malignant condition? No. Pre-malignant condition? No, it is also not, right? Infective condition? Yeah, we can call it infective condition, right? And another question is, what is the next question? Autoimmune condition. So it is infective condition. What is it? It is infective condition. Now moving toward next question. 46. The life-threatening condition in diabetic patient is, it is malignant otitis externa only, right? Now here the other are also life-threatening condition, right? But malignant otitis externa is what? It is what? It is serious, right? It is serious one. Now moving further, right, now true about skull base osteomyelitis are all except frequent oral toileting is required. Is it here? It is talking about skull base osteomyelitis. Here it is talking about what? It is talking about our external otitis, what? Otitis externa only, right? Necrotizing otitis externa, or what? External otitis externa. Now here it will further on what? Osteomyelitis, right? When it enters into EAC, right, it will spread out of fissure of Santorni, right? Fissure of Santorni, and then it will cause cellulitis, chondritis, periostitis, osteitis, and finally osteomyelitis involving Haversian system, right? Now it will spread across skull base, right, involving cranial nerve, right? That's why it will cause skull base osteomyelitis, right? Okay, now here frequently oral toileting is required. No, we did not talk about that, right? High uptake on bone scan, yes it does. Cause pain in ear, yes it does, right? Most common organism Staph aureus and Proteus mirabilis. No, it is absolutely wrong statement, right? Proteus mirabilis is not the causative organism, right? Okay, now next question is, the most common cranial nerve palsy in malignant otitis externa is, we said from how much, right? We said that it is responsible for causing what? Facial palsy, right? Palsy on what? 9th, 10th, 11th knob. So facial palsy, right? Facial palsy, that is by facial knob, right? 7th knob, that is the appropriate answer. Patient present with pain and discharge in ear. On examination, the ear shows the following he is managed by. So here it is also what it is. It is also the it is also what it is our what malignant otitis external. So drug of choice is ciprofloxacin. Now ciprofloxacin, right? What we said? It said that it is what it is our what ciprofloxacin. Ciprofloxacin is oral antibiotic, but here we have got ciprofloxacin ear drop. So ear drop, it is not that, right? And clotrimazole ear drop. So here clotrimazole ear drop is the appropriate answer, because ciprofloxacin we provided oral, right? Okay, now moving to our next question. Correct about the shown picture is, now here it is showing about syringing. So the ear is pulled up, right, backward, and syringe is done posterior superiorly, right? The option number A is correct. Now oral myiasis, right? Oral myiasis is, what is myiasis? Myiasis is what? The myiasis is maggot in of ear, right? Maggot is present in ear. Now the irrigation of ear canal is done to remove wax or foreign body fluid. Used should be of body temperature, that is 37 degrees Celsius. So that's all about what? That's all about the question from our external ear, right? Disorder of external ear. Okay, now here the topic we are covering is, we are going to talk about acute, right? Acute infection of middle ear, right? Now here the throat infection can cause ear infection through, that is eustachian tube, right? The commonest causative organism for ASOM, acute suppurative otitis media, in 2-year-old child is, right? Talking about the common organism, that is Streptococcus pneumoniae, that accounts for 30%, and that is also called what? Pneumococcus, right? Streptococcus pneumoniae, right? The commonest cause of acute otitis media in children is, I've already said, Streptococcus pneumoniae, right? Pneumoniae, or what? Pneumococcus. Cartwheel sign is seen in ASOM. ASOM consists of how many? 4 different stages. Now the first stage is stage of what? Stage of tubal occlusion, right? Tubal occlusion or hyperemia, right? And another is stage of what? Stage of pre-suppuration. Similarly, another is stage of suppuration, and then stage of what? Resolution, and another stage of complication. Now stage of suppuration is divided into these two stages: stage of resolution and stage of complication. So how many stages? Stage of tubal occlusion, stage of what? Pre-suppuration, suppuration, right? Suppuration, and stage of resolution, and stage of complication. Now here, out of this stage, the Cartwheel sign is seen in what? It is seen in what? Our suppuration, pre-suppuration, and in suppuration there is nipple sign, right? There is nipple sign. Okay, and talking about in resolution, there is positive lighthouse sign. So ASOM, 4 stages: stage of tubal occlusion, stage of what? Pre-suppuration, stage of suppuration, and then stage of what? Resolution, right? Resolution, and stage of complication. Now in stage of pre-suppuration, what is seen? Cartwheel sign, right? Stage of suppuration, nipple sign. In stage of resolution, what is seen? There positive lighthouse sign, right? Positive lighthouse sign. Okay, now here the most common perforation site in tympanic membrane in ASOM is, what is the most common site of perforation in ASOM, right? The most common site is anterio-inferior, right? Anterio-inferior. Going further, lighthouse sign is characterizes what? ASOM, right? But already says in ASOM also what? There is stage of resolution in which it is seen. Pulsatile otorrhea is seen in pulsatile otorrhea, right? Otorrhea. Now here it is talking about pulsatile otorrhea, right? Pulsatile otorrhea is seen in ASOM, but similarly pulsatile tinnitus, it is seen in what? Glomus tumor, right? Lighthouse sign is seen in ASOM in which stage? We have already said it is seen in what? Okay, it is seen in stage of, okay, lighthouse sign we say that in resolution, right? Stage of resolution, but here it is given the stage of suppuration, right? Suppuration, but here the lighthouse sign is seen in the stage of resolution, right? Myringotomy is what? Tomy, right? Myringotomy, that means tympanic membrane, what we are doing, what? Surgical opening in tympanic membrane, right? Similarly, myringotomy is indicated in, it is indicated in ASOM, right? ASOM, right? Now in ASOM myringotomy is indicated, and it is what also done in what, in serous otitis media, right? But there are in serous otitis media what grommet incision is done, right? In serous otitis media, right, there the incision that is given is on different side. Now, right, posterior superior region the incision is given, but anterior inferior, okay, we will see that, will come into that also, right? Okay, just let me see. Okay, now in ASOM myringotomy is done in what, myringotomy is done in posterior inferior, right, in posterior inferior region, right, in ASOM posterior inferior, and that is also in curvilinear or J-shaped manner, right? But talking about SOM, it is done where? It is done in what? In SOM it is done in anterior anterior superior, right? Anterior and in anterior superior region, and here it is done in radial, but in radial format, right? It is done in radial format. Okay, ASOM posterior inferior quadrant, right? But in SOM anterior inferior quadrant, right? Anterior inferior quadrant. Okay, now moving further, for ASOM myringotomy is done in which quadrant? Or just now we talked about in ASOM it is done where? In posterior, what? Posterior superior or posterior inferior? Posterior inferior, right? In what? Curvilinear or J-shaped manner, right? In curvilinear or J-shaped manner, that is posterior inferior, right? Similarly, what? Anterior inferior was done in SOM, right? SOM, that is serous otitis media, right? In anterior inferior region. A 3-year-old child presents with fever and earache, right? On examination there is congestion with slight bulging of tympanic membrane. The treatment of choices. Now here what we can do initially is the child is suffering from what? The child is how many year old? 3-year-old, present with fever, earache, and on examination there is congested and slight what? Bulging of tympanic membrane. The treatment of choices, here we don't go directly into myringotomy, we initially provide oral antibiotic and decongestant, right? And we just observe what will be the result after how many, if the earache will what it will resolve or not after 2 to 3 days, right? Now if earache persists, right, then we give second antibacterial, and after that also if it persists, then we go for myringotomy only, right? Okay, now moving further, 7-year-old child presented with acute otitis media, right? Acute otitis media does not respond to amoxicillin clavulanic acid. Examination revealed full and bulging tympanic membrane. The treatment of choices. Now here it is not responding, right? It is not responding. That's why what we do? We do myringotomy here, right? We do myringotomy here. Now myringotomy where? In what? In posterior inferior quadrant, right? Curvilinear or J-shaped. Okay. The acute suppurative otitis media ASOM is treated by using all except. Now here. Okay, now here we provide erythromycin also, penicillin also, cephalosporin also, but we don't provide streptomycin, right? Streptomycin is aminoglycosides and used in anti-tubercular treatment, right? Anti-tubercular treatment, that's why. Okay, now here treatment of true statement about ASOM is most frequently it resolves without sequel, right? Commonly it commonly follows painful parotitis. Radical mastectomy is required for treatment, right? No, it is not right. Common organism is Pseudomonas. Okay, the most common organ is what? Streptococcus pneumoniae, right? We already said that. So here the true statement is most frequently it resolves without sequelae, right? Most frequently it resolves without sequelae is the true statement. Incision on tympanic membrane is called incision, right? Incision in tympanic membrane we call what? We call myringoplasty, myringotomy, tympanoplasty, or fenestration operation. That is myringotomy, right? Myringotomy. Now image based question, right? A 3-year-old child presented with fever and earache. Endoscopic appearance of tympanic membrane is shown below. The treatment of choices. Now here there is fever and earache to 3-year-old child. So here what we can do here is we can consider is at the case of ASOM, right? Now here the treatment of choice is oral antibiotic, right? We initially give oral antibiotic and we see if it persists or it resolves by providing it, right? And that's all, right? Now here directly we don't go for myringotomy, right? Now another question, the following type of incision on treatment of tympanic membrane. Here it is giving in what? It is given in it is anterior inferiorly, right? Is it anterior inferiorly? Yes, it is. No, it is posterior inferiorly, right? Posterior inferior, because here it is what, it is which tympanic membrane, right or left? Now here, as you can see, the cone of light is lying on 7 o'clock, right? 7 o'clock, so it is left side of tympanic membrane, right? Left side of tympanic membrane. So here in cone of light region, that is anterior inferior quadrant, but here the incision is in posterior inferior, right? And posterior inferior incision is given where? In ASOM, curvilinear or J-shaped, right? Okay, if here there was incision, then that would be called what? That would be in anterior inferior, that is in SOM, right? Serous otitis media. That's all. Now, okay, this was all the question about what? Acute infection of middle ear. Now we are going to cover the MCQ from serous otitis media, right? Now before getting into serous otitis media's MCQ, now what are the other synonym for serous otitis media? It is also called what? It is also called glue ear, right? It is also called what? Serous otitis media, I've already said. It is also called mucoid otitis what? Media. It is also called what? It is also called catarrhal otitis media, right? Similarly, exudative otitis media and secretory otitis media are its name, right? So glue ear, it is what it is. Here it is talking about what? Serous otitis media only. So here glue ear is painful, painless, radical mastoidectomy is required, right? Sodium fluoride is used. Now here talking about serous otitis media, here it is not painful, it is painless, right? It is painless. Here the clinical presentation will be child will what? He will not present as he will not present in painful condition, right? Here pain is not present there. Here the child has to sit in front of the bench in school, right? Hearing will be decreased. Here his parents give history of decreased academic performance. He turns TV in very loud sound, right? And he cannot concentrate well, and now the child has delayed and defective speech. So that are the clinical presentation, how the serous otitis media patient presents in hospital. The boy with ASOM underwent treatment for same, now present with subsidence of pain but persistent of deafness, right? Pain has already removed, right? No pain, but the deafness is present there, right? Deafness is present there. On examination, tympanic membrane appears dull, the diagnosis is, right? On examination, tympanic membrane is dull, right? Now here obviously, right, no pain, but deafness is there. It is boy, right? Child. That's why secretory otitis media, right? Secretory otitis media, right? That's the right answer. Okay, now moving further, right? Blue eardrum is seen in. Now here talking about in serous otitis media, there is what? There is blue what? Tympanic membrane, right? On examination we find blue tympanic membrane, right? Now moving further, unilateral non-suppurative otitis media in adult is due to the secretory otitis media is what? It is what? It is it is non-suppurative, right? Now here the unilateral non-suppurative otitis media in adult is due to, it is in adult it is due to what? Malignancy, right? In adult it is due to malignancy. In any adult presenting with unilateral non-suppurative otitis media should be investigated for nasopharyngeal carcinoma, which might be obstructing the particular side on eustachian tube, right? Okay, now all are false in case of secretory otitis media except, that means here it is asking about true statement, right? Red tympanic membrane, no, it is not red. Blue it is. B-shaped tympanogram, yes, it is right, right? In tympanogram B, right? From B we said that we will remember it as what? Bogne, right? Bogne. So B for Bogne, and in serous otitis media inside there is what? There is fluid. It will what? It will Bogne, it will Bokcha. So B type, right? And talking about, so the right answer is B type tympanogram is seen. And marginal perforation, most common, there is no perforation, right? And Raynaud's test positive, no, Raynaud's test is negative because it is conductive hearing loss, right? So it is negative. Now a 55-year-old man presented with unilateral conductive hearing loss, fullness sensation in ear, no discharge, tympanic membrane is normal, tympanometry shows B type of graph, right? Graph. What is the next step of management? So obviously directly it is what? It is serous condition, serous otitis media, right? Now here, since it is adult, right, 55 years old, what we said, we will evaluate for what? We will suspect malignancy, right? So here what we do is evaluation of nasopharyngeal mass, will do that, right? Evaluation of nasopharyngeal mass will be done. Now moving to our next question, right? Now moving to our question number 7. Now talking about question number 7, what is the question? The cause of unilateral secretory otitis media in adult is, same question, right? Nasopharyngeal carcinoma, right? Now secretory otitis media is diagnosed by, how it is diagnosed? It is diagnosed by, we already said that in tympanometry there will be type B curve, right? But here there is no tympanometry. Impedance audiometry is there, Puton audiometry is there, X-ray and otoscope is there. So here what we can use here is the patient presenting with painless blocked feeling of ear in subacute fashion. On otoscope, right, there will be what? There will be on otoscope, what will be there? Tympanic membrane will be dull, retracted and shows fluid level or ear bubble, right? And here SOM is the diagnosis, right? So here the Puton audiometry shows conductive hearing loss of approximately 20 to 25 decibel, right? 20 to 35 decibel, which can be seen in complete obstruction of EAC or in tympanic membrane perforation. So it is not used here. So impedance audiometry and otoscope are the what are the investigation here. In otoscope we have already said dull, right, blue tympanic membrane is seen, loss or loss of light reflex is seen. Okay, now moving into next question. The next question is, in secretory otitis media, which one of the following statement is true? Right, now here sensory neural deafness occurs? No, it does not occurs, right? And sensory neural deafness does not occur, right? Intracranial spread of infection complicates the clinical course? No, it also does not occur. Tympanostomy tube are usually required for treatment. Tympanostomy, yes, it can be right answer, right? Now gram positive organism are grown routinely in culture in the spirates? No, so the right answer is, right, tympanostomy tube are usually required for the treatment, right? So sensory neural deafness, no. SOM lead to conductive deafness, right? Now SOM does not lead to what? Intracranial complication, right? Now so here myringotomy or opening of what? Tympanostomy, right, tube, or opening of eustachian tube is the what? The management, right? That's all. Now the following statement are true about otitis media with effusion in child. Immediate myringotomy is done. Is it done? No, it is not done, right? Type B tympanogram, yes, that is right. The effusion of middle ear is sterile, yes, that is also right, right? That is also right. The most common deafness, it is the most common cause of deafness in children in daycare patient, that is also right. So B, C, D are the right statement. The treatment of choice for glue ear is myringotomy with cold knife, myringotomy with diode laser, myringotomy with ventilation tube insertion. So the 11C is the right answer. Ventilation tube insertion is also required, right? Grommet insertion with myringotomy is done yet. Where it is done, right? We have already said yes, OEM, it is done where? It is done anterior inferiorly, right? So the right answer is anterior inferior quadrant. Grommet tube is used in serous otitis media, we know about it, right? So that's the answer. Procedure for serous otitis media is, what is the procedure? That is myringotomy, right? Myringotomy. To do myringotomy in ASOM, the incision is given in posterior inferior region, we know that. That is preferred region for all of the following region except it is easily accessible. Yeah, that's right. Damage to ossicular train does not occur, that's also right. Damage to chora tympani is avoided, that's also right. It is least vascular region is not right, it is most vascular region, right? That's why, right, it is most vascular region, and here healing is so well, right? Healing will happen so well, that's why it is not least vascular region, it is the most vascular region, right? Cause for grommet insertion, what is the cause for grommet insertion? That is our secretory otitis media, right? Okay, moving further. A child has adenoidectomy done but has effusion in middle ear. What is done next? The next, it is what? We do myringotomy and we insert grommet, right? That's the answer, grommet insertion. Now moving further, 6-year-old child present with recurrent URTI with mouth breathing and failure to grow with high arched palate. Impaired breathing is present. His tympanogram finding is given below. It should be managed by, it is what? It is type B, right? Type B, right? Now here it should be managed by what? Myringotomy with grommet insertion, right? Myringotomy with grommet insertion, right? Okay, sorry, it is not mentioned, he is not managed by laryngotomy and grommet insertion, because here if you see clearly there is mouth breathing, right, and high arched palate. So these are the sign of what? These are the sign of hypertrophy of adenoid. So what we do, here the child is suffering from adenotonsillar hypertrophy, right? Here the child is suffering from adenotonsillar hypertrophy, which is causing recurrent URTI, right? So here what we do is we do adenoidectomy with grommet insertion, right? It is understood that grommet has to be put by radial mastectomy in anterior inferior quadrant. So the right answer is adenoidectomy with grommet insertion. Sorry. Okay, talking about question number 19. The child presented with recurrent respiratory tract infection, mouth breathing and decreased hearing. The treatment is, now again the same thing, right? Now here the child is presenting with recurrent respiratory tract infection, right? Mouth breathing. So here the child is what? The child can be managed, treated by what? We already said adenoidectomy and laryngotomy can be done, right? But along with laryngotomy we also need to do grommet insertion, right? And tonsillectomy can be also done, because it can be also because of tonsillitis. So A, B, C, D all are right answer. Now here the child is most probably suffering from what? Adenotonsillar hypertrophy, right? That's why. Now moving further, question number 20. Autophony is seen in which condition of eustachian tube? Autophony, right? Now autophony is seen where? It is seen either in blocked eustachian tube, right? It is seen blocked, or it is seen in eustachian tube dysgenesis, patulous eustachian tube, retraction of eustachian tube. It is seen in patulous eustachian tube, right? Autophony is seen in patulous eustachian tube. Okay, moving further, all are tests to check eustachian tube patency except Valsalva maneuver. Yes, it is used. Fistula test, no, it is not. It is used for vestibular what? It is used for what? Used to assess what? Vestibular functions, right? Fistula test. So it is not. Frizzle maneuver, yes it is, right? 20B maneuver, it is also used. So fistula test is test of vestibular function. Eustachian tube get blocked if pressure difference is more than 90 mm of Hg S2, right? 90 mm of S2. That is when eustachian tube get blocked. Now another question: at what atmospheric pressure gradient barometric otitis media occur, right? Gradient pressure, gradient barometric otitis media occurs. Now it occurs when there is 90 mm of Hg, right? Now when there will be blockage of eustachian tube. Now otitic barotrauma resolves due to what? Now otitis barotrauma, that is due to descent in ear, right? D4 descent, D4 destruction, right? Otitis barotrauma occur due to descent in ear. Child presents with barotrauma pain without middle ear inflammation. The treatment is, what is the treatment? The treatment is simply what? Supportive treatment, right? Barotrauma, we provide supportive treatment. After what duration of medical management in SOM laryngotomy is done? It is done how many? After how many? After 3 months, right? After 3 months, we just wait and watch. About how many? 3 months, right? Now after 3 months, if the criteria are matched, right, like effusion persists for more than 3 months when bilateral case, or 6 months when unilateral case, right? At that time there is significant hearing loss of greater than 25 decibel, or speech or language delay is there, right? Complication like otitis, meningitis or impeding cholesteatoma formation are there. Then at that time, if these criteria are met, then only we do laryngotomy, right? There are several criteria, but in the case of unilateral, 6 months is what? The duration, and in the case of bilateral, 3 months the duration. Hearing loss should be greater than 25 decibel, speech and language what? Delay should be there, complications should be there, right? All of the following are tests for patency of eustachian tube except Valsalva test, yes it is. Caloric test, right? Caloric test, it is not, right? Is the caloric test? No, caloric test is for what? It is also assessing what? For assessing vestibular function, right? Tympanometry, it is. Pollutzer, it is. Ventilation tube is put in ear in the case of ventilation tube, right? That is in the case of serous otitis media, right? Serous otitis media. During flying an aeroplane, barotrauma occurs with, yes, D4 what? D4 descent and D4 what? Dangerous, right? Okay, glue ear is also known as serous otitis media. It is called that, right? Suppurative otitis media, no. Acute meningitis, no. Acute suppurative otitis media, no. Serous otitis media is the right answer, right? 7-year-old child presents with bilateral hearing difficulty for 3 months. Impedance audiometry shown B type of curve. There is bilateral conductive hearing deficit. There is no sign of infection. The next step is what we do. Obviously, we give what for 3 months, right? Already 3 months has passed, right? Now, what we are going to do here is we are going to give myringotomy and chromate insertion. That's all, right? Now, moving further, in the given condition, which of the following statement is true? Now, here if you'll see, ear bubble like structure are seen on what otoscopic finding. Now here, now here, the tympanostomy tube are usually required for treatment. That is what chromate insertion is usually required, right? Okay, the eustachian tube function is best assessed by. It's best assessed by what? It is best assessed by our what? Obviously tympanometry, right? Tympanometry. Now, in child with serous otitis media, hearing loss is typically how much? It is 20 to 40 decibel, right? 20 to 40 decibel. Now, Renee's test can what? It can be give its negative value if the hearing loss is about 10 to 15, right? And Weber lateralizes at around 5 decibel change, right? 5 decibel change. That is also important. What numerical value we need to remember? The most reliable method of detecting otitis media with effusion is, what is the most reliable method, right? The most reliable method is our what? That is tympanometry, right? That shows type B. True about chromate insertion. What is true? It is a small plastic tube aerating the middle ear, right? Ventilating the middle ear, right? And another is, now healing occurs spontaneously after extrusion, right? Healing occurs spontaneously after extrusion of what? Chromate. It is placed anteriorly on tympanic membrane, right? It is, here we are talking about SOM. In SOM it is placed, okay, when chromate is usually placed on what anteriorly on tympanic membrane, and surgery is always needed to remove it. No, that's not right, right? Question number 37, the treatment of choice for glue ear is, right? We have already said what is the treatment of choice. Now here, myringoplasty, no. Decongestant and anti-allergic, steroid drop, low power hearing aid. So here decongestant and anti-allergies are the treatment of choice for glue ear. Now image based question. Now okay, now what we're doing here, type of incision. What is the type of incision? The following type of incision is given where? It is given in SOM, right? SOM. Now where it is giving? It is giving anterior where? Inferiorly, right? Inferiorly. The following are used in, these are the chromate, they are used in SOM, right? Okay, this was all about what? Question on what? Our serous otitis media or glue ear or secretory otitis media, right? That's all. Now we are going to talk about what? The MCQ point from what? True, from what? From safe CSOM, safe chronic suppurative otitis media, or also it is what? It is tubotympanic or benign condition, right? Now here, true about safe CSOM is, now here true about safe CSOM is, here the etiology is multiple bacteria, right? CSOM is caused by mixed aerobic and non-aerobic organism, right? It is caused by what? The most common organism is Pseudomonas, right? Other include Proteus, E. coli, Staph aureus, right? And like there are what? Multiple what cause of CSOM, safe CSOM, tubotympanic disease. Oral antibiotic are not effective. These are what? Oral antibiotic are not effective, right? These are not effective here because these are simply given to control the infection once the ear is dry, and after 6 weeks without antibiotic surgical repair is taken up, right? It is simply given to keep ear dry, right? Ear drop have no role. So yes, ear drop has no role. Otic hydrocephalus is a complication, so it is not the complication, right? And ossicular erosion is not seen. Ossicular erosion is what? It is not seen, right? It is not seen here. Okay, treatment of choice in central safe perforation is modified mastoidectomy, tympanoplasty, myringoplasty, conservative management. So here the treatment of choice for safe, central safe, it is It is tympanoplasty, right? It is tympanoplasty. Okay. Now, surgical repair of tympanic membrane is known as myringoplasty, right? Myringoplasty. Now, if while doing the surgery any ossicle is found to be necrosed, at that time ossiculoplasty is also done, and here if once ossiculoplasty or ossicular reconstruction is done, then that is what we say tympanoplasty. Now, tympanoplasty is simply we can say myringoplasty plus ossicular reconstruction, right? And type 1 tympanoplasty, in which there is no ossicular reconstruction, that is simply our myringoplasty only, right? So here the better answer is tympanoplasty, not myringoplasty. Ossicles the most commonly involved in CSOM are. What are the ossicles most commonly involved? If you know the arrangement, right, and these are arranged like this, right? The steps is what? The closure, right? But steps is closure, but long process of Mcqs, right? It is most commonly what involved in CSOM, right? The long process of Mcqs, right? Because it is what having less blood supply, poor blood supply. In tubotympanic CSOM, commonest operation done is, what is the most commonest operation? That is tympanoplasty, right? We just talked about it. Now, similarly, the surgery on eardrum is done using, right? Surgery on eardrum is done using, how it is done? It is done by using operative microscope, right? It is done by using operative microscope. Focal length of lens used in microscope ear surgeries. What is the focal length of lens used in microscope of ear surgeries? That is how much? 250 mm, right? 250 mm. And where we studied about this 250 mm, we talked that 25 centimeter is the focal length of mirror, right? Mirror while doing what? Ear examination also, right? Head mirror, right? Head mirror, right? Focal length of mirror was what? Head mirror. In head mirror, and diameter was how much? Diameter was how much? 9 centimeter, right? If you could recall. What is tympanoplasty? Tympanoplasty I have already said, right? Here what will happen in tympanoplasty? Myringoplasty is done, that means tympanic membrane is what? Repaired along with ear ossicles, right? So here it is eradication of middle ear disease, right? Middle ear disease with repair of tympanic membrane, not only tympanic membrane, also what? Ossicles. So option number A, eradication of middle ear disease with reconstruction of tympanic membrane and ossicles, that is our tympanoplasty. Columella effect is seen in, where is this columella effect seen? Now it is seen in, right? It is seen in tympanoplasty, right? Columella effect is seen in tympanoplasty. Now columella tympanoplasty, what is the columella tympanoplasty? It is type 3, right? Type 3. Now how can remember it? C for columella and type 3, right? Type 3. It is what columella effect is seen in type 3 tympanoplasty. Myringoplasty is done using, now it is done using temporalis fascia, right? The graft is obtained from temporalis fascia, right? Material used in tympanoplasty, temporalis fascia, right? Temporalis fascia along with what? Our tragal cartilage is also used, right? Cartilage is also used. The Austin's classification for ossicular chain defect depend upon. Now Austin's classification for what? Ossicular chain defect depends upon malleus head and steps suprastructure. It depends upon malleus head and steps suprastructure, right? Austin's classification. Now moving into next question, tympanoplasty is mainly used for. Now where tympanoplasty is useful? It is used in the case of what? CSOM, right? In the case of CSOM, active otosclerosis is managed by what? It is managed by sodium fluoride, where mature osteosclerosis is managed by stepedotomy, right? Okay, now ASOM here, it responds to antibiotic, antihistaminic, decongestant, and analgesic also. Now myringotomy is plastic repair of what? Simply tympanic membrane, right? All are true about myringoplastic except, now all are true except it is done by overlay and underlay technique. It is true, right? It is true. Temporalis fascia graft is most common graft used. It is also true, right? Now moving further, reconstruction of tympanic membrane is done. It is also true. It requires malleus. It required malleus is also, if required malleus is also reconstruction. No, because ossicles are reconstructed in tympanoplasty, not in myringoplasty. In myringoplasty simply we do tympanic membrane repair, right? Which of the following is true regarding myringoplasty, right? Okay, now here the same thing, it is true is it is done by underlay graft is placed medial to annulus, right? It is always underlay graft is placed medial to annulus, and other statement are Not true, right? Underlay graft is placed lateral to malleus. No, it is underlay graft is placed medial to annulus, right? Okay, least blood supply goes to long process of incus. That's why it was what? It was what? More prone to what? Erode, right? It was more prone to erode. Similarly, the tympanic membrane perforation graft is taken from temporalis fasciae. What type of graft it is? If it is taken from itself, from its own body, it is what? It is autograft. Simple, right? Simple. Now, moving further, all of the following are feature of tubotympanic CSOM except profuse, painless discharge, right? Here, the pain is what? The pain is there, right? Profuse is profuse, but hearing loss is present there. Marginal perforation is not seen, right? Central perforation is seen. So, marginal perforation is the incorrect statement, right? Williston type 2 tympanoplasty is, what is the type 3? Okay, in type 3 tympanoplasty we said columella effect was seen, right? Now type 3 tympanoplasty is myringostapediopexy, right? Myringostapediopexy is type 3 tympanoplasty. Now, okay, now 35-year-old patient with 6 months of non-fall smelling discharge, right? 6 months non-fall smelling discharge is found in tubotympanic, right? Fall, it is found in what? Etiquantral. And hearing loss. The tympanic membrane appearance is given below. Treatment include all of the following except, right? Now here tympanic membrane is what? Here we can say central perforation, right? Now what we do here is discharge is present there. So what we do, we just need to make it dry initially, right? Right? Here treatment include all except. Now topical antibiotic, yes, it is given. Systemic, it is given. Mastoidectomy, it is given. Tympanoplasty, right? Sorry, mastoidectomy is not given here, right? Tympanoplasty is done. So mastoidectomy is not there, it is not given here, right? So initially we provide topical and systemic antibiotic, and then we just wait till ear become dry, right? After 6 weeks, right? Then what we do tympanoplasty after the ear has become dry. Okay, these are the questions on what? Tubotympanic disease, right? The safe CSOM. Now we are going to cover the MCQ point from etiquantral or squamous chronic otitis media, right? Etiquantral or unsafe chronic otitis media. The first question is, which is true in the case of perforation of pars flaccida? CSOM is rare cause. No, it is the cause, right? Which is true. Associated with cholesteatoma, usually due to trauma, all of the above. Now here the true statement is it is associated with the cholesteatoma, right? CSOM is the what? It is not rare, it is must come. Any perforation of pars flaccida is unsafe CSOM because of its association with cholesteatoma. Perforation of part of tympanic membrane with destruction of tympanic annulus is called, it is what? It is called marginal, right? Marginal. Cholesteatoma occurring. Now cholesteatoma occur where? It occurs in central perforation or marked mastoiditis, coalition mastoiditis, acute necrotizing otitis media. Now here it occurs in acute necrotizing otitis media, right? Acute necrotizing otitis media. The most common cause of secondary cholesteatoma is right, migratory keratinizing stratified squamous epithelium through marginal perforation of tympanic membrane, right? Okay. Levinson criteria for diagnosing congenital cholesteatoma include what? Levinson criteria for diagnosis of okay, it includes what are the different criteria for Levinson's diagnosis congenital cholesteatoma. It is white mass behind intact tympanic membrane, right? Normal pars flaccida and pars flaccida, right? Prior otitis media is not an exclusion criteria. So here A, B and D are the right statement, right? A, B and D are the right statement. Now the most common accepted theory for formation of secondary cholesteatoma, right? The most accepted theory for formation of secondary what? Cholesteatoma is, what is it? It is migration of squamous epithelium, right? It is the migration of squamous epithelium. So for secondary cholesteatoma, migration of squamous epithelium is the most accepted theory. For congenital cholesteatoma, white mass behind the tympanic membrane, normal pars flaccida and pars flaccida, and prior otitis media is not the exclusive criteria, right? Now the posterior superior retraction pocket, if allowed it to progress, will lead to what? It will lead to posterior suppression retraction pocket if allowed. Now here we are not talking about what tympanic membrane perforation. So secondary is not the answer. So here the answer is sensory neural hearing loss, right? Sensory neural hearing loss. The posterior superior retraction pocket, if allowed to progress, it will lead to primary cholesteatoma, right, which in turn can lead to sensory neural hearing loss, right? Okay, secondary cholesteatoma is simply secondary to what? Secondary to perforation, right? Okay, cholesteatoma is usually presented where it is present, right? It is mainly present at our what? Atic region. The most common site of primary cholesteatoma is atic region, right? In atic region, right? Okay, the cholesteatoma is commonly caused by what? It is commonly cholesteatoma is commonly caused by atic perforation. Simple, right? Now question number 9, right? Cholesteatoma commonly associated with, it is associated with aticoventral CSOM. Okay, scanty foul smelling painless discharge from ear is characteristic feature of which of the following lesion? Yes, scanty, right? Profuse was in tubate tympanic. Foul smelling, non-foul smelling was in tubate tympanic, right? Painless discharge, right? Painful was in tubate tympanic. Now here it is characterized by what? It is characterized by cholesteatoma, right? Okay, it is characterized by cholesteatoma. Now moving to our next question. What is the next question? Cholesteatoma and anticoagulal true about is scanty malodorous discharge. Yes, we know about it, right? Otalgia, no, it is not present there. Central perforation, no. Ossicular necrosis, yes, it is. Convulsions, it might be, right? It might be. So here the right answer is A, D, and E, right? Unsafe aticoventral presents with scanty malodorous discharge, right? Yes, because of osteitis or bone erosion, and there will be deafness also, right? The patient can also present with any of the complication of CSOM, right? CSOM convulsion can be due to temporal lobe abscess, right? It can be because of temporal lobe abscess also, right? Now moving further, true about, okay, now here ossicular necrosis, right? Ossicular necrosis is seen in both safe and unsafe CSOM. In unsafe CSOM, it is mainly due to eroding of cholesteatoma. In safe or tubate tympanic CSOM, ossicular necrosis is due to repeated infection, right? Repeated infection. The most common ossicle to get necrosis, already we talked about it, long process of incus, right? Because of its what? Insufficient blood supply. That's it. True about cholesteatoma is or are, right? It is benign tumor. Okay, cholesteatoma, it is benign tumor? No, it is not. Metastasis to lymph node? No. Contains cholesterol? No. Erodes the bone? Yes, it is true, right? Malignant potential? No. Cholesteatoma, word is misnomer, right? It does not contain cholesterol. It is not malignant tumor also, right? It is not oma at last. It is not tumor also, and it is not cholesterol also, right? It is benign tumor. However, its bone eroding property justified the suffix oma, right? That's all. The true about cholesteatoma is it is physiological, erode bone. Yes, it erodes bone. Benign neoplasm. Yes, it contains benign neoplasm. No. Contains cholesterol. No. So what? It erodes bone is the right answer. All of the following are feature of disease shown in the picture except. Now here the disease that is shown. What is the disease shown here? Right? Cholesteatoma. Right? Cholesteatoma. CSOM. Right? Filled with keratinized stratified squamous epithelium. Yes, it is right. Right? Deafness is present there. Yes. Erode bone. Yes. Right? Lymphatic permeation. No, it is not there. Right? Now cholesteatoma, it is not spread by lymphatic, right? It is spread by eroding bone and not by lymphatics. Cholesteatoma is seen in, we know that, right? CSOM, right? Cholesteatoma formation is characteristic of unsafe CSOM, right? Okay, now next question. The primary treatment of medullary cholesteatoma is primary treatment of medullary cholesteatoma. What is the primary treatment, right? Now here what we do, we go towards surgery. The main management of cholesteatoma is surgery, right? Okay, the treatment of choice for aticoantral variety of CSOM. Treatment of choice, aticoantral variety of CSOM. What is the treatment of choice? The treatment of choice is our what? It is mastoidectomy, right? In safe type, what we were doing? We were doing tympanoplasty, right? But in unsafe, we are doing mastoidectomy. The main management of unsafe CSOM is mastoidectomy, right? Mastoidectomy, right? Where we do mastoid exploration, which can be right, which can be intact canal wall or canal wall down procedure, right? It can be, we can do it by canal up or canal down procedure, right? Initial management of anticoagulal CSOM is by local and systemic antibiotic, only what? To superimpose infection or complication, right? Okay, Now here the next question is the treatment of choice for perforation in pars flaccida of tympanic membrane with cholecystoma is. We already said what is the treatment of choice. It is mastectomy, but modified radical mastectomy is the treatment of choice, right? Now why we are choosing modified radical mastectomy? Because reconstruction of hearing is not done in radical mastectomy. So MRM, modified radical mastectomy, is preferred over radical mastectomy in treatment of onset CSOM to give patient a hearing ear beside making them safe and dry, right? All of the following techniques are used to control bleeding from bone during mastoid surgery except. All of the following techniques are used to control bleeding from bone during mastoid surgery except cutting and drilling over the bleeding area. No, it is what it will again further cause what it will again further cause the bleeding, so it is not used, right? Other all diamond drill over bleeding area it is used, bipolar cautery over the bleeding area it is used, bone axe is used, right? The child presents with foul smelling ear discharge. On further exploration, small perforation is found on pars flaccida of tympanic membrane. Most appropriate next step in management would be, right, obviously what we are going to do, there is foul smelling ear discharge, right? So initially what we do, we just do tympanomastoid exploration, right? We just explore it. Foul smelling discharge and perforation in pars flaccida of tympanic membrane indicate that it is onset CSOM. So management is tympanomastoid exploration, right? Now tympanoplasty is done as a part of modified radical mastectomy, right, in onset CSOM, right? Now further, the 5-year-old boy has been diagnosed to have posterior superior retraction pocket, right? All would constitute a part of management except audiometry, right? Audiometry, okay, we can do it, right? Mastoid exploration, we can do it. Tympanoplasty, we can do it. Myringoplasty, no, we can't do it, right? Myringoplasty, right, is what not done here, right? Here we do tympanoplasty, that includes the reconstruction of what, hearing mechanism. Mastoid exploration, yes, part of what, mastectomy. Audiometry is also done, right? It is done pre and post operatively to assess the improvement of hearing. That's why the myringotomy is not done here. Most difficult site to remove cholecystoma, such that sinus tympani is related with sinus tympani, right? It is related with mastoid segment of facial nerve, tympanic segment of facial nerve. It is related with mastoid segment of facial nerve, right? Sinus tympani, it is related to mastoid segment of facial nerve. Sinus tympani is area hidden in middle ear and is most important sign for residual cholecystoma. It lies medial to bulge of vertical part of fallopian canal, right? Mastoid segment of facial nerve, right? It being hidden area, it is most difficult site to remove cholecystoma. Okay. Now 30-year-old male is having atic cholecystoma of left ear with lateral sinus thrombophlebitis. Which of the following will not be the operation of choice, right? Here canal wall down mastectomy will not be the operation of choice, right? Canal wall down mastectomy will not be the what, it will be, right, it will be the operation of choice, right? Canal wall down includes two types, that is radical mastectomy and modified radical mastectomy, right? Here we will do what, MRM, right, modified radical mastectomy, since complication is there, right? Now moving further, we have next question, that is medical treatment is not effective in which type of suppurative otitis media? That is our chronic suppurative otitis media, right? Simple. Now moving to our next question, the modified radical mastectomy is indicated in all of the following except, right? It is modified radical mastectomy is not what done in safe CSOM, tubative meningitis, because here simply tympanoplasty is done in safe CSOM. Radical mastoidectomy is done for right, it is done for what, it is done not done for safe ASOM, aticoantral cholecystoma, acute mastoiditis. So it is done for aticoantral cholecystoma, right? These days MRM, modified radical mastoidectomy is preferred over radical mastoidectomy in measurement of aticoantral disease, right? All of the following steps are done in radical mastoidectomy except lowering of facial ridge, it is done. Removal of middle ear mucosa and muscles, it is done. Removal of ossicles except steps with plate, right, it is done. Maintenance of patency of eustachian tube, so it is not done, right? Maintenance of patency of eustachian tube is not done. Radical mastoidectomy include all except closure of auditory tube, Ossicles are removed, yes. Cochlea are removed, no, it is not done, right? Exteriorization of mastoid, it is done. So cochlea removal is not done, right? Now communication between middle ear and Stachan tube is obliterated in which surgery? Middle ear and Stachan tube communication is obliterated, right? Where it is obliterated? Now it is obliterated in radical mastoidectomy, right? Communication between these two are obliterated in radical mastoidectomy, right? Now nerve which can get damaged in radical mastoidectomy is, what is the nerve that can get damaged? That is obviously our facial nerve, right? Facial nerve. Tubercular otitis media is characterized by all accept. Tubercular otitis media is characterized. Tubercular otitis media is characterized by all ear, all above, right? Multiple perforation is seen. Pale granulation it is seen. Pain it is not seen in tubercular otitis media. Foul smelling discharge is seen, right? Which of the following is characteristics of tuberculosis otitis media? That is our marginal perforation. Okay, it can be, but the appropriate answer is multiple perforation, right? Multiple perforation is seen there. Now next question, Sueller's view and Locke's views are for. Sueller and Locke's view, what these are for? These are for our mastoid cells. Sueller's and Locke view, right, are lateral oblique view of mastoid to see the extent of pneumatization and destruction, and these are also used to see dural and sinus plate, right? Stenver's view is useful for. Stenver view is useful for our temporal bone. Stender view is used to see whole of the petrous pyramid, right? Nowadays SRCT is done to assess temporal bone pathologies, right? But this Stenser view, it is also used for temporal bone. What is the treatment of choice for aticoantral CSOM? We already said treatment of choice is our modified radical mastoidectomy, right? Now which of the following are removed in radical mastoidectomy except radical mastoidectomy? All are removed except cora tympani, incus is removed, posterior meatus wall is removed, Stapes foot plate is what? Stapes foot plate is removed or not? Now here Stapes foot plate is not removed. Is the structure that is not removed in what? In our radical and modified radical mastoidectomy, right? So Stapes foot plate is the right answer. All of the following are theories for acquired cholesteatoma except. We said, okay, all of the following are theories, right? We said squamous metaplasia, also basal cell hyperplasia, retraction pocket, pressure of keratin. There is no such theory for acquired cholesteatoma, right? Pressure of keratin. So other all are the theories. In radical mastoidectomy, it is necessary to preserve. What is necessary to preserve in radical mastoidectomy? Stapes foot plate, right? Yes, Stapes foot plate. Which of the following is most likely diagnosis of the picture depicted? Right here you can see what? You can see perforation right here. What is the most? Which of the following is most likely diagnosis of the picture depicted? Now the most likely diagnosis is, what is the most likely diagnosis? It is CSOM with atic perforation and cholesteatoma, right? 30-year-old male presented with foul-smelling discharge. On examination, tympanic membrane appeared as picture given below. Most appropriate next step of management would be, what we are going to do? Since foul-smelling discharge, right? Modified radical mastectomy, right? Obviously, that is what we are going to do. Okay, the child with adenoid hypertrophy and blockade of Stachan tube has future risks for. It has future risks for what? It has future risks for, right? Primary or secondary? Primary cholesteatoma, right? Okay, primary cholesteatoma, because secondary is simply when we talk about the cholesteatoma secondary to what? Secondary to perforation, right? Okay, now moving further, below is endoscopic picture of patient who presented with foul smelling ear discharge. Most probably diagnosis is foul smelling ear discharge, right? Obviously it is what? Here there is what? Perforation is seen here? No, the picture shows atic retraction pocket, right? Atic retraction pocket with whitish cholesteatoma is also seen there. So it is what it is, primary cholesteatoma, not secondary. Okay, this was all about the questions on what? Chronic, okay, aticoantral chronic suppurative otitis media. Now the topic of discussion is from otosclerosis. Now we are going to solve MCQ point from the chapter of otosclerosis. Now here, without delay, let's move directly into our question. So the first question is the most common site for initiation of otosclerosis, and the right answer is fistula anterofenestrum, right? Fistula anterofenestrum. Now here, what is fistula anterofenestrum? It is just anterior to foot plate of steps, right? Though otosclerosis ultimately result in fixation of foot plate and margin of steps which is lying over the oval window, it actually gets initiated most commonly in what? In immature cartilage of area bony labyrinth, which lies anterior to a fenestra of oval window, hence called fistula anterofenestrum, right? Okay, now moving into next question. The part most commonly involved in otosclerosis is, now what is the most common part? We have already said, right? There is mainly what? Initiated most commonly in what? Immature cartilage in area bony labyrinth which lie in anterior to fenestra of oval window. So what is the most common site? The most common site is oval window, right? Okay, now moving to next question. The most common is for otosclerosis is, what is the most common? It is what? Pregnant women, right? Pregnant women. Otosclerosis is found in mainly pregnant women in what? In second trimester. So the age we can assume here is, what is the age? The age is 20 to 30 years. The age is 20 to 30 years. Moving to our next question. Otospongiosis is inherited as, now otospongiosis is inherited as autosomal dominant disease, right? The truth about otosclerosis is family history is usually present. Male are affected twice than female. No, it is mainly what? Female is affected, right? More common in Negroes and Africans. Now talking about which are more common, the more common are our Caucasian races, right? Caucasians, right? These are more common in Caucasians and Indians. Now talking about deafness occur in about 20 to 30 years. Yes, we are true about it. In about 20 to 30 years, pregnancy has bearing on it. Yes, it is also true. So here the right answer is the answer number what? A, it is right, family history, it is autosomal dominant. D, deafness occurs in 20 to 30 years, we also know about it. And another is E, right? These are the correct statement. A 30-year-old female with family history of what? With a family history of hearing loss from mother side developed hearing problem during pregnancy. Hearing loss is bilateral, slowly progressive. Pure tone audiogram shows apparent white conductive hearing loss of how many? 2000 Hz, right? 2000 Hz. What is the most likely diagnosis? So here what is going on is, first clue we have got is, we have got age group, that is 30 years. We already talked the age. What is the age affected? The age affected is between 20 to 30, right? And female is here with a positive family history, right? Now there is another thing is during pregnancy. Hearing loss is bilateral, slowly progressive. And here one important characteristic is that pure tone audiometry shows apparent bone conductive hearing loss at 2000 Hz. Now here 2000 Hz, that is what? This is our Carhart notch, which is a peculiar finding in the case of what? Audiometry, or in the case of audiometry of our otosclerosis. Now there is deep, right, in bone conductive curve which is maximum at 2000 Hz, right? Deep, there is deep in bone conduction curve which is maximum at 2000 Hz, right? And this is what? Carhart notch, right? Carhart notch. The cause of Carhart notch is that steps mobility is maximum at 2000 Hz, right? But as steps fixation has occurred, so there is no transmission at 2000 tone, so depression of curve occur. Deep is more at 2000 Hz, producing Carhart notch. Similarly, there is another condition, that is our Boiler's notch. Now what is Boiler's notch? It is deepening at 4000, right? 4000 Hz. It is mainly seen in the case of noise induced hearing loss, right? So here obviously we are sure that it is the case of otosclerosis, right? Moving further, next question is otospongiosis causes, what it causes? We have already said it causes what? It causes bilateral conductive deafness, right? Bilateral conductive deafness. The next question is 30-year-old woman presented with progressive conductive deafness bilaterally. The most common causes, we have already said, it is age, it is woman. Here there is conductive deafness and it is bilaterally presented. So the most common cause is otospongiosis, right? Otospongiosis. Now moving to our next question, question number 9. Paracusis olissae is a feature of. Now what is this paracusis olissae, right? Now okay, now paracusis Willis is, here the patient has, it is the clinical feature of otosclerosis in which patient has better hearing in noisy surrounding. That means what will happen is that in noisy surrounding, people increases their voice intensity, right? And patient speech discrimination becomes better, right? That is the condition. So paracusis Willis is a feature of what? It is a feature of obviously what? Our otosclerosis, right? Okay, now moving to our next question, right? A patient hears better in noise. The diagnosis is, we have already said what is the diagnosis? Paracusis, right? Paracusis, right? Okay, now the otosclerosis, in otosclerosis tinnitus is due to, now what is the cause of tinnitus in the case of otosclerosis? It is what? Cochlear otosclerosis also, yes. Increased vascularity in lesion, that is also right. Conductive deafness is also right. So here tinnitus in otosclerosis is not common, but if it is present, it is due to active otosclerosis because of increasing vascularity. And another is cochlear otosclerosis, right? Any hearing loss condition, but it is conductive or sensory neural hearing loss, can lead to what? Tinnitus, right? So all are the possible mechanism. In majority of the cases, right, in majority of the cases with otosclerosis, the tympanic membrane is, now what will be the tympanic membrane here? Okay, here the tympanic membrane will be what? Normal. In majority of the cases it will be normal, right? In 90% of the patient, right, in 90% of the patient of otosclerosis, the tympanic membrane appear normal, or we can say pearly white, right? Pearly white. In 10% of the cases which are active tympanic membrane, right, which are active tympanic membrane, there what will happen? There what? There will be flamingo pink, right? In active tympanic membrane there will be 10, these are what? These appear pink, flamingo pink, but those account for only 10% of the cases. But tympanic membrane is feature of what? But talking about blue ear, the blue ear is found in the case of what? Our glue ear, right? That is what? Our serous otitis media, right? Serous otitis media, glue ear, or what? Or we can say otitis media with effusion, right? Because of what? Cholesterol granuloma. And yellow tympanic membrane, it is not seen in any of the cases. Pink tympanic membrane is seen in, we have already said, in about 10% of the cases, the active otosclerosis, there will be pink tympanic membrane, and that is otosclerosis. Schwartz sign is seen in. Now, what is this Schwartz sign? Okay, the first thing is, the Schwartz sign is what? Is a reddish hue seen through tympanic membrane on promontory, right? It indicates active focus, which is vascular, where there will be flamingo pink appearance of tympanic membrane. So simply Schwartz sign is nothing, but it is what? It is reddish hue, which is seen through tympanic membrane on promontory, right? It indicates active focus, right? Now that active focus, that is what? That is flamingo pink appearance, right? Okay, so it is seen in the case of otosclerosis. Feature in otosclerosis include, what does it include? Okay, here feature in otosclerosis includes sounds not heard in noisy environment. Okay, it is not right, right? Paracusis Willis, right? Paracusis Willis, it is what? Sound heard better in noisy environment. Normal tympanic membrane, yes, normal tympanic membrane is seen, right? Now more common in male, no, that's not right. Malaise is most commonly affected, we have already said. Anterior what? Foot plate, anterior to foot plate of steps is more affected. So here what you can see here is, what is the right answer here? Normal tympanic membrane is the right answer. So now true statement about otosclerosis is, now what is the true statement about otosclerosis? Is it unilateral? No, it's what? It's bilateral, right? Carhart notch seen? Absolutely right. Deepening of bone conduction at 2000 Hz. Fluctuating hearing loss? That's not right, right? Progressive deafness? Yes, that's right, right? That's right. And males are more commonly affected? Not right. So the right answer is our what? B and D only. Characteristics feature of otosclerosis are all except. Now here conductive deafness is the characteristics of otosclerosis, that's right. Positive rain is, now since it is conductive hearing loss, is there positive rain? No. Paraculis Willis, yes, that's right. Pearly white eardrum, that's also right. So here just alter option is our what? That is, what is the alter option? Positive Renin test. Since otosclerosis majorly lead to conductive deafness, so Renin test is negative, right? Negative. Not true regarding hear loss in otosclerosis. right? Not true regarding hearing loss in otosclerosis, common in female of age around 30 years. That's right, right? Vertigo present? No, we are not concerned about it, right? We did not talk about any of it till now. Paracusis willaceae, that's right. Short sign, that's right. So here the answer is our vertigo present. It is not present. Now next question, Galley's test is for. Now Galley's test is for our otosclerosis, right? Now normally, right? Normally, or in sensorineural hearing loss, right? In Galley's test, right? What we do is, okay, vibrating tuning fork is placed over mastoid in both the test, right? In both the test, that means in Galley's and in Bing, right? In Bing, vibrating tuning fork is placed over mastoid, right? Then hearing is compared by blocking the external auditory canal in Bing test and by increasing ESC in Galley's test, right? By increasing ESC pressure, signalization is done in what? Galley's test, and what? The tuning fork is kept in mastoid, right? In normal or in sensory neural hearing loss, right? What will happen is that on increasing ESC pressure, right? On increasing ESC pressure, right? There is increase in intensity, right? Sorry, there is decrease in intensity. On increasing pressure, there is decrease in intensity of sound, right? But what happens here in otosclerosis is there will be no change, right? Since why there will be no change? Because already the steps, they are what? They are fixed, right? They are fixed, right? They are fixed. That's why in Galley's test, on Galley's test at otosclerosis, on while doing Galley's test, there will be what? There will be no change in what? There will be no change in what? Our intensity, right? There will be no change in intensity. That's why. Okay, now moving further, right? Now the next question is, a lady has bilateral hearing loss, right? A lady has bilateral hearing loss, and here now the lady has bilateral hearing loss since 4 years, which is worsened during pregnancy. The type of impedance audiometric graph will be okay. Now yes, as for what? As for our sclerosis, right? yes. So we will remember, right? Now here the what will be the audiometric graph? It will be AS type, right? AS type. So AS, it will be AS will be seen where? In the case of stiffness, right? Stiffness, right? And sclerosis, right? Talking about what sclerosis, we have how many? Tympanosclerosis and otosclerosis, right? Osteo or otosclerosis. So that is what that is our AS type of curve. In otosclerosis, the tympanogram is, right? Otosclerosis, since okay, what will be the otosclerosis? What is the tympanogram in otosclerosis? Here the otosclerosis will be our of low compliance, as AS type of curve in otosclerosis is of low compliance and normal pressure type, right? Now I was talking about what? High compliance and normal pressure curve type of curve is seen in the case of AD type, right? High compliance and normal. So here what is our right answer? Low compliance. Moving further, in otosclerosis, Carhart notch deep set, how many? We have already talked about it, 2000 Hz, but where? In air conduction or bone conduction? It is in bone conduction, right? Bone conduction. Okay. Now moving further, the Carhart notch in audiograms depends at what frequency? It depends at what? 2000 Hz, right? Okay. Moving further, pure tone audiogram with deep at 2000 Hz is characteristic feature of our otosclerosis. That's all. Otosclerosis treatment include all of the following except. Okay. Now here talking about the treatment, sodium fluoride, it is given. Now why the sodium fluoride is given? It is medical treatment, right? It is given. Okay, it is given because it has stemmed the maturity of active focus and arrest further cochlear loss, right? Now how it is going to arrest the further cochlear loss? By decreasing bone resorption, right? By increasing bone formation, right? This thing also. And another thing is by preventing what? Enzymatic digestion of cochlea, right? These are what? These are the reason why we give sodium fluoride, right? In management. Similarly, another thing, okay, stapedectomy, right? Stapedectomy is what? It is surgical management, right? It is the definitive way of management, right? Stapedectomy, right? Here it is also what under it is also used in treating, right? Similarly, hearing aid and radical mastectomy. Now here talking about these two, what might not be the right answer? The right answer is that is our radical mastectomy is not done here. So we do what? Sodium fluoride, hearing aid, stapedectomy, right? But the treatment of choice for otosclerosis is stapedotomy, right? Stapedotomy, right? Here it is spedectomy. The treatment of choice is stapedotomy. Carotid notches in audiometry is seen in our otosclerosis. All are true about otosclerosis except, okay, increased incidence in female, that's right. Conductive difference, that's right. Irreversible loss of hearing, okay, right. Okay, this is not right. Carotid notch, that's right. Family history positive, that's right. Autosomal dominant nature. So here the answer is this. Medication which may prevent rapid progression of cochlear otosclerosis is, we have already said, sodium fluoride, right? That's right. Now the other question is, all of the following statement about sodium fluoride in otosclerosis are true except. Now it acts by inhibiting proteolytic enzyme in cochlea, that's right. Act by inhibiting osteoblastic activities, no, that's not right. It by inhibiting osteoclastic activity. It is contraindicated in chronic nephritis, okay, that is also our right. Is indicated in patient with positive Schwartz sign, that's right, because it is indicated in the patient with what? Active focus, right? It has still the maturity of active focus. So here the right answer is act by inhibiting osteoblastic activity. Because, okay, a 31-year female patient with complaint of bilateral impairment of hearing for past 5 years. Audiogram shows bilateral conductive deafness. Impedance audiogram is given below. All constitute part of treatment except, okay. Now here we have already seen, right, it has decreased. The compliance is what? The compliance is decreased here, right? Compliance is decreased. Okay, now what is we always know it is the case of what? Osteosclerosis, right? Now here what is not the treatment of choice? The sodium fluoride, it is hearing aid, stapedectomy, all these are, but gentamicin is not given here, right? Here from this graph what we can see is it is AS type tympanogram, right? Now gentamicin is not used here. Gentamicin is vestibulotoxic drug which is given in the case of what? Meniere's, right, to relieve vertigo. So it has no role here in otosclerosis. Now following operation is most preferred in case of otosclerosis. Following operation is most preferred in the case of otosclerosis: stapedectomy, fenestration, stapedotomy, sacculotomy. I have already said what is the treatment surgery of choice? Stapedotomy, right? Stapedotomy, right? Now another question is the otosclerosis during step surgery prosthesis used is. Now what is the prosthesis used? Okay, now here the prosthesis, right, that is used here is, that is our Teflon piston, right? Talking about grommet insertion is required in serous otitis, right? Serous otitis media, we know. Total ossicular replacement prosthesis, TORP, is used when it required to reconstruct whole of the ossicular chain. For example, in the case of unsafe, right? In case of unsafe CSOM, when there occur complete necrosis of all three ossicles, right? Okay, stapedotomy include removal of all except, right? It involves removal of everything except lenticular process of incus, right? What is the role of sodium fluoride in otosclerosis? It restores the electrolyte equilibrium, okay, that's right. Okay, what is the role? Okay, we don't know about it, right? That's not right. It has still recovery of overstimulated cochlea, we are not sure about it, right? It quickens the maturity of active focus and reduce osteoclastic crashes. Yeah, that's right, we know about it, right? It repolarizes the cochlear cells, no, we don't know. So the thing that it does is it what? Quickens the maturity of active focus and reduces osteoclastic resorption, that's right. Now moving further, otosclerosis most commonly affect which race? We have already said what? It will affect our Caucasian, right? Caucasians. Now what are the Caucasian? The white races, right? Caucasian, white races. Now here, 25-year-old female patient presented with a history of bilateral hearing loss, tinnitus which worse during pregnancy. She can hear better noisy environment. She speaks in low volume, monotonous voice. Examination showed intact ear drum bilaterally and renin test negative bilaterally. Pure-tone audiogram is given below. What is the most probable diagnosis? Obviously, right? The most probable diagnosis is our what? our otosclerosis. In the above patient, deep in bone conduction at 2000 Hz is called carotid notch. The treatment in this patient is, what is the treatment? Stepedotomy and piston what? Insertion. The finding of impedance audiometry in long standing case of otosclerosis is what it is? It is AS graph alone or AS graph with increased stapedial reflex, AS graph with loss of stapedial reflex. So the right answer is there will be what? There will be loss of stapedial reflex. Post step surgery procedure which curve in impedance audiometry? Post step surgery produces which curve in impedance audiometry? What it will produce? It will produce AD, right? It will produce AD. Okay, this was all about questions from our what? Osteosclerosis. Now we'll be talking the next chapter, MCQ next chapter in next video. Now we are going to talk about MCQs from facial nerve and its disorder. Right now, without delay, let's dive into the first MCQ, and that is right upper motor neuron supranuclear lesion of facial nerve causes. Now here it's talking about right upper motor neuron supranuclear lesion of facial nerve causes loss of taste sensation in right anterior part of tongue, loss of corneal reflex on right side, loss of wrinkling of forehead on left side, paralysis of lower facial muscle on left side. So here it is talking about what? It is talking about upper motor neuron lesion, right? Upper motor neuron lesion, right? Now since there is what there is what our upper motor neuron lesion, then in opposite side there will be what? Half, right? Half. In opposite side there will be lower facial paralysis, right? Paralysis of lower facial muscle will be there, right? Okay, so here the right answer is paralysis of lower facial muscle on the left side. Which part of facial nerve is most commonly exposed through natural dehiscence in fallopian canal? Which part of nerve is commonly exposed through natural dehiscence in fallopian canal? We all know that there is fallopian canal, right? The fallopian bony canal through which what facial nerve passes, right? Now through which part there is maximum exposure? Now it is asking about that thing. So here it is the horizontal part, right? This horizontal part through which there is what? Common exposure. The first branch of facial nerve is, what is the first branch? The first branch of facial nerve, that is our, what is? It is greater petrosal nerve. What it is? It is greater petrosal nerve, right? Now the greater petrosal nerve arises from geniculate ganglion in first genu, right? In the first genu, this is first branch. The second branch is nerve to stapedius given at the pyramid, and the third is chora tendini given 4 to 6 mm before the exit of facial nerve from stylomastoid foramen. So here the first is greater superficial petrosal nerve, right? The second is our what? Nerve to stapedius, right? And the third is chora tympani, right? And okay, now talking about lesser superficial talking about lesser superficial petrosal nerve, right, is not a branch of facial nerve. It arises from tympanic plexus and supply otic ganglion. Okay, moving further, dryness of mouth with normal stapedial reflex in facial nerve. The cital lesion is, there is dryness of mouth with normal stapedial reflex, right? So okay, there is dryness of mouth with normal stapedius reflex in facial nerve, right? Okay, the site of lesion is, now here since the stapedial reflex is normal, right? Since the stapedial reflex is normal, nerve to stapedius, that means up to what? First genu, there is what? There is normal. Now after first genu, now talking about dryness of mouth, right? Now what is chora tympani? Chora tympani, what is the role of chora tympani? Chora tympani give taste to anterior 2/3 of the tongue and parasympathetic supply to sublingual and submandibular salivary gland, right? Okay, so here in the question, since stapedial reflex is normal, right? Stapedial reflex is normal, so injury is beyond the nerve to stapedius, such that it or before chora tendini, right? But after pyramid and will lead to loss of taste from anterior 2/3 of the tongue, and it will cause what? It will cause reduce in salivary flow leading to some dryness in mouth. So till stapedius muscle there is everything is okay, but it may be what? The site of lesion may be it or what? It or before chora tympani, right? Chora tympani. Nerve involved in hyperacusis, right? Talking about the nerve involved in hyperacusis, that is our facial nerve, right? Now which test can detect facial nerve palsy occurring due to lesion at outlet of stellomastoid. Which test can detect facial nerve palsy occurring due to lesion at outlet of stellomastoid? That is what? Loss of taste sensation in anterior 2/3 of the tongue. Now why it is so? Because, right? Okay. Okay. Now when there is lesion in what? Outlet of stellomastoid foramen, the motor fiber which supply facial muscle on same side are affected, leading to what? Leading to what? Leading to deviation of angle of mouth toward the opposite side due to pull of normal side facial muscle, right? So here the answer is deviation of angle of mouth toward the opposite side, right? It is not the loss of taste sensation anterior to third of the tongue, right? Because the chorda tendineae originates before stellomastoid foramen, right? Before stellomastoid foramen. So taste sensation in anterior to third of the tongue is what? There is preservation of it. It is not what? It is not lost. Stellomastoid foramen is out. Is what? Is will be later on, but earlier to stellomastoid foramen there is already what? Chorda tendineae, right? Before stellomastoid foramen. So the taste sensation will not be lost. Simply there will be what? There will be deviation, right? There will be what? There will be deviation of angle of mouth toward opposite side. That's all, right? Dryness of eye is caused by injury to facial nerve 8. Now dryness of eye, right? Now talking about dryness of eye, whenever there is injury before or at the origin of what? Greater petrosal nerve, right? There will be what? There will be what? There will be affection. There will be what? Geniculate ganglion affected, right? There will be affective geniculate ganglion, which is responsible for what? Lacrimation, right? Lacrimation, right? And that will cause to dryness of eye. So what we can see here is geniculate ganglion, right? Geniculate ganglion, because from here from here there will be because geniculate ganglion is responsible for what? Lacrimation, right? That's why dryness of eye caused by injury to facial nerve 8, geniculate ganglion. Lacrimation is affected when facial nerve injury is at, I have already said what? Geniculate ganglion. Now moving further, right? The facial nerve injury at stellomastoid foramen can cause what? It can cause at stellomastoid foramen, right? Now loss of corneal reflex at the side of lesion, loss of taste sensation at anterior 2/3 or ipsilateral half of the tongue, loss of lacrimation at the side of lesion, hyperacusis. So here what is the right answer? Loss of corneal reflex at the side of lesion, right? Now why is it so? Because we have already said when injury is at stellomastoid foramen, right? The extracranial motor part of facial is affected, leading to loss of corneal reflex, right? Now here the next thing is, now the branch of facial nerve before what? Stellomastoid foramen, such as greater superficial petrosal nerve to stapedius and chorda tendineae will all be preserved. So there will be what? There will be no loss of what? Taste sensation, right? Loss of taste sensation, loss of hyperacusis. There will be no loss of lacrimation also, because it is already from our geniculate ganglion, and hyperacusis also. So the loss of corneal reflex at the side of lesion will occur. That is what? That will arise after what? After stellomastoid foramen. Which of the following statement is correct in facial paralysis? The nasolabial fold is obliterated on the same. The nasolabial which one of the following is correct in facial paralysis? The nasolabial fold is obliterated on same side. The nasal fold is obliterated on the other opposite side. The face deviates to the same side. The eye do not close completely on opposite side. So here talking about question number what? Question number 10. The nasolabial fold is obliterated on same side, right? The nasolabial fold is obliterated on same side. So here in facial nerve palsy, motor supply of facial muscle on same side will be affected, leading to what? Obliteration of what? Nasolabial fold, that is loss of facial movement, and incomplete closure of eyelid in affected side. Another thing will be, there will be incomplete what? Closure of eye on affected side. We have already said. Now talking in facial paralysis, what will happen? The motor supply of facial muscle on same side will be affected. Okay, we are clear. That will lead to obliteration of what? Nasolabial fold, right, on the same side. Intratemporal lesion of chorda tympani nerve result in, right? Intratemporal lesion of chorda tympani muscle lead in. We already should know the loss of what? Taste sensation from anterior to third of the tongue, right? In order, the patient present with hyperacusis, loss of lacrimation, and loss of taste sensation. in anterior two-third of the tongue. The injury extend up to which level of facial nerve? We know it will what? Now since it will, okay, here there is loss of taste sensation present with hyperacusis, loss of lacrimation. So the loss of lacrimation, that means it has already reached up to what? Proximal to geniculate ganglion, right? Since all the intertemporal branches of facial nerve are involved, the injury should be before first branch, that is greater superficial petrosal, which is given off at geniculate ganglion, right? The surgical landmark for identification of facial nerve in mastoid surgeries are all except below the processus cochleariformis. Okay, it is not below the processus cochleariformis, right? Okay, above and posterior to oval window. Yes, we know it is above and posterior to oval window. Medial to short process of incus. That's right, it is medial to short process of incus, behind the pyramid. That's right. So below the processus cochleariformis is the wrong answer, right? The first genu of facial nerve, right, lie anterior superior to processus cochleariformis, not below, right? It lies anterior superior to processus cochleariformis. The blood supply of facial nerve. What is the blood supply of facial nerve? Okay, now ascending palatine artery, no. Facial artery, no. Labyrinthine artery, yes, that is. And another is our what? Ascending pharyngeal artery, no, it is not. Another is stylomastoid artery, right? These are what? The blood supply of facial nerve, labyrinthine artery and stylomastoid artery. Moving further, the etiology of facial nerve paralysis include all of the following except, okay, etiology of facial nerve paralysis include all of the following except otosclerosis. No, it is not included. Bell's palsy, yes it is. Acoustic neuroma, yes it is. Modified radical mastectomy, yes it is also. The facial nerve palsy is seen in, where it is seen? It is seen in acoustic neuroma, yes. Varicella zoster virus, yes. Sarcoidosis, yes, it is seen in all, right? Now moving to our next question, facial nerve palsy is seen in this condition: seborrheic otitis externa, otomycosis, malignant otitis externa, diffuse otitis externa. So the malignant otitis externa is the right answer, in which facial nerve palsy along with 9, 10 and 11 nerve palsy will be there. The most common cause of facial palsy is, that is our Bell's palsy, right? We clear about it? Yes, it is Bell's palsy. The most common cause of lower motor neuron facial palsy is, that is also what? That is also our Bell's palsy. The Bell's palsy is paralysis of, I've already said, lower motor neuron 7 nerve palsy, right? Yes. Patient with Bell's palsy, all are true except immediate surgical decompression, acute onset unilateral palsy, herpes simplex virus is the cause, steroid is the choice of treatment. So here the right answer is acute onset unilateral palsy, that is right. Herpes simplex virus is also right. Steroid is choice of treatment, that's also right. So here it is not true about what? Bell's palsy, right? Immediate surgical decompression is not required, right? Now moving further, all of the following are seen in Bell's palsy except ipsilateral facial palsy, yes it is seen. Ipsilateral loss of taste sensation, ipsilateral ptosis. Okay, now here ipsilateral ptosis is not seen, right? In Bell's palsy, because of involvement of facial nerve, the muscle of ipsilateral face are paralyzed, which leads to complete closure, which lead to incomplete closure of eye, but not, that's not ptosis, right? Ptosis is seen in third nerve palsy, not here. Hyperacusis of Bell's palsy is due to paralysis of following muscle. Now the hyperacusis of what our this Bell's palsy, in Bell's palsy is due to the paralysis of which muscle? That is our stapedius muscle, right? Stapedius muscles. Hyperacusis is normal sound perceived as abnormally loud. This is due to loss of stapedial reflex. In Bell's palsy, this is due to paralysis of facial nerve which supplies stapedius, right? Which of the following is not true of Bell's palsy? Acute onset, that's right. Always recurrent. Okay, that can be a discussion. Spontaneous re-emission, increased predisposition in diabetes mellitus. So here it is not always recurrent, right? Recurrence is uncommon. There may occur spontaneous re-emission, but steroids are very important in management, right? True about Bell's palsy is heart, most common cause of facial palsy, that's right, associated with diplopia. Yes, that is also right. It is associated with diplopia also. Crocodile tear and synkinesis may occur. That's also right. These are the complications that may right. No role of steroid. Okay, there is no role of. Okay, there is. Okay, now here the most common cause of facial palsy. That's right. Talking about B option, it is associated with, no, it is not associated with diplopia. Crocodile tear and synkinesis. Yes, it is right. And no, there is no role of steroid. There is role of steroid. Prednisolone is given, right? The drug of choice can reoccur. Yes. So the right answer is A, right? C and E. So these are the right answer. Now moving further, true about Bell's palsy is spontaneous recovery. No. Yes, that's right. Spontaneous recovery. Steroid contraindicated. That's not right. 25% recover completely. That's also not right. Antibiotic ministry treatment. That is also not right. So spontaneous recovery is the right answer. Now moving toward the next question. This is our next question. Okay, now here, true about lower motor palsy of 7th knob. So here it is talking about what? It is talking about Bell's palsy one, right? Other motor knob, other motor cranial knob are also involved. We are not clear about it. Mcqs syndrome may cause recurrent paralysis. Okay. So now here, true about lower motor palsy of 7th knob, other motor cranial knob are also involved. Yes, it is right. The Mcqs syndrome cause recurrent paralysis. That is also right. Recurrent alternating facial palsy. Right. There will be fissure, tongue, facial level edema, familial history. Now eye protection is done. That is also right. Eye protection is done. Prognosis can be predicted by series electrolytical studies. That is also right. Bell's palsy is common because that's also right. So these are all what? These are all true about lower motor palsy of 7th knob. Which one of the following statement truly represent Bell's paralysis? Facial knob paralysis and contralateral hemiparesis. Contralateral hemiparesis. No, that's not true, right? Combined paralysis of facial, trigeminal and abducens knob. That's also not right. Idiopathic ipsilateral paralysis of facial knob. That's right. Another option, facial knob paralysis with uveitis and parotid enlargement. That's also not right. So our right answer is option number C, right? Now Bell's palsy patient comes on day 3. Treatment would be, what will be the treatment? If the patient comes in day 3, obviously we know that oral steroid are given, right? Oral steroid are given. Similarly, viral are also given. So here oral steroid and acyclovir. Now what will give in oral steroid? Prednisolone, 1 mg per kg in 2 doses for 2 to 3 weeks. Similarly, acyclovir, 200 to 400 mg 5 times per day for 7 days, right? It will be what? Spontaneous recovery, but we need to give this also, right? This also. So eye care is also important along with it, right? Similarly, physiotherapy is also important. Facial massage, electrical stimulation of facial knob and muscle, facial knob decompression, right? It is a bit controversial. Now if Bell's palsy is not responding to steroid, right, next management will be electrophysiological knob testing, right? That is what we need to do. Now moving further, Bell's palsy not responding to steroid, what will be the further line of management? We have already said electrophysiological knob testing, right? Electrophysiological knob testing. Now if on electrophysiological knob testing the sign of regeneration are not present, surgical decompression is indicated. And talking about this vasodilator and ACTH, these have no role, right? Now the physiotherapy is started from day 1 itself while treating Bell's palsy, right? Okay. Now increased dose of steroid. Now here the steroid in Bell's palsy are given in dose of 1 mg per kg body weight and gradually is tapered. There is no response. If there is no response, electrological knob testing is done, right? Okay. Ramsay-Hunt syndrome is caused by, Ramsay-Hunt syndrome is caused by herpes zoster, right? It is caused by herpes zoster. Now simply a man presents with vesicles over external acoustic meatus, right, with ipsilateral facial palsy in lower motor neuron type. Okay, the man present with vesicle over external acoustic meatus with ipsilateral facial palsy of lower motor neuron type. The cause is what? The cause is obviously herpes zoster, or what it causes? It causes Ramsay-Hunt syndrome. Is underlying condition, right? It is the underlying condition. Now talking about herpes simplex virus, right, is found to be associated with Bell's palsy in some patient, but there are no vesicle eruption in Bell's palsy, right? But here it is talking about vesicle eruption, right? Remember, herpes simplex virus, it is the cause of what? Our Bell's palsy, and herpes zoster, it is the cause of what? Ramsay-Hunt, right? Ramsay-Hunt syndrome. Now all are true about Ramsay-Hunt syndrome except, right? All are true of Ramsay-Hunt syndrome except, right, involves 7th nerve. That's right, it involves the 7th nerve, right? Similar, it may involve 8th nerve. Yes, it may involve 8th nerve. Surgical treatment gives excellent prognosis. That is not right, right? Causative organ is virus, that is herpes zoster. So answer number C is the right answer. Which of the following are true for Ramsay-Hunt syndrome except? It has viral etiology. That's right. Involves 7th nerve. That's also right. May involve 8th nerve. That's also right. Result of spontaneous recovery are excellent. That's not right. Right, that is not right. Iatrogenic treatment, traumatic facial nerve palsy is most commonly caused during. Iatrogenic traumatic facial nerve palsy is most commonly caused when? It is most commonly during the time of mastoidectomy, right? The most common iatrogenic cause of facial nerve palsy is parotid surgery, right? The next most common of iatrogenic cause of facial nerve palsy is mastoid exploration, that is mastoidectomy, right? Okay. Which fracture of petrous bone will cause facial nerve palsy more commonly? Which fracture of petrous bone will cause facial nerve palsy more commonly? Okay, now here the transverse fracture will cause facial nerve palsy more commonly, right? Okay. Now, moving further, which is correct statement regarding facial nerve palsy in temporal bone fracture? Now, more common with temporal transverse fracture, more common with longitudinal fracture, right? Now here it is more common with transverse fracture, just above the question, right? Similar to above question. CSF otorrhea is caused by fracture of what? Now it is caused fracture of what? Petrous temporal bone. Petrous temporal bone, right? Rhinorrhea because of cribriform plate, but otorrhea, petrous temporal bone, right? Petrous temporal bone. The most common cause of cerebrospinal fluid otorrhea is, we have already said what? Fracture of what? Petrous ridges or fracture of petrous temporal bone. Treatment of choice for temporal bone fracture with facial nerve palsy is, temporal bone fracture with facial nerve palsy is, what we can do here is nerve decompression, right? Treatment of choice for temporal bone fracture with facial nerve palsy. Now in sudden onset complete palsy following fracture, which is the common presentation, early exploration and decompression of facial nerve or nerve repair should be carried out, right? Okay. Treatment of choice in traumatic facial nerve injury is, what is the treatment of choice, right? Here what we can do is facial nerve repair, right? Facial nerve repair, since generally following trauma the facial nerve injury occur at sudden onset, so facial nerve facial decompression should be best option, right? Now in patient present with facial nerve palsy following head trauma with fracture of temporal bone, the best intervention here is, what is the best intervention, right? Facial nerve palsy following head trauma. Now here, right, immediate decompression, we have already said immediate decompression can be done. Now next question is our crocodile tear are due to cross innervation of facial nerve fiber, cross innervation of trigeminal nerve fiber, improper regeneration of trigeminal nerve, cross innervation of auriculotemporal nerve. So it is cross innervation of facial nerve fiber. Cross innervation of facial nerve fiber will cause what? Crocodile tear syndrome, that is gustatory lacrimation, salivary to lacrimal gland overcross, right? Similarly, there is another, that is Fraze syndrome, that is gustatory sweating, secretomotor to sympathetic crossover. Okay, Fraze syndrome is caused by, yes, we're talking about that thing, it is what? Abnormal. Okay, I have already just mentioned that secretomotor to sympathetic cross, right? So secretomotor to sympathetic cross. Okay, are the other option with sympathetic cross? No. So it is aberrant innervation of parasympathetic fiber of auriculotemporal nerve with sympathetic sweat gland, right? There will be gustatory sweating, right? Okay, two things. One is crocodile tear, that is gustatory lacrimation, salivary to lacrimal gland crossover, right? And phrase secretomotor to sympathetic crossover. For crocodile tear to occur, the injury should be, now it should be where? It should be at what hour? Before greater petrosal, what? Greater superficial petrosal, right? Okay, most accepted management of crocodile tear is, right? What is the most management? Now here the most management would be our injection botulinum toxin in lacrimal gland, right? The most accepted management, that is injection botulinum toxin in lacrimal gland. The best investigation for petrous temporal fracture is, what is the best treatment? The best treatment is HRCT. What is it? It is HRCT. Secretofiber of facial nerve does not supply. Secretomotor fiber of facial nerve does not supply parotid gland, right? Parotid gland. Here the lacrimal and our nasomucosal gland are supplied by greater superficial petrosal nerve, right? Lacrimal and our nasal are supplied by greater superficial petrosal nerve. Here submandibular gland and sublingual gland are supplied by coda tympani. Parotid is supplied by otic ganglion through auriculotemporal nerve, right? So secretomotor fiber of facial nerve does not supply what? Our this parotid gland, right? Now similarly, moving to our next question, that is lacrimal gland is supplied by. Now lacrimal gland is supplied by, right? It is supplied by what? It is supplied by sphenopalatine ganglion. Sphenopalatine ganglion. The level of facial nerve lesion with intact lacrimation on Siemers test. Loss of taste in anterior 2/3 of the tongue is, there will be intact lacrimation on Siemers test. That means sphenopalatine ganglion or ciliary ganglion was intact, but there is loss of taste in anterior 2/3 of tongue, right? It is because of what? It is because of lesion where? It is lesion in what? At the region of our horizontal segment, right? Horizontal segment. Now moving to our next question. The 2-month-old following parotid surgery patient present with flossing and sweating of cheek while having his meal. The following is false about this condition. Now here 2 months following parotid surgery patient present with flossing and swelling of cheek. Now here all are true except tympanic neurectomy is contraindicated. Okay, it is not true. Okay, due to faulty regeneration of parasympathetic nerve, that's true. Sternocleidoid mastoid flap is used in the treatment, that's true. Injection botulinum toxin is given, that's true. So here the false statement is tympanic neurectomy is contraindicated. Which is the mainstay of treatment for Bell's palsy? We have already said it is what? It is prednisolone, right? Fraze syndrome occurs due to damage to which nerve during parotid gland surgery? It occurs because of which it occurs because of our auriculotemporal nerve, right? Auriculotemporal nerve. Fraze syndrome. Fraze syndrome is due to cross connection of auriculotemporal nerve with which nerve after parotid surgery? We have already said sympathetic cholinergic nerve fibers, right? Fraze syndrome includes what? Gustatory sweating, right? The most appropriate treatment of facial nerve injury in lateral facial wound is, what is it? It is primary repair, right? Primary repair. It is primary repair. Any sudden onset palsy, right? Any sudden onset palsy following injury, iatrogenic or non-iatrogenic trauma, should be managed by immediate exploration and repair, right? Okay, now next question. The next question is, the facial nerve is related to which wall of middle ear during mastoid surgery? We all know that is what? Posterior wall. Facial nerve is related to which wall of middle ear during mastoid surgery? That is posterior wall, right? The nerve that supplies the skin over angle of mandible, if innervated, if involved in parotid injury, forms a part of anatomical basis of gustatory swelling, that is auriculotemporal, greater auricular nerve, right? The nerve that supplies skin over the angle of mandible, if involved in parotid surgeries, form a part of anatomical basis for gustatory swelling. That is what? That is greater auricular nerve. The nerve that supplies over the skin over the angle of mandible is greater auricular nerve. Sometime during parotid surgery, greater auricular nerve also get injured during auriculotemporal nerve. Along with auriculotemporal nerve, in this situation, the aberrant regeneration of auriculotemporal nerve, the parasympathetic fiber to salivary gland become aberrantly connected with sympathetic cholinergic fiber to sweat gland of his skin overlying the parotid as well as overlying the angle of mandible. That is territory of greater auricular nerve, right? The patient, now here we have already known, comes in day 3. The treatment would be, what is this? This is obviously our Bell's palsy, so oral steroid plus acyclovir, right? Patient present with lower motor neuron facial nerve palsy along with pain in ear. The appearance of ear is given. The following is true about the disease. Now here, okay, now the following is true about the disease. Now here, the treatment about is, it occurs because of what? It occurs because of due to reactivation of herpes zoster virus in genicular ganglion, right? Okay. Now this was what? This was our last question from what? From facial nerve, what? Facial nerve disorders. So now we are going to talk about the MCQ from tumor of axonal and middle ear. Now here, without delay, let's move to the first MCQ, that is surface ear is, that is exostosis. The most common benign tumor of middle ear is, that is glomus tumor, right? Now here similarly acoustic neuroma, it is the most common benign tumor of CP angle. Similarly squamous cell carcinoma, it is the most common carcinoma of middle ear, and adenocarcinoma, it is the occasional glandular tumor of middle ear. All are the true about jugular glomerulate tumor except it is common in female. Yeah, that's right, right? The ratio is about 5:1. The cause, it causes conductive deafness, that's also right, that is unilateral deafness, right? Okay, now the disease, it is a disease of infancy. No, that's not right answer. It involves labyrinth, petrous, pyramid and masted. So here the answer is, it is disease of infancy. The true about glomus jugular tumor is, it is most common in female, it is most common in male. No, that's not right, right? Arise from non-chromaffin cells. Okay, okay, now here, yes, that is right. Lymph node metastasis is seen. No, it is not seen, right? Multicentric, yes, it is multicentric, right? We know that 10% tumor are familiar, right? 10% tumor are multicentric, 10% tumor are functional, and 4% tumor are metastatic. And fluctuating kinetics and conductive type of hearing loss is seen. Fluctuating tinnitus with conductive type of hearing loss is seen, that's also right, right? Okay, since, okay, now why lymph node metastasis is not seen? Because the glomus jugular is benign tumor, lymph node benign tumor, so lymph node metastasis is not seen, right? Which is pulsatile tumor found in external auditory meatus which bleeds on touch, right? The pulsatile tumor found in external auditory meatus, the pulsatile tumor is our only glomus tumor, right? The usual location of glomus jugular tumor is where? Obviously hypotympanium, right? Glomus jugular tumor, it arises from paraganglionic cells, right? Paraganglionic cells in relation to jugular bulb, which is related to floor of middle ear. Therefore, from floor it comes into hypotympanium. Pulsatile tinnitus in ear is due to, where it is due to what? Pulsatile tinnitus is due to glomus what? Jugular tumor, right? Odd symptom of glomus tumor is, what is the odd symptom? That is our pulsatile tinnitus, right? The oddest presenting symptom of glomus tumor are conductive hearing loss and pulsatile tinnitus. Similarly, moving to our next question that we have is the true about glomus jugular all except rising sun sign is seen. Yes, in glomus jugular the rising sun sign is seen. Red reflex through intact tympanic membrane otoscope, right? That is seen, right? Involves 9th and 10th cranial nerve. Okay, talking about cranial nerve that it will involve, it will involve what? 9th, 10th, right? Also 11th and 12th also. Pulsatile tinnitus is seen, usually invade epitympanium. Now, so it does not invade epitympanium. That's why the answer is number D. Polypoidal mass in ear on touch bleed heavily. The cause is, what is the cause? That is our what? Glomus jugular, right? Jugular. Now the brown sign is seen in, what is brown sign? Brownish sign or brownish pulsation sign on signalization. When ear canal pressure is increased with Siegel's speculum, tumor pulsate, engorges, and tumor blenches pressure release and tumor engorges, right? Pressure, when we pressure apply, at the time blanches, right, because it is vascular in nature. That is what that is shown by glomus tumor. Field sign is seen in, now what is field sign, right? Now field sign, okay, field sign is seen in, the field sign is seen in glomus jugular only, right? Now field sign is, it is what the field sign is our it is what it is CT finding, high resolution CT scan finding. That is there is what, there is one what our cortico carotico jugular spine, right? There is carotico, right, jugular spine, right, that helps to distinguish glomus tympanicum from what, that helps to differentiate, that helps to keep barrier between our internal carotid artery and jugular vein, right? Now what will happen is that during this our glomus glomus jugular, right, glomus jugular, this carotico-jugular spine, right, that was differentiating internal carotid artery and our jugular vein will what, will erode, right? Now this will erode, right, in glomus jugular, right? So now Phillips sign is seen in where, in glomus jugular, right? Now this Phillips sign is only the sign that helps in distinguishing glomus tympanicum from glomus jugular. There are two types of glomus tumor, that is glomus jugular and glomus tympanicum. So this Phillips sign is seen in glomus jugular, that will differentiate it from glomus tympanicum. The glomus jugular tumor compressing the carotid is diagnosed by I've already said what it, okay. Now here compressing the carotid is diagnosed by MR angiography, right? Magnetic resonance angiography is used to evaluate for the compression of internal carotid artery, right? Okay, the Fish classification is used for, now the Fish classification is used for what, our glomus tumor. Now what does this Fish classification, it says it divide what into what stage, okay, it divides into stage A, B, C, D1 and D2, right? Stage A, tumor limited to middle ear cleft, right? Stage A is tumor limited to middle ear cleft. B is tympanomastoid tumor sparing infralabyrinthine bone, right? Tympanomastoid tumor sparing infralabyrinthine bone. And C is our what, tumor tympanomastoid tumor eroding infralabyrinthine bone. And D1 is when there is intracranial extension, right? When there is intracranial extension less than 2 cm, that is D1, and intracranial extension greater than 2 cm, that is D2. So this is all about what Fish classification used in glomus tumor. The patient presents with bleeding from ear pain, tinnitus, progressive deafness. On examination, there is red swelling behind the intact tympanic membrane, which branches on pressure with pneumatic speculum. The management include all except. So here it is talking about what? It is talking about glomus, the different signs, the rising sun sign, the brownish pulsation sign, right? It is talking about that. So what are the management we can do? The management we can do is we can do surgery, we can do what? We can do radiotherapy, right? Similarly, we can do preoperative embolization we can do. So the all are the management except what? Interferon is not the management, right? Now the glomus tumor invading significant vertical part of carotid canal, it is okay if it involve the vertical part, that is type C2, right? Type C2. Okay. Now which of the following is cause of pulsatile tinnitus? We have already said glomus tumor. The patient present with pulsatile tinnitus and progressive deafness. Endoscopic picture of his tympanic membrane is given below. The red swelling blanches on pressure with pneumatic speculum. All are true except arise from non-chromaffin cells, that's right. Lymph node metastasis not seen, that's right. Rising sun sign is seen, that's right, right. Fluctuating conducting type of hearing loss is seen, so that's not right. So other all ABC option are right, but here the D option is not right, so answer is D. Which of the following is not site of paraganglioma? Which of the following is not site for paraganglioma, right? The geniculate ganglion is not site for paraganglioma, right? Pulsatile tinnitus is a feature of, it is a feature of glomus tumor. Okay, so this was all about the MCQ from what? Our tumor from what? Axonal and middle ear. Now we are going to talk about MCQ from the points of what? From the point of acoustic neuroma and vestibular sonoma, right? Now here, now without delay, let's begin from our first point, right? Now what is the most common cerebropontine angle tumor? And the first most common cerebropontine angle tumor is, what is it? It is acoustic neuroma, right? It is acoustic neuroma, right? Now here the next most common tumor is meningioma, right? Followed by what? Followed by our epidermoid, right? That is cholesteatoma. Now here the acoustic schwannoma most common site is, what is the most common site? We already said CP angle. Schwannoma most common involves the schwannoma, right? Vestibular schwannoma or acoustic neuroma, these are the same thing. It involves what? Vestibular part of which? Eighth nerve, right? Vestibular part of eighth nerve. That's why the acoustic neuroma is a misnomer, because it is what? Acoustic neuroma is a misnomer because acoustic, it does not involve the acoustic part, it involves the vestibular part, and it is not neuroma. That means it is not what? It does not arise from neuron cells, it arises from sonal cells, right? Okay. Now, and another thing is this vestibular schwannoma, right? Vestibular schwannoma is not capsulated tumor, right? And it is mainly what? Slow growing tumor arising from Schwann cell of vestibular division, mostly inferior part, right? Mostly inferior part. Okay. Now, about 80% of the CP angle tumor, right? Cerebropontine angle tumor are what? Are our what? Vestibular schwannoma, right? Similarly, in glomus tumor, we talked about glomus tumor. The glomus tumor was most common benign tumor of many layer, right? Most common benign tumor of many layer. So here next question, acoustic neuroma commonly arise from, we already said it arises from what? Inferior vestibular nerve, right? Okay, inferior vestibular nerve. The earliest symptom of acoustic nerve tumor is, it's talking about acoustic neuroma. The earliest symptom, what is the earliest symptom? Yes, the earliest symptom is our sensory neural hearing loss, right? Sensory neural hearing loss. Now talking about the clinical feature of our what? Our this vestibular schwannoma, right? The otological symptom, that is what? The initially there will be progressive unilateral sensory neural deafness, right? But in the case of glomus tumor, there was what? There was conductive deafness, right? And this sensory neural hearing loss is it is what? It is the earliest sign, right? Okay. Now other symptom are tinnitus, right? Tinnitus, mild vertigo, and nystagmus, right? Nystagmus, these are what? These are the feature of our this vestibular schwannoma. And there are other cranial nerve involvement also, which involves 5, 6, 7, 8, 9, 10, 11th cranial nerve, right? Okay, the earliest sign seen in acoustic neuroma is, what is the earliest sign? That is, okay, now here reduced corneal reflex is the what? Earliest sign, right? Now the reduced corneal reflex, that is because of what? Because of involvement of fifth cranial nerve, right? The first nerve to be involved is our fifth cranial nerve. Now since the fifth cranial nerve is responsible, trigeminal nerve is responsible for what? Corneal reflex. So the first earliest sign is loss of corneal reflex. Similarly, because of this trigeminal nerve only, there will be pain, numbness, paresthesia of face, right? Similarly, okay, that are the fifth cranial nerve in manifestation. In acoustic neuroma, cranial nerve to be involved or less is, we have already said what is the first cranial nerve to be involved, right? Okay. Okay, now here it is our fifth cranial nerve, right? Trigeminal nerve. In acoustic neuroma, cranial nerve to be involved earliest is, that is our fifth. Same question, earliest ocular finding in acoustic neuroma is, we have already said loss of corneal reflex, right? Loss of corneal reflex. Okay. Now another thing is, the true about CP angle tumor is, right? CP angle tumor is what? Absence of corneal reflex. Yes, that absence of, okay, it is talking about absence of corneal. Yes, we know what? Corneal reflex, because of what? Because of what? Involvement of fifth cranial nerve, right? Okay, in acoustic neuroma, all are seen except loss of corneal reflex, that is seen, tinnitus is seen, facial palsy is also seen because of what? Facial nerve involvement, right? Facial weakness or facial palsy, right? Okay. Now and bitemporal hemianopia, yes, it is not seen, right? It is not seen, right? Progressive sensory neural hearing loss, tinnitus, ataxia have been seen in elderly. This is the case of, we know, progressive sensory neural hearing loss, tinnitus. These are seen where? These are seen in vestibular schwannoma or acoustic neuroma. 70-year-old men presented. Okay, what is the age distribution? It is around 40 to what? 40 to 70 years of age, right? Age presentation, right? Okay, and the male is to female ratio is 3:2, right? And another thing is 90% of the cases are unilateral and 10% of the cases are bilateral, right? Okay. Now here the 70 years old male presented with loss of sensation in axonal auditory meatus, right? That's Herschel-Berger sign positive. The likely diagnosis is, okay, talking about ESC, in ESC, right? Talking about in ESC, posterior superior region of ESC. Posterior superior region of ESC is supplied by 7th nerve. right? Seventh nerve, cranial nerve, that is facial nerve. That the seventh nerve is what? It is what there is in defect in the seventh cranial nerve in case of vestibular schwannoma. And because of this defect in seventh cranial nerve in vestibular schwannoma, what will happen is that this region, posterior superior region of axon auditory meatus, will be what? Hypo, right? Hyposensitive. That means there will be loss in sensation in posterior superior region, right? That is our Hertzberger sign, right? It is seen in the case of vestibular schwannoma. Okay. Acoustic neuroma causes what? It causes cochlear deafness. Yeah, it causes what? Sensory neural hearing loss, right? Sensory neural hearing loss. So here can we say cochlear deafness? No, we can't say cochlear deafness because it is not directly affecting cochlea. Retrocochlear deafness, yes, we can say retrocochlear deafness, right? Conductive deafness, no, right? Any of the above, no, right? It arises from what? Internal acoustic meatus, right? Right. The acoustic neuroma arising in internal acoustic meatus compresses cochlear nerve, and therefore patient presents most commonly with unilateral retrocochlear hearing loss, usually slow progressive. That's why it is retrocochlear deafness, right? In patient with acoustic neuroma, all are seen except reduced coronal reflex is seen, unilateral deafness is seen, cerebellar sign. Are cerebellar sign seen? Yes, ataxia guide, right? Fall on affected side, intentional tumor, post panting, right? Dysdiadokinesis, these are what? Cerebellar involvement, right? These are seen. Acute episode of vertigo, is it seen? No, it is not seen, right? It is not seen. So this is the right answer. The acoustic neuroma causes the following except it causes ptosis. It causes ptosis or not? Okay. It causes ptosis? No, it does not cause ptosis, because for ptosis third nerve involvement is required, and third nerve involvement is seen in vestibular schwannoma. No, it is not seen in vestibular schwannoma. It is seen where? It is seen in the case of what? Here only, right? No, okay. Ptosis is not seen here, right? Ptosis is not seen here. The third nerve involvement is seen here, but third nerve involvement, right? The ptosis is not seen here, right? Ptosis is not seen here. Okay. Now moving further, vestibular schwannoma does not not correct. About vestibular schwannoma, which is not correct? Facial numbness, yes. Seventh nerve, sensory neural deafness, yes. Absence of VMP response, that's right. Normal corneal reflex is not right, right? It is not right, right? Normal corneal reflex is not right. Now, in patient of acoustic neuroma, corneal reflex is absent in applied implementation of cranial nerve, which fifth, we know about that, right? Now moving further, the true about acoustic neuroma is malignant tumor. Is it malignant tumor? Is it malignant tumor? No, right? Misnomer, UMA is there. It is misnomer, right? Arise from vestibular nerve. That's right. Arise from vestibular nerve. Is it arising from vestibular nerve? Yes, it is arising from vestibular nerve or vestibular Schwann cells. Upper pole comprises of 9, 10 and 11 nerves. No. Lower pole compresses, right? Sorry, upper pole compresses 9, 10, 11 nerve. No. Lower pole compresses trigeminal cranial nerve. No, right? Okay. The arising from vestibular schwannoma is the right answer, right? Going further, the acoustic neuroma of 1 cm diameter, the investigation of choice is in the case of 1 cm diameter, right? The investigation of choice is, that is MRI, right? Even a very small asymptomatic lesion can be observed by MRI, right? MRI scan. Similarly, a patient suspected to have vestibular schwannoma, the investigation of choice for the diagnosis, our word, it is gadolinium contrast, right? Gadolinium enhanced MRI, right? It is the gold standard one, right? And it is not just here, right? Here, but also in MRI, it is also what? Investigation of choice in the case of glomus tumor, right? In the case of glomus tumor. Now, moving further, right? Gadolinium enhanced MRI is the right answer. Treatment of choice for acoustic neuroma. What is the treatment of choice? Okay, talking about the treatment, right? What is the treatment of choice? The treatment of choice is surgical excision, right? Surgical excision. Okay. But here, if the individual is what? Old age, greater than 60 years old, right? Tumor only now in such case, right? Tumor in only hearing and better, if only in 1 year and another there is better year, right? Now here in this condition, observation is the best, but microscopic removal, right? The surgical excision is the what best, what it is the what treatment of choice. Which of the following would be the most appropriate treatment for rehabilitation of patient who has bilateral profound deafness following surgery for bilateral acoustic neuroma? Now, what is the best method of rehabilitation, right? The best method of rehabilitation is brain stem implant, right? Brain stem implant, right? Since it is retrocochlear, right? Acoustic neuroma is what? Retrocochlear pathology. Hearing aid and cochlear implant will not help, right? Rehabilitation of hearing is done by auditory brain stem implant, ABI, right, which is placed in lateral recess of fourth ventricle where it directly stimulates the cochlear nuclei. So brain stem implant, right, is the what rehabilitation method. Hertzsprung sign is seen in, I have already said about Hertzsprung sign, it is seen in what? Acoustic neuroma, right? Okay, now moving to our next question. The true about vestibular schwannoma is unilateral hearing loss is commonly presented. That's right. Mostly malignant? No. Most commonly benign tumor of CP angle, right? Sensory neural deafness, right? Non-capsulated, that is also right. Beta is reliable indicator in diagnosis of, right? Beta is reliable indicator in diagnosis of our vestibular, sorry, okay, where it is in the case of acoustic neuroma, right? But here acoustic schwannoma, right, it is also the same thing. Beta, in which the wave, what wave, fifth wave has greater than 4.2 milliseconds, right? That is what, that is the value of beta, right? It is reliable indicator in diagnosis of acoustic schwannoma. In 70-year-old male presented with left sensory neural hearing loss and tinnitus. On examination, there is loss of sensation in posterior superior part of external auditory meatus, that is Hertzsprung sign, right? His MRI shows below. Most probably the diagnosis is, we know the diagnosis is acoustic neuroma, right? The above patient was operated. The biopsy specimen histopathology will show what it will show. It will show Antony A and Antony B pattern, right? Antony A and B cells. Now, what are Antony A? The Antony A are what? These have closely packed cells. These are closely packed cells. Cells are small spindle shape and have dentally stained nuclei and are called Verroche body, right? And talking about Antony B, these are closely packed, these are loosely packed cellular aggregation of vacuolated polymorphic cells, right? Okay. Now, okay, moving further, the next question is, okay, these are all about the question of acoustic neuroma, right? Now we are going to solve MCQ from the topic cochlear implant and brain stem implant, right? The father of neurootology. Who is the father of neurootology? The father of neurootology is William F. House, right? William F. House. In the case of bilateral profound hearing loss, what should be done? Bilateral profound hearing loss, right? What can be done? What should be done? The cochlear implant should be done, right? Okay, cochlear implant is to be done if the following is intact, right? If the following is intact, that is auditory nerve is intact. If auditory nerve is intact, cochlear implant is done when a defect lies in organ of Cotai, right? Okay. Now all are true about cochlear implant except, now all are true about cochlear implant are true except, now here minimum age is 1 year, yes. PTA of 70 decibel or more, that is also right, right, about cochlear implant. Switch on is done after 3 weeks, that is also right, right. And MRI has no role in preoperative assessment, no, that is not right. So here the answer is option number D, cochlear implant, right? Okay, cochlear implant. Now talking about what the indication of cochlear implant, right? Now severe to profound. Okay, what are the indications are severe to profound, what? Severe to profound sensory neural hearing loss, that is around what, 70 decibel in what, decibel in adult and 50 decibel in what, in child, right? Similarly, poor speech perception, what, that is SDS, right, that is less than 20 to 30% in such case. And there is, if there is no improvement with hearing aid, right, and if the age is 1 year or old, right, minimum age is 1 year, right, and the priority is given to postlingual deaf child already who have developed what, who have developed voice. So here we talked about indication, that is what, in adult sensory neural hearing loss in adult 70 decibel, right, in children 50 decibel. Similarly, poor speech perception, that is STS, is less than 20 to 30%, right, 20 to 30%. No improvement with hearing aid. Age is less than age is greater than 1 year, right, minimum age is 1 year. That is what, that is the indication, right. Okay. Now, the cochlear implant electrode are most commonly introduced through, we have already known about it, that is through round window, right. Now, cochlear implantation, which part is placed inside the ear? Now, before getting into the which part is placed inside the ear, there are what, there are external part and internal part. Talking about external part, right, the external part are microphone, right, microphone, speech processor, right, and we have what, transmitter, microphone, right, the external part microphone that will receive the sound. Now, that is speech processor, right, and another is transmitter that will transmit the sound, right. Okay. And talking about the internal part, now obviously internal part, what, that internal part consists of what, receiver, stimulator, right, stimulator. We have got electrode array, right. Now this electrode electrode array, right, it is what, it is placed inside the ear, right, it is placed inside the ear. Okay. So the cochlear implantation, which part is placed inside the ear, that is the part of internal part, that is what, electrode array, right, electrode array. The cochlear implant electrode are placed in, where they are placed, they are placed in scala, what, scala tympani, right, just behind our round window. 3-year-old Rajan is having sensory neural deafness, not benefited by hearing aid. The next best management is, we have already said, if not benefited by what, if not benefited by cochlear not hearing aid, then we can do cochlear implant. Regarding cochlear implant, which of the following is true? Not contraindicated in cochlear malformation, right. Is it contraindicated? No, not contraindicated in cochlear malformation. This is true, right. Contraindicated in less than 5 years, no, right. Minimum age is 1 year. Indicated in mild to moderate hearing loss, no. In severe, right, 70 decibel and 50 decibel in adult and children respectively. Implanted through oval window, no. So the right answer here is not contraindicated in cochlear malformation, right. All of the following statement are what, true about cochlear implant except, right, all of the following about cochlear implant are true except which is false. It is asking improved speech and sound perception. Is it true? It is true, right, it improves sound and speech and sound perception. Better chance of acquiring normal or near normal verbal skill, right. It is true or not? It is also true, right, better chance of acquiring normal or near normal verbal skills. Improved sound localization and discrimination is possible. That is also what, that is also right, right. Tinnitus enhancement in patient with tinnitus prior to implementation, is it right? No, it is not right. So it is not, it has no relation to tinnitus, right. Moving to our next question, which of the following would be most appropriate treatment for rehabilitation of patient who has bilateral profound deafness following surgery for bilateral acoustic schwannoma? Right, now here, which is the most appropriate treatment of rehabilitation of patient who has bilateral profound deafness following surgery for bilateral acoustic schwannoma? Now here, what is the best rehabilitation method? The best rehabilitation method is brainstem implant, right. Okay, 2-year-old child was planned for brainstem implant. All are indication of brainstem implant except. Now here we are talking about what, brainstem implant, right. Now talking about brainstem implant, okay. Now here all are the indication except, right. Now bilateral neurofibromatosis, yes, it is the indication, right. Absence auditory knobs, it is also. Absence cochlea, yes, it is also, right. Mondini deformity, no, it is not. In Mondini deformity, the defect is in cochlea, right. In Mondini deformity, the defect is in cochlea, which can be corrected by cochlear implant, not by what, not by brainstem implant, right. So that is the right answer. Okay, now moving further, Baha is used for conductive hearing loss with the following. Now talking about the indication of Baha, right. The first one is, let's talk initially the EAC atresia, right, atresia, action auditory canal atresia. Another is anosia with what, with hearing loss, right, hearing loss. anosia with hearing loss, absence of pinna with hearing loss in that also. That means in case of ESC atresia, ESC atresia, it is all we are talking about ESC atresia, ESC stenosis, right? ESC stenosis. Similarly, another is chronic discharging ear, right? Similarly, unilateral sensory neural hearing loss, right? That is cross, right? Cross will happen here, right? Crossing will happen, by crossing it will reach into another. And okay, these are the indication. Now what are the indication of bone anchored hearing is BAHA, right? The indication is ESC atresia, ESC stenosis, anosia with hearing loss, another is what, our chronic discharging ear, right? Unilateral sensory neural hearing loss. So here now let's go into the question. BAHA is used for conductive hearing loss with the following: cochlear malformation. We talked about cochlear malformation? No, we did not talk. Sensory neural hearing loss, we talked about it, but unilateral, right? Bilateral acoustic impairment? No. Atresia of axonal ear? Yes. Atresia and stenosis of axonal ear, in that case we can do it, right? And it is mainly done in the case of age greater than or equal to 6 years, right? Because that is the time period when adequate bone thickness of skull will meet, right? Okay, going further, a newborn presents bilateral microtia and external auditory canal atresia. The corrective surgery is usually performed, okay, I have already said, right? At around 6 years the child gets the bone maturity, so at that time we can do BAHA, right? BAHA. So it is 5 to 7 years of age, right? The internal device for cochlear implant is, I have already said, what is it? The internal device. In internal device we have two things: receptor stimulator, right? And another is electrode array, right? Electrode array, receiver stimulator and electrode array. So receiver stimulator is the right answer, right? Okay, moving further, what we have next one? Okay, now a cochlear implant is device designed to create alternate hearing pathway for people of all age with bilateral severe profound sensory neural hearing loss, right? Which of the following normal structure of ear are directly stimulated by electrode, right? Which of the structure are what? Which of the following normal structure of ear are directly stimulated by the electrode? These are what? These are auditory nerve. Auditory nerve are directly what? Stimulated by electrode. The minimum age by which intervention should be ideal be placed if prelingually deaf child is to acquire language in manner as close as possible to normal child in terms of both speed and completeness of development, right? Minimum age, what is the minimum age, right? Okay, the minimum age is 1 year, right? The 1 year for what? For cochlear implant. Cochlear implant convert which form of energy to which form? We know it converts sound energy into what? Into electrical energy, right? Sound energy into electrical energy. So the right answer is sound energy into electrical impulses, right? Similarly, indication of BAHA is, right? We have already said, right? Indication of BAHA is congenital canal atresia. We talked about canal atresia, right? Yes, it is. Bilateral hearing loss, bilateral hearing loss, no. Unilateral sensory neural hearing loss, that's not right. Sensory neural hearing loss, unilateral, right? So here the right answer is A, right? A. The electrode of cochlear implant stimulates. Cochlear implants electrode stimulate what? It will stimulate, we have already said, auditory nerve, right? This is showing, right? What is this showing? This is what? Our question number 21. What is it? It is our BAHA, bone anchored hearing aid, right? It is made up of titanium. It will conduct sound by direct to bone conduction, right? Via bone to inner ear, right? It will bypass what? External auditory canal and middle ear. Okay, the modality of rehabilitation for child with anosia is, we have already said anosia. What is done in, what is there? That is BAHA. The below is passed into inner ear through. Now it is passed into inner ear through, right? It will pass to inner ear through what? It will pass to inner ear through round window, right? Round window, right? Okay. The below is passed into middle ear through. Now in middle ear, it is talking about in middle ear, and into middle ear it will pass through facial recess. Through if it is to be passed into middle ear, that will pass through what? Facial recess. And if it is to be passed into inner ear, it will be passed through round window, right? In inner ear through round window, in middle ear through facial recess. Bone anchored hearing aid BAHA can be used in for the following, right? 50-year-old male with bilateral profound hearing loss, bone anchored hearing aid, right? Okay, now is it used in 50 years old individual, right? No, it is not used. In 6-year-old female with bilateral SOM, chronic discharging ear, right? Okay, it is also not absolutely right. 7-year-old child with bilateral microtia, okay, bilateral microtia, canal atresia, congenital hearing loss. So here this is what, this is the what suitable candidate, right? 25-year-old, no, it is also not. So the right answer is option number C. In which device is shown here? Now here we know which device is shown here. Here it is cochlear implant, right? Cochlear implant is shown here. Similar, next question, total number of electrode in new cochlear implant is, what is the total number of electrode? Yes, that is 24. In ABI, right, the ABI is placed in which of the following area, right? Now it is placed in what? Lateral recess of fourth ventricle, right? Lateral recess of fourth ventricle. The ideal time of treatment of hearing loss for language development is, what is it? It is 6 months, right? 6 months. Cochlear implant is done in at 1 year, but prior to that, hearing aid or BAHA soft band is given as early as possible, right? That is around 6 months. So this was all about what? This was all about the question from cochlear implant and what? Brainstem implant. The topic of which we are going to cover MCQ is from what? Congenital lesion, anatomy and physiology of nose, right? Congenital lesion, anatomy, physiology of nose. The first question is commonest presentation of infant with bilateral choanal atresia, right? The right answer is difficulty in breathing. Choanal atresia is associated with what? Colobomatous blindness, heart disorders, ear disorder, cranial nerve lesion, right? Okay, these are what? These are the association of choanal atresia. So the right answer is A, B, D and E. Colobomatous blindness, heart disease, ear discharge, ear disorder, cranial nerve lesion. Here the renal anomaly is not the right answer. It is urogenital anomaly, not renal anomaly. 2-year-old child is brought to hospital with a compressible swelling at the roof of nose, right? Roof of nose. See the clinical picture. The most likely diagnosis is, what is the most likely diagnosis? Since it is present where, okay. Now here, since it is present right here, right, it can be what? The most common diagnosis is, what is the most common diagnosis? It is meningoencephalocele, right? 2-year child with compressible swelling at the root of nose is likely meningoencephalocele, right? Now talking about this lacrimal sac cyst, it occurs as compressible swelling near the medial canthus, right? Okay, and talking about what? This ethmoid sinus cyst, present as a swelling at medial quadrant of orbit, pushing orbit forward and laterally, right? Okay, true about nasal glioma, right? 60% are extranasal. CT provides the bony detail and MRI differentiate between glioma and nasal encephalocele. That is what? True about what? Nasal glioma. External nose is formed by, what? It is formed by our, how many? 3 paired and 1 unpaired cartilage, right? 3 paired and 1 unpaired cartilage, right? The osteocartilaginous junction on the dorsum of nose is, osteocartilaginous junction, bone and cartilage junction on the dorsum of nose is, what is it? It is our rhinion, right? Rhinion is the osteocartilaginous junction. Okay, moving further, that is our nasal valve is formed by all except, it is formed by nasal valve, right? It is formed by septum also. It is not formed by middle turbinate, right? It is formed by lower end of upper lateral cartilages, inferior turbinate, right? Not middle turbinate. Inferior turbinate, septum, lower end of upper lateral cartilage. Choana is what? Posterior near. Ethmoid bone forms all except, okay, ethmoid bone forms all except superior turbinate, middle turbinate, inferior turbinate. No, inferior turbinate is separate bone. On-stent process is also the part of ethmoid bone. The inferior turbinate is, it is separate bone. Which of the following is known as fourth turbinate? Okay, the fourth turbinate is our supreme turbinate, right? Supreme turbinate. Turbinate that articulate with ethmoid is what? Inferior turbinate. Not other, because superior, middle, these are itself a part of what? Ethmoid bone, right? So inferior turbinate articulates with inferior turbinate articulates with ethmoid. All these structures are found in lateral nasal wall except, right? Lateral nasal wall. Superior turbinate, it is found. Agar nasicels, it is also found, right? Hasner's valve, it is also found. Vomer, it is not found, right? Vomer is independent separate bone which forms posterior inferior part of septum proper, such that medial wall of nose. It is not found on lateral wall, it is found in medial wall, right? The nasolacrimal duct opens into, it will open into what? Right? Inferior meatus. Nasolacrimal duct opens into inferior meatus, right? Okay. Now, okay, the direction of nasolacrimal duct is what we are going to remember. We are going to remember date of birth, right? DOB, that is downward, outward. Outward means what? Lateral, right? And B, backward. Okay, that means the option number what? B is the right one. Downward, backward, and lateral. Paranasal sinus opening into middle meatus is, okay, into middle meatus, anterior group of paranasal sinuses open, like maxillary sinus, anterior ethmoidal sinus. Not, it is not posterior ethmoidal sinus. The frontal and sphenoid, yes, frontal sinus will what? Open, right? This will open. Okay, all drain into middle meatus except, right? Middle meatus. Maxillary sinus, yes. Frontal sinus, yes. Ethmoidal sinus, yes, but not nasolacrimal duct because it drain into inferior meatus. Frontonasal duct open into frontonasal duct, right? Here it is talking about what? Okay, the frontonasal duct opens into, it will open into middle meatus, right? Middle meatus. Now moving further, the frontal sinus drain into, we already talked about it, that is middle meatus. The maxillary sinus open into middle meatus 8. Maxillary sinus open into middle meatus 8, it will open into what? 8 infundibulum, right? The hiatus similaris is present in, where is hiatus similaris is present? Now it is present in middle meatus, right? Bulla ethmodalis is seen in, now where is bulla ethmodalis seen, right? It is also seen in middle meatus, bulla ethmodalis and hiatus similaris. Osteometal complex connects, what it will connect? Osteometal complex, it will connect what? Nasal cavity with maxillary sinus, right? The opening of posterior ethmoidal sinus is anterior, we said that is middle meatus, right? Now what is the posterior ethmoidal sinus? Opening of posterior ethmoidal sinus, that is our, right? What is it? It is superior meatus, right? Posterior ethmoidal sinus is superior meatus. Sphenoidal sinus, now what about the sphenoidal sinus, which is also not opening into middle meatus, right? The opening of sphenoidal sinus is sphenoethmoidal recess, right? Sphenoethmoidal recess. The sphenoidal sinus open into sphenoethmoidal recess just above superior turbinate, right? Superior turbinate. Okay, which of the following bone do not contribute to nasal septum? Okay, right? Nasal septum, that is our lacrimal bone, right? Lacrimal bone is exclusive to what? Lateral wall. Similarly, vomer is exclusive to medial wall, right? Okay, the shape of septal cartilage is, what is the shape of septal cartilage? Quadrangular. The quadrangular cartilage is attached to all of the following except, it is attached to all of the following except sphenoid, right? It is posterior mostly present. The nasal septum, right? The nasal septum is supplied by, it is mainly supplied by what? It is mainly supplied by our external carotid artery, right? It is mainly supplied by external carotid artery, right? Okay, the artery which do not contribute to Little's area, okay, the artery which do not contribute to Little's area is our what? Posterior ethmoidal artery. Other all sphenopalatine artery, right? Our anterior ethmoidal artery, superior labial branch of facial artery, these all contribute to Little's area, right? Now anterior ethmoidal artery arise from anterior ethmoidal artery, okay, anterior ethmoidal artery, it arises from, where it arises from? It arises from ophthalmic artery, right? It arises from ophthalmic artery. Ophthalmic artery, there are two branches, anterior ethmoidal and posterior ethmoidal. Posterior ethmoidal do not contribute to Little's area, anterior ethmoidal only does. The first paranasal sinus to develop at birth is, we need to remember, MESF, right? The first paranasal sinus to develop at birth is, what is the first paranasal sinus, right? That is our maxillary sinus, right? Okay, the sinus not present at birth is, okay, sinus not present at birth is, that is frontal sinus. That is the most late sinus, or that will attain its maturity as it was at puberty. The least common sinusitis is, what is the least common sinusitis? Okay, that is our sphenoid sinusitis. The true about sphenoid sinus is lined by stratified squamous epithelium, right? Okay, is it lined by stratified squamous epithelium? No, right? Duct open into middle meatus, that's also not right. Open into sphenoid model, this is right. Present at birth, that's right. Present in greater wing of sphenoid, not right. So the C and D are the right statement. The which sinus is not present, which sinus is not the part of paranasal sinus? Frontal it is, sphenoid, ethmoidal, piriform is not the part. The most superior sinus in the face is, what is the most superior sinus in the face? Okay, we know that is frontal sinus, right? The anterior fistula is most common after extraction of, and antral fistula is most common after extraction of which one? That is first molar, right? First molar, antral fistula, right? A and the first, right? Opening of maxillary sinus is A at the first molar and second premolar. That is also important. The opening of maxillary sinus is at what? At the what is at first molar and second molar, right? Second premolar. The maxillary sinus achieves maximum size at, it achieves maximum size where? It achieves maximum size at secondary dentation, right? It achieves maximum size at secondary dentation. Okay, Odini cell and Haller cells are seen in relation to Odini cell, O for optic nerve, right? ON for optic nerve. So optic nerve is right answer, and Haller cells are for floor of orbit, right? So the option number A is the right answer. The pain sensation from ethmoidal sinuses are carried by, what? Okay, these are carried by nasociliary nerve, right? These are carried by nasociliary nerve, ethmoidal sinus. The ciliary movement rate of nasal mucosa is, what is the ciliary mucosal movement rate of nasal mucosa? These are 5 to 10 mm per minute. These are what? 5 to 10 mm per minute. Okay. The further question, the function of mucociliary action of upper respiratory tract is, what is the function? Okay, temperature regulation, is that the function? Okay, let's go other. Increased velocity of inspired air traps the pathogenic organism in inspired air. That is the what? The most important function of upper respiratory tract. The movement of mucus in air is by, okay, the movement of mucus in air is by what? It is by mucociliary action, right? Mucociliary action. During inspiration, the main current of airflow in normal nasal cavity is through what? What is the, where the mean current of air flows in nasal cavity? In the middle part of cavity in parabolic what manner, right? In middle part of cavity in parabolic curve. The main current of airflow, right? Airflow of nose is in parabolic curve, both during inspiration and expiration, right? The odor receptor is present in, right? Odor receptor is present in, they are present where? In olfactory epithelium, right? Olfactory epithelium. Anosmia is common, and it is common in coryza also, atrophic rhinitis also, fracture of cribriform plate also. So these are the right answer, right? In coryza also, right? In atrophic rhinitis also, in fracture cribriform plate also. Parosmia is what? The perversion of smell sensation. Parosmia means the perversion of smell sensation, right? Is what? Here the good smell appears bad, right, to the patient, right? Okay, perversion. Which of the following syndrome is associated with anosmia, right? The syndrome that is associated with anosmia is our Coleman's syndrome. Coleman's syndrome, right? The nasal cycle is cyclic alternate nasal blockage occurring how many, right? Cyclical alternate nasal blockage occurring every what? Every 5/2 to 4 hours, right? That is 2.5 to 4 hours, right? Okay, that is what? That is our what? The nasal cycle, right? The cyclical alteration of nasal blockage. All are true about nasolabial cyst except, right? All are true about nasolabial cyst except, right? Arise from adenoid epithelium, No, that is not the right answer. That's right. Present with swallowing in anterior nasal floor, that is right answer. Unilateral, that's right, usually seen in adults, so the right answer is A. Thoricum speculum is used to visualize. We know thoricum, right? Vana and thoricum, they are used to visualize anterior nasal cavity, right? Okay, so the right answer is anterior nasal cavity, which is not visualized on posterior rhinoscopy, right? On posterior rhinoscopy, which is not visualized, that is our what our structure that is not visualized is our superior concha, right? Superior concha is only seen at the time of what? Nasal endoscopy, right? Nasal endoscopy. The pneumatization pattern of sphenoid sinus are all except precellular concha, postcellular and conchal, right? Concha bullosa and conchal. So here it is concha bullosa is not what the pneumatization pattern, right? These are what the pneumatization pattern of the concha bullosa is a pneumatization pattern of what? Middle turbinate, right? Now here are all precellular, right? Postcellular, conchal, these are the pneumatization pattern of sphenoid. What percent of total airflow through nose passes through olfactory region? That is what? 5 to 10% only through olfactory region. Boundary of anterior nasal nerve are all except, right? Inferior turbinate, it is middle turbinate, no it is not, right? So the middle turbinate is the right answer. Lining of maxillary sinus is, what is the lining, right? These are what? Keratinizing or non-keratinizing? These are obviously what? These are not squamous epithelium, these are ciliated columnar, right? These are ciliated columnar. Sphenopalatine foramen is located at the end of which turbinate? Sphenopalatine foramen is located at the end of which turbinate? That is our middle turbinate, right? Middle turbinate, sphenopalatine foramen. The narrowest part of nasal cycle is, that is our nasal wall, right? Ethmoidal bulla is seen in where? Infundibulum, infundibulum bulla, where these are seen? Middle meatus. Infundibulum lies in between, where does it lies? It lies in between our what? Okay, lateral wall and uncinate process of what? Ethmoid. It lies in between what? Lateral wall and uncinate process of ethmoid. This is the region of where infundibulum lies, right? The Onidi cell refer to, what are Onidi cells? Refer to what? These are the posterior, right? These are the posterior group of ethmoidal cell which are in relation to what? Optic nerve, right? Posterior group of ethmoidal cells. The cause of choanal atresia is bucco-nasal membrane, persistent bucco-nasal membrane. The ventilation of sinus occurs during expiration, right? Ventilation occurs during expiration. Which turbinate is seen only in nasal endoscopy? We already said it, that is superior. Halar cells are present in, where are the halar cells present? We already said it, that is our roof of maxillary sinus. Roof of maxillary sinus or orbital floor, same thing, orbital floor. Lining of maxillary sinus is, we already said, ciliated columnar, right? The Onidi cell is in relation to, we already said, where? The Onidi cells are present, where these are present? These are present in relation to sphenoid sinus, right? Posterior group, that's why relation to sphenoid sinus. A child is normal while crying but develops cyanosis on breathlessness when being quiet. The most probability diagnosis is, that is choanal atresia, right? Sphenoethmoidal recess has opening of sphenoethmoidal recess, we know that is sphenoid sinus, right? Which sinus is last sinus to appear radiologically on X-ray? What is the last sinus to appear radiologically? Last, that is frontal sinus, last to develop. The valve of Eisner is what? That is the opener of nasolacrimal duct. Hiatus similaris is present in, where it is present? It is present, hiatus similaris is present in middle meatus, right? We know about it. The eustachian tube is located in, where it is eustachian tube is located? It is located posterior to what? Inferior turbinate, right? Inferior turbinate. Similarly, all of the following are true regarding maxillary sinus except, right? True regarding maxillary sinus except largest present sinus, yes. Common sinus involved in acute bacterial sinusitis, that is also right. Brain refer to lower premolar and molar teeth via trigeminal nerve. No, these are upper first molar and second molar. So, right, this is the not right answer, right? In maxillary sinusitis, pain is referred to what? Upper teeth, not to lower teeth, right? Open into middle meatus, that's right. So the here the answer is option number C. Rhino rhinomanometry is the measurement of nasal airflow and nasal air resistance. The Vidian knob is what? The Vidian knob is knob of pterygoid canal, right? Knob of pterygoid canal. Roof of a nasal cavity is formed by all except. It is formed by all except which is not formed by palatine process of maxilla. It is formed by sphenoid, cribriform plate, and frontal process also. But palatine process of maxilla, it is what? It is the bone of what? Lateral wall, right? Osteometal complex consists of the following except osteometal. Sphenoidal sinus opening, no. Frontal sinus opening, yes. Anterior sinus opening, yes. Maxillary sinus opening, yes. So the right answer is sphenoidal sinus opening. Right now, where does the given sinus drain into? Now the sinus, right? Here it is talking about maxillary sinus, right? Now obviously the sinus drain into what? It will drain, okay, where does the sinus? It is asking about, right? Okay, given sinus drain, it is asking about maxillary sinus only. It drains into what? Infundibulum, right? Infundibulum. That will eventually goes into middle meatus. The shaded area represent, it is the shaded area represent what? Obviously it represents what? Osteometal complex, right? Osteometal complex. Now further, the shaded area sky blue is lined by which epithelium? Now here it is talking about this. It is lined by which epithelium? That is olfactory epithelium, right? That is lined by, okay, olfactory epithelium, right? Okay, moving for the next question. The encircled area on the lateral wall of nose is a picture of, now here this is the picture of sphenopalatine foramen, right? It is a picture of sphenopalatine foramen. The marked structure on X-ray is, what is the marked structure right here? Now here the marked structure, what is the marked structure right here? It is sphenoid sinus, right? What is it? It is sphenoid sinus. Which paranasal sinus is last to completely develop? We already know. That is what? That is our frontal. Nerve not involved in olfaction while eating is, right? While eating, which is the nerve that is not involved in olfaction? That is hypoglossal nerve, right? It is pure motor nerve. So these are all about the MCQs from what? Our chapter congenital lesion, anatomy and physiology of nose, along with paranasal sinuses also.